We can start the live streaming, no problem at all, Shubham.
We are live now, sir.
Fantastic. Thank you very much. So, hi friends, this is Dr. Apoor Mehra, and I present Team Cerebellum Academy here. Gradually, over years, we just realized that we want to make a difference in the life of the medical students who are appearing for entrance exams in India. And what could have been better than we all like-minded people, more like brothers in life and friends together, sharing last 15 years journey of teaching and learning. The learning continues here. And what we realize is this particular time when people appear for an exam is a little tough one, a day prior, on the day, and then the day after the exam. The good part is that two parts are over, a day prior to the exam and the exam is over. The next part is what happened today, right? So this session is not about what happened today. This session is more about understanding the exam, that what happened in the exam and what's likely to happen in the future. So before I take on to some things here, I will like to welcome my younger brother and a phenomenal speaker, well connected to the students. What makes him the universe boss is that he's somebody who can relate to everybody. It's so easy to connect to him. And being a psychiatrist, he has an edge over all the other 18 faculties in communicating. He's supposed to communicate because that's his skill. And he's supposed to look beyond what people feel and finally give them a rational answer so that they can approach everything in their life. But right now, let's listen to him, how to take on this day when somebody has appeared for this exam. Over to Dr. Praveen Tripathi, sir.
Thank you, sir. Thank you. Good evening. In fact, good afternoon, students. I would not take much of your time. We want to start this recall session as soon as possible and talk about things while you are here. Guys, just 2 points I want to make that if you are one of those students whose exam went well, great, congratulations. But if you are one of those students who feels that the exam was simple, but still they could not do it, or they can identify the mistakes that they have made, it's not a bad sign. In my experience, whenever you come out of the exam saying that it was very simple, it's not usually a great sign. Those students sometimes struggle in the results. Students who find the exam a bit tough, but end up completing the examination, often they end up with better results. So even if you felt that the exam was a bit tough, and if you could identify your mistakes, that's a good sign. Now we know what to do next. So let's not get disheartened at all if the exam did not go according to your expectations. And whatever is asked in INI CET, of course, has a direct impact on the questions of NEET. Often the topics are similar. So let's take this examination as one of the stepping stones. If it did not go so well, and if it went well, I mean, nothing like that. I have got nothing to tell you. Chalo, let's start करते हैं इसको. ठीक है. Apoor sir, you want to start with the recall session?
I will start with the recall session, but few things which the students I could connect to were the exam was different this time, divided into 4 different parts, where they had given 50 questions each with 45 minutes for each. That is what they had done. So they had divided those 90 minutes into this part. And the first thing that the students were seeing was that they were finding it difficult to speed up or catch up with the timing in the first section of the paper, Dr. Praveen. This is what they say. Like they were trying to gear up. It's like the India-Australia match where we lost 3 wickets and suddenly then Kohli and Rahul had to build the innings. This is something that can happen because a new pattern comes suddenly. This is one.
Right.
Same thing, the questions were classically INI CET type. The topics were repeated, the questions were not. As you classically keep on saying, it is PYT that matters than the PYQs. Third, it was a balance of clinical and single liners, clinical more than single liners. The images and the graphs were throughout there. And it was not a skewed paper. It was from what classically, if a person prepares, keeps his mind cool, can do well. Easy and difficult, I don't know, because it is very difficult to predict, Dr. Praveen, because what I know is paper सबका अच्छा होता है, result सबका अच्छा नहीं आता. And जैसे जैसे एग्जाम से हम दूर जाते हैं हमें समझ आता है कि why the paper was difficult. It's not so simple.
Correct, sir. Correct.
Or regarding
So I mean, this paper, like all other paper, tells us the same thing. It's always going to be a combination. There would be questions which would be completely memory based. They would always come in the exam. There would be questions which would be conceptual. They would also come in the exam. So, and we have to take care of all the aspects. Let's start with the recall session, and then later on we can come up with a more elaborate analysis.
I'll just give you simple two questions which I have got till now.
Right.
The first question is about a 3-point bony relationship of elbow is maintained in. So 3 points that we say 90 degrees are medial epicondyle, the lateral epicondyle, and tip of olecranon. So these 3 points are not disturbed in something which is above these points. So if you have a head injury or you do anything else, so this is maintained in supracondylar fracture humerus. It's a classical question that came. And the second question that students have told me about orthopedics is the classification of calcaneal fractures, which is Sanders. So this is there. And I will be getting more questions in the due call, but what I would like to start is that there are teachers who are ready with their questions.
So मैं start करता हूँ sir. Let me start, है ना?
It is over to Dr. Praveen with psychiatry questions.
ठीक है. So okay, so let's start the session. I'll share my screen. Okay. मैं proper PPT बना के लाया हूँ, ऐसी बात नहीं है sir. All right. So I could find 5 questions from psychiatry, and I would really be thankful if you could correct me if I got anything wrong here. Chaliye. So the first question was this, and yesterday only day before yesterday when we were doing marathon INICET, I just said this thing that TCA toxicity is like one of the favorite topics for AIMS examiners, INICET examiners. It always comes. So the question was, the patient was started on amitriptyline. Just a second. Okay. All right. A patient was started on amitriptyline, which is a TCA, of course, and was found unconscious. Which of the following does not suggest TCA toxicity? Right. So again, the question is on what are the symptoms of TCA toxicity. Now we know that TCAs have got anticholinergic effect, and we know that TCAs also have got anti-adrenergic effect. So arrhythmias can happen, confusion can happen, pupillary dilatation, of course, can happen, anticholinergic impact. Hypothermia is rarely seen. What is more commonly seen is hyperthermia, right? TCAs have a negative impact on sweating. They prevent sweating, and that results in increase in temperature. So the answer was option C. Hyperthermia is seen. Hypothermia is not seen. चलिए. कुछ और भी था इसमें? No, this was not the question. Okay. So what was the question? But I think hypothermia was there. Were there any other options? Did I get any of the options wrong? I'm sure if pupillary dilatation was there, arrhythmia was there, and hypothermia was there. Was it confusion or nausea, vomiting? Okay, I think, okay, hypothermia was there now, so that's the answer. So the answer is option C. All right, this is very interesting because this question was asked by AIMS, I think somewhere in 2015. Much before INICET started. So they have repeated this question, but this repeat is from 9 years back. So basically they have talked about the stages of change. So all the terms that you're reading here, they are stages of change. Whenever you want to change any habit, and this applies more to the substance abuse, a person goes through certain stages. So the first stage is that of pre-contemplation. Now it's a very simple question if you just look at the terms. Pre-contemplation is before contemplation. The person has not even started thinking about any change. Contemplation is when the person has started thinking about changing a behavior. And then comes our preparation, action, and maintenance. So in preparation phase, the person decides that he has to change, starts preparing for it. In action stage, he takes the action, and maintenance phase, it maintains with the action. Now let's look at the statement. Contemplation. A person who smokes is thinking of quitting smoking. So the person has started thinking about quitting smoking. So is definitely contemplating. Statement 1 is correct. Pre-contemplation. A person is considering starting morning walks and its benefits to the health. Now, if the person has started considering the benefits of morning walk, it means he has gone into the stage of contemplation. He is already contemplating. So this is definitely not pre-contemplation. In pre-contemplation, patient would not even think. Maintenance phase, a person quit smoking 1 year back and has not smoked since then. This is correct. The person took the action and for 1 year he has not smoked, which means he is in maintenance phase. Statement 3 is also correct. Action phase, a person with obesity say he cannot do anything as it runs deep in the family. Now, this is a statement of pre-contemplation. He is not even thinking about making a change. So, statement 1 and 3 are correct. Option A is correct. Did I get anything wrong? Acha. Did I get anything wrong? Pre-contemplation definition was wrong, hence the answer. Pre-contemplation, it was the same. Reverse. First option, 2 option reverse. Sir, first was pre-contemplation. Acha. So you are saying ki this is what was given as pre-contemplation, and this one was given as contemplation. Is that what you are saying? अच्छा तो ठीक है अगर ठीक है अगर फर्स्ट और सेकंड स्टेटमेंट आई गॉट रिवर्स आई गॉट रॉन्ग तो भी यू अंडरस्टैंड द आंसर राइट चलो ठीक है इतना यू वुड नॉट बी एबल टू रिकॉल द जेस्ट ऑफ द क्वेश्चन रिमेन्स द सेम चलो आगे बढ़ते हैं ऑलराइट slightly tougher question and please let me know if I've gotten the language correct or not. Please let me know if the question and the options I've got correct or not. A pregnant female with bipolar disorder with previous history of 4 episodes and no episode for 1 year. Achha, in fact, most students are telling me that they said that a pregnant female in 3rd trimester. A pregnant female in her 3rd trimester, history of bipolar disorder, previous history of 4 episodes, no episode for 1 year, is controlled on lithium. Again, now in 3rd trimester, came to psychiatrist. What is the next step of management? I'm sorry about the language here. There are some typos. But was this the question? Question सही है ये? Lithium question I got correct? She was in 3rd trimester. ठीक है. क्या करोगे बताओ? क्या करोगे? हाँ, okay. So she was on 750 mg of lithium. So the only thing that you have to remember is at the time of delivery, in fact, in the 3rd trimester, during delivery and postpartum, the chances of lithium toxicity increases. The chances of lithium toxicity increases, right? So clinically and guidelines say we should not touch it unless we are monitoring the serum lithium levels and we find that levels are increasing. But that option was not given to us. So if you have to pick between these, increase the dose, decrease the dose, stop the drug and make the patient drug free, you cannot do that. There is a high chance of relapse in the postpartum period. And of course, you would never give valproate to a pregnant patient. So out of these 4 options, keeping in mind that she's in the 3rd trimester, I think the best answer is decrease the dose. We don't want that any toxicity happens. So our answer is decrease the dose. Best answer is decrease the dose. Patient does not have any complaints, that is okay. Still, you cannot stop the medication. You don't want to risk relapse. Decrease the dose is the best answer. आगे बढ़ें. Again, a classical INICET question. Classical INICET question asked repeatedly. Side effects of carbamazepine compared with oxcarbazepine. All of us know that carbamazepine causes all the side effects more frequently than oxcarbazepine, except for hyponatremia. Hyponatremia is more common with oxcarbazepine than carbamazepine. A classical repeat question. I hope all of you got it correct. है ना, ये GRJ सर ने अपने फार्मा क्लास में एग्जैक्ट लाइन पढ़ाई है, right? So please, I hope you got the answer correct. Again, a simple question. Which of the following mood stabilizers can cause hepatitis? Or I think it was hepatotoxicity rather than hepatitis. So again, lithium does not usually cause hepatitis or hepatotoxicity. Topiramate does not. Both valproate and carbamazepine can cause. Between them, if we have to choose, we usually go with valproate. ठीक है? Did I get anything wrong or did I miss any question? Because these were the 5 questions that I got. Anything I missed? Any other question which was in the exam and I did not cover? Hyperammonemia ऑप्शन में था. अच्छा ठीक है, उसको मैं कर लूंगा include. Anything else that I missed? Anything else that I missed? Were there any other questions apart from these 5? Lamotrigine option. ठीक है. चलो ठीक है. I think I'm done, sir. Apur sir.
Take Praveen. So I also have got my 5 questions.
हाँ तो आप करिए.
I mean, you have been lucky throughout. So while you were doing it, the students have put all the questions on our official Cerebellum Telegram channel, and I will like to thank the students for helping me out with that. So again, the same thing. The first one, what I discussed, is 3-point relationship. The second question was Hawkins classification is used for. So the answer was fracture of talus. The third is a classical image, which I am very sure Dr. Zainab will be discussing soon, is about the structure being marked on MRI about posterior cruciate ligament. So that's what they very commonly ask. Sometimes they mark ACL, sometimes they mark PCL. The fourth question was an extension of a previous question of INICET, where they had asked about the fibular neck fractures causing foot drop. So they asked you what gait is there. So when you have a foot drop, so you want to lift your leg up, it's called as a high stepping gait. So this is what they asked. And the last one is the commonest lesion of a shoulder dislocation, the Bankart lesion. So that's an anterior part going to the anteroinferior part of the glenoid labrum. So these are the 5 questions, and I'm sure as the day goes on, I'll get some more. And I will be making a presentation like Dr. Praveen has done. He is the first one, and he is always going to do it very systematic. That's why he's called as the universe boss. I don't know how he finds.
Sir, just एक चीज, ये was there a question on IV drug for Alzheimer's disease?
Okay, so that's in the chat.
Was there a question on this IV drug for Alzheimer's? सर बस 1 मिनट दे दो सर, मुझे इसमें मिल जाए ना तो मैं इसको ऐड कर लूंगा.
आपका 1 मिनट मुझे एक और क्वेश्चन देगा प्रवीण, ऐसा नहीं है. मैं कह रहा हूँ ऐसे थोड़ा किस्मत.
आप पीपीटी बना के लाइए अच्छे से, ऐसे काम ही चलेगा. ऐसे
मेरा
बता दो
वेलकम करना आप लोगों को.
IV drug, चलो ठीक है, मैं देखता हूँ इसको. ठीक है सर, मैं अपनी स्क्रीन शेयर.
They had asked the classical question of rheumatoid arthritis, where they had asked about morning stiffness, small joint pain and tenderness, where they had just asked the definition and the answer was rheumatoid arthritis. So that was the 6th question. All right. So we have Dr. Zainab here right now. Has she joined?
Zainab is here. I think Zainab is joined.
All right. So we will like to welcome Dr. Zainab now. Yes. And so Zainab, as we were discussing, Dr. Praveen has already welcomed the students. A quick word about the paper that you got from the students, and then I think you can take over with the radiology questions.
Yeah, I think the AIMS paper always brings mixed feelings as far as the immediate feeling goes. And then as the days pass, the perception kind of changes. So that's how AIMS paper usually evolve. So immediately it's a normal tendency that all of us have as students, is that we remember the difficult questions more. The easier questions are what we forget. When they come up in the recall, it's when like, oh, acha, ye question bhi tha. Our mind tends to play these games wherein we remember that the paper was difficult. You remember the difficult questions more. So that's what happens. So what I want to tell the students is, right now, don't just be biased by the feeling that you have immediately. It's gonna evolve. And what I will advise is, if you're feeling overwhelmed, if you're feeling that, it is not something I've not done well, just take a day off, just take a day off and relax, and don't don't let your feelings get the better of you. Today is the time when you just pat yourself on the back. You've done a good job. You've cleared one exam is over. So now just take the day off and relax if you're feeling overwhelmed. So again, there is something where, you know, we go through a dabda stage. I'm sure Praveen sir will teach you that better, but there is going to be denial. There is going to be anger that you might take out on people, or you might take out on institutes. So all of these phases will come, and eventually we'll reach a stage of acceptance. And hopefully we'll learn from there. You know, that is when the learning happens, that, okay, this is where probably I went wrong. This is where I could have done better. So that is my, you know, message to all of you, that just let the dabda pass. Eventually you'll reach acceptance, and hopefully you will be able to, you know, learn from whatever this exam was. And that's what we are also trying to do here. With the immediate recall, our aim is again to, you know, analyze how the paper is. And this is what we are doing for the juniors, more than the people who have given the exam. The whole point of doing this recall is so that we can analyze the trend, how the pattern is evolving, and help the juniors. So that is one thing. And as far as the new pattern was there, wherein they gave you 4 blocks, I think most of the students adjusted well. The first block, I think, was time consuming for a lot of you, but overall I think you guys coped up well, and it was not something which came as a very harsh change. So that is the one takeaway that was there. Now coming to radiology, so very quickly, I don't want to take up a lot of time. So I got 4 radiology questions. Most of them were allied questions, you know, from different clinical branches. So let me just share my screen. Is the screen visible, sir?
Yeah, it's visible.
Yeah, so these were the questions which I got. So this one is an allied ortho question, which sir was just talking about. So this was an image which was labeled on the MRI, and they had asked you what this structure is. So anytime you see that a ligament is crossing, you know, it's crossing from the femur to the tibia, it's a cruciate ligament. That is how it is named. The name cruciate means it's a cruciate. It's crossing over the 2 bones. So you can see how it's starting from the anterior part of the femur and coming on the posterior part of the tibia. So this is how the cruciates are labeled, whether it's inserting on tibia posterior part or it's inserting on tibia anterior part. Hence, here, this ligament which is marked in this image is the PCL. PCL means posterior cruciate ligament. I hope this is the image which came. This is something that, you know, the same image we'd done in BTR. So this is the image I had with me. So I don't know if this was the similar image which came in the exam, but it was a posterior cruciate ligament which was marked, right? A lot of you are saying anterior cruciate ligament. No, if this was the image where it's going behind, it is a PCL. Okay, so 2, I think we can rule out. It is not a collateral, it is not a menisci. So 2 we can clearly rule out. If this was the image, it is PCL. Okay, so the learning point here is you see the insertion on the tibia, right? Okay, next. The next question here is about, this is the one question which I think most students remembered. And when the recall started, everybody was remembering this question first and the East India Company question. These were the 2 takeaways. And I was like, खाली दो सवाल का पेपर था क्या? Everywhere, every group, these were the 2 questions that you guys started discussing. So this is something that we have actually seen, you know. So a child was playing alone and is found to be drooling and choking. So X-ray was shown, and at this point, I think all of you were feeling very happy when you were reading that, yeah, it's foreign body, it's in the esophagus. But then when you looked at the option, it was like, oh, but they're not asking me that. They're asking me what is the foreign body which is ingested. So I think they gave you this AP view and they gave you a lateral view both. So it is pretty clear from both of them that it's in the esophagus. I think nobody has any doubt, because you can see the N face on the frontal and you can see how clearly it's behind the trachea, right? Now the question is it a coin or is it a button battery? Those were your 2 main differentials, and this is something which exactly we have discussed in radiology. So when you see this beveled margin, do you see in this image how the center part is lighter than the periphery? Yeah, so this is known as a beveled margin. When you see this, it means that it's not a flat coin, it's a button battery. If you have ever seen a button battery from any toy, you know, you will see how the center part is a bit more depressed. So that is why it gives you this differential sort of density, and that is the feature of it being button battery. And you know why even if this was not the image, why the chances are that it would be a button battery that they have asked you is because it is clinically very important for you all as residents and as interns to diagnose a button battery out of all of these: coin, metallic ball, cap of cold drink. This is the most clinically significant because it causes tissue necrosis. This is the one which needs to be removed immediately. So even if you would have told me ki ma'am image pata hi nahi, image yaad hi nahi hai, I would still have put my bets on button battery being asked because this is the one which is clinically relevant. It's not a metallic cap. A metallic cap will not have center density only. Na, imagine cap kaisa hoga? A cap will have center part, so it will just have the margins which are seen. In that case, this part won't be that dark. You will see a very, very lucent center. Are you getting it? I don't have that image, but when I do a formal recall, I'll show you all of these images, how these all look. But this is not what a cap will look like. It'll only have the periphery white, if you understand what I mean. So this is what it was. Okay, so it is a button battery because of the beveled margins. Then this was a slightly tricky question. So they have asked you what is the investigation of choice for PTH adenoma. So here, I'm sure all of you knew sestamebe. It's a question which has come a lot of times. So this is where, when we say PYQ nahi aaye, PYQ aaye, PYQs directly kabhi nahi aayenge. This is what they'll do to PYQs. They will take you till the point that you know, and then they're going to twist it from there. So this is what happens through the ages. This is how questions evolve. They'll take you till sestamebe. You will be very happy, and then you'll be like, oh, but is it technetium? Is it SPECT? So here, just the basic knowledge of radiotherapy that we have learned. Again, in radiology, we have learned this, that when I say technetium, it's a scintigraphy. It's a two-dimensional study. When I say SPECT, it is CT. The name itself tells you the answer. The name is CT. So now when I ask you a question, guys, कि बताओ, X-ray और CT में से क्या prefer करोगे? एक two-dimensional है, which is technetium. एक three-dimensional है, which is SPECT. Which is the one which you will prefer? You will all say CT. So this is what it is. SPECT is nothing but the CT of nuclear medicine. Yeah. So SPECT is the better answer here. It is sestamebe SPECT, which is always going to be better. In fact, the image that we've seen in our classes is of a SPECT, so you can go back and see it's sestamebe SPECT, which is going to be better. All right. Option had MRI. So instead of ultrasound or CT, the option was MRI. Still, MRI is not going to be a correct answer. If that was the option, you can rule it out. You can rule that out. Agar sestamebe SPECT likha tha, it's the best. Agar sirf SPECT likha tha, still we have to presume it's a sestamebe SPECT and we have to answer. ठीक है? I hope that is fine. Regarding localization, फिर भी, yeah, we are talking about localization only. So for PTH adenoma, it's localization. That's why radiology is being done. So localization ही सवाल आता है. Best for localization, sestamebe SPECT. अगर आप कह रहे हो कि मैम SPECT ऑप्शन ही नहीं था, it was technetium sestamebe, it was MRI, ultrasound, CT. In that case, better answer will be obviously technetium sestamebe. Are you understanding? So bottom line, so काफी mixed feedback here. So अगर SPECT option में था, better answer. If SPECT was not there, then we go for technetium. Then there's no controversy. Then it's a 1-minute discussion, right? So yes, localization only. I think all of you are saying, ma'am, it was localization, not investigation of choice. Same answer. Nothing changes. Okay, right? Okay. Then again, this was a difficult question in my opinion, because for this you need to understand how we define cellulitis in the orbit, So this was a difficult question. So 35-year-old male presented with URTI and orbital pain. What is the likely diagnosis? So just tell me if this is how the image was. I was just talking to the students on the group and this is the feedback I got कि ऐसा image था. तो देखो जरा ये image, was it something like this? So what you see here is the right ethmoidal sinus, which is opacified. So sinusitis is definitely there and all the options have that. So that's not something where I have a doubt. Now, what is this? So when it is protruding inside the orbit, is it orbital cellulitis? Is it preseptal cellulitis? Is it subperiosteal abscess? And fourth option, I don't know. So it probably will be sinusitis with something in the orbit. But we already have an answer from one of these three. So whatever D was is probably wrong. For this, I want to show you this image here. This is the classification Chandler's classification, don't need to know the name, that we follow for orbital complications of sinusitis. Okay, so look at this. If there is opacification in front of the globe, that is called as preseptal. Can I see that here in front of globe? No, it is not going in front of the globe. So can I rule out preseptal? Yes. Orbital is the most fulminant complication, which will go everywhere. Ye dekho, everywhere the abscess is going, all around. Is it going all around? No, it's not going all around. Here you can see black fat preserved. Here you can see black fat preserved. I can rule A out. Look at subperiosteal. So subperiosteal abscess is the one which bulges out into the orbit like this. Does it look similar? Oh yes, it looks similar. So you can see how just the periosteum is bulging. So the correct answer here is going to be C. Okay, only sinusitis was fourth option. Perfect. So that is clearly not the case. There is definitely a complication in the orbit. So now, do I have all of your agreement that yes, ma'am, you have proved that it is subperiosteal abscess? So this is what will be the answer: sinusitis with subperiosteal abscess here. Okay, so this, if you have gotten right, you will have a boost in your rank. But if you get this wrong, your rank will not go back drastically, you know. So this is one of the 60 questions. If you know our classification of questions, this will be one of the 60 questions, which is good to get right. All right, so this is how the radio questions were. So more or less allied questions only, no direct radiology questions from core general radio per se. And that is how the trend has been, you know. So anything else? If you
दिखाना है ना first question का image.
हाँ sir.
देखो इसमें क्या है, why students are confusing between ACL and PCL? That's very commonly asked to me in the questions also. The sagittal view, when you look at the femur, ACL and PCL both, they almost look starting from the posterior part. You have to look at the tibia where they are going.
Yeah.
If you look at the tibia, you will never make a mistake. The most posterior structure on the tibia is PCL. If you remember that mnemonic from anatomy, Medical College, Lucknow Medical College, the C at the end is PCL. All right. So because people do confuse this because they look almost the same on femur, but if you look at the tibia, it's easier to pick up. This is what I wanted to put into. That's all.
Yes, sir. If yeah, maybe later on I can show them ACL also. If you want, I can show you ACL right now only. Is my screen still getting shared?
It's good. We can see that. Yeah.
Yeah. Oh, where did it go? So this is how ACL will appear. So this is where it will insert anterior.
Perfect.
So that's it, sir, for radio.
Thank you very much. While I was looking at the chat when you were discussing, there are two more questions that I could find from ortho. One is a classical glass holding cast. I always tell them that party का पहला glass, Spurs sir will know that पहला glass हमेशा सीधा ही होता है, फिर तो wrist drop हो जाता है. So the first part is glass holding cast for scaphoid. And then they had one question on Kainbach, the osteochondritis of lunate. So these are the things, you know, these are those single liners that we talk about. They keep on coming. So these are simple things that keep on coming, you know. Now they appear simple. उस टाइम पे क्या करके आए हैं वो बहुत फर्क होता है. So over to you. Next is Dr. Sparsh taking up the class.
हाँ जी sir. I hope I'm properly audible and visible, sir.
You are beautifully visible.
Thank you so much.
The best voice we hear in Cerebellum.
Thank you for introduction with the glass, sir. Thank you so much. And I hope everybody has done really well. We appreciate the kind messages that you are sharing with respect to the benefit that each one of you got from the BTR offline, online sessions, as well as from the mission classes. I think the teachers are going to be equally motivated and would still work harder to make the classes even more relevant. Now, I don't have any screen access to share with you, but then the kind of questions that I got range anywhere between 12 to 15 questions. Let us just have a recap with respect to the questions. So first classical question was pertaining to the gene involved in the different types of malignancies that are seen in the individuals. So we had the presence of ALK, KRAS, JAK2 and KIT. I hope these were the different genes which were mentioned in the exam. And then you were supposed to match them with the respective malignancies. Right. So the easy one initially, the JAK2, most of you understand, is going to be associated with myeloproliferative disorder. I hope there was no doubt to that. The second one happened to be KIT. KIT is associated with GIST. So we had a discussion about that particular thing as well. For future reference, of course, you are familiar that it can also be associated with something like mastocytosis. When we are talking about RAS, now KRAS and ALK, they were two options which some people confuse in the exam because you had two other options which were lung adenocarcinoma as well as pancreatic carcinoma. Now all of you know that अगर आपको पता ही है कि KRAS जो है वो दोनों के साथ हो सकता है तो look at the other option. No, ALK अगर हो सकता है तो आप ध्यान रखेंगे KRAS is going to be going with pancreatic carcinoma, and of course ALK, we talked about that fact, associated with something like adenocarcinoma of the lung, right? So that was the first question. Second one was a question pertaining to the different type of inheritance disorders, wherein they made a mention of autosomal dominant, autosomal recessive, X-linked recessive, and mitochondrial inheritance. ये चार options थे, and you were supposed to match them with different disorders. So I'll just talk about the answers quickly. No, there's nothing I have to share with the screen here. I just have those questions. We'll be going out with a formal discussion of the questions. Please don't worry on that. We had myotonic dystrophy. So myotonic dystrophy, all of you understand, you know, the CTG thing, and autosomal dominant in nature. Cystic fibrosis, of course, a separate question in the exam as well, at chloride channel defect, that is autosomal recessive. Duchene's muscular dystrophy is going to be X-linked recessive. And then we had Leber's optic neuropathy, which is going to be having the presence of mitochondrial inheritance, right? So I hope there was no doubt to those questions. A third question was a repeat question with respect to the COVID-19 situation where the person had suffered from a COVID-19 infection and then he was given high dose steroids. And this person came back to you because of the complaint of a nasal obstruction. Perhaps an image was given, which was very much resembling, had the presence of the image of a mucor because of the presence of obtuse, angled hyphae. And then you were having the presence of the question asked you about making a diagnosis. So I hope you could make a diagnosis of something like mucormycosis. Then we had a question that we had, which was a repeat question, wherein the question talked about IgM and IgD being produced simultaneously because of what kind of a mechanism. So this was a previous INI question, which was explained on the basis of the alternate RNA splicing. Yeah. So that was another one. Another question in the exam, I was not able to get the complete history, but then elderly gentleman, 60-year-old guy who was having a complaint of weakness. And he was having the presence of a hemoglobin less than 10 gram per percent, and the MCV value was given to be 110. I don't know for what strange reason the options given in the exam were, as I was told, thalassemia, IDA, and one of the easy options in the exam was megaloblastic anemia. There is no PPT here, please don't worry on that. You will be having a formal discussion. Abhi aapne sirf questions recall karne hain, or just be happy about the ones that you got correct. And just try to give me some input in case you find that there was additional information given pertaining to a question. Then the question did make a mention of the patient having the presence of a reduced transferrin saturation. Yeah, so reduced transferrin saturation, which was associated with the presence of different options given in the exam were megaloblastic anemia, hemochromatosis. One option was iron deficiency anemia as well, and the fourth option was not given. Okay, so history of. So vegan diet and so vegan diet is going to be associated with HER2 की भी बात करता हूँ यार, अभी बात करता हूँ भी, ये मेगलोब्लास्टिक एनीमिया वाला क्वेश्चन जो है इसमें था ये. Okay, vegan diet was also there. So I think that was again a repeat and an easy one. Vegan diet, MCV value 110 हो गया, elderly patient, hemoglobin less than 10, so megaloblastic हो गया. And transferrin saturation reduced obviously is classically associated with iron deficiency anemia, so nothing to worry on that as well. One question which was apparently a good question was pertaining to sickle cell anemia, in which they asked you about the concept of erythrocyte mechanical fragility and erythrocyte osmotic fragility. So we had a discussion so many times earlier that sickle cell disease के अंदर osmotic fragility तो low हो ही जाता है, as most of us understand, but then you are going to be having cells which are going to get stuck up and they are going to get broken down. So logically speaking, their cells are mechanically fragile. So mechanical fragility is increased, and hemosidrosis, hemochromatosis, दोनों option के अंदर. Okay, that's a bit unusual usually, but ठीक है अगर आप कह रहे हैं तो. Mechanical fragility high हो जाता है because of which hemolysis takes place, and then osmotic fragility obviously is going to be low. Please remember that. Right. The next question which was given in the exam was what we had talked about in the Mission NEET PG class as well. Remember when we talked about the different subtypes of necrosis over there, we did make a mention of the tombstone appearance, and I, by sheer chance, I shared with you the difference between the pemphigus vulgaris and the bullous pemphigoid. I think a similar question was given in the exam where a histopathological image of a supraablasal blister was given, and then they asked you to make a diagnosis. Pemphigus vulgaris was the answer, of course. Yeah, that is what you need to remember over here. Then One question which was incomplete in the sense was that nephrotic syndrome patient was there and which kind of a band was seen. If I'm able to understand the question correctly, presuming that the question was having the presence of the protein electrophoresis pattern. So we have talked about the different patterns earlier. And in this situation, you're going to be having an increased value of serum fibrinogen. The albumin levels are expected to be lower, right? Then the next question was, what confused a lot of people was an image-based question on vacutainer, wherein the question made a mention of the fact that you had a vacutainer which was given as an image, and the question did make a mention of the fact that the vacutainer is being used for blood glucose estimation, and they asked you to name the anticoagulant over there. Now I don't know whether it was because of a image problem over there or some kind of an issue. Most of the people said that the color of the vacutainer that was shown was having the presence of a light blue top. Normally, obviously, most of us understand that if you are talking about glucose estimation, you would be using a gray top vacutainer. But since the question very clearly made a mention कि vacutainer को हम use कर रहे हैं for glucose estimation, so I believe you can understand that it would be having the presence of sodium fluoride. Now the question was tricky because उन्होंने ये नहीं पूछा कि why this particular vacutainer is being used. So it was not about the use of sodium fluoride because that is going to obviously inhibit glycolysis, but anticoagulant पूछा था उसने. तो इसके अंदर जो anticoagulant होता है वो आपने याद रखना है, that is potassium oxalate, right? So vacutainer for glucose estimation contains potassium oxalate, which functions as an anticoagulant. Of course, it contains sodium fluoride as well, which is going to be useful because it is going to inhibit the metabolic pathway, and therefore the value of blood glucose is not going to get altered. One question which was incomplete, which I got was the patient was having a presence of hepatitis, and this patient was having the presence of only and only anti-HBC. The options which were recalled were: is the patient having a history of being immunized? Is a patient is an inactive carrier? Is a patient having complete recovery? And fourth option as some people, I could not confirm it, but only few people did make a mention of the fact that patient is having the presence of a recovery from an acute infection. So to that extent, I believe the last option would be the most appropriate one. Then another question in the exam that was asked was about the features associated with a patient having breast cancer, and this patient was having the presence of a luminal A subtype of breast cancer. Understandably, we understand this patient is going to be having the expression of the estrogen receptor with a low proliferative rate, right? That is what we need to be remembering. Okay, window period was also there, so I might as well just add it. Just give me a minute to add that information. Won't take too much of a time, right? So that a better recall is obviously going to be planned that ways, right? Another question talked about the presence of markers for seminoma. So we had the mention of OCT 3 and 4. As we understand, KIT is there, PLAP is there. So all those markers were there. हाँ यार, लाइट ब्लू वाला कंटेनर था लेकिन ब्लड ग्लूकोज एस्टिमेशन था ना, तो ब्लड ग्लूकोज एस्टिमेशन पे हम जाएंगे, तो साइट्रेट नहीं मार्क करना था, मतलब दैट्स माय पॉइंट. Then we had a question on the concept of super antigen, wherein they did make a mention of presentation of an antigen by the APC to the cell, and this was associated with I don't know, some people said yes, there was a history of release of cytokines, some people said there was just an image. But if you could have the presence of an antigen remaining outside the standard cleft, not present in the antigen binding cleft, and then causing activation of the cell associated with the release of cytokines, of course, then that would be associated with a super antigen. And obviously two classical examples that we always talk about, that is the toxic shock syndrome toxin 1 and the streptococcal antigen. I believe streptococcal super antigen was what was given as a question in the exam. Okay, ji. Then we had a question, appear to be too simple a question for an INI, but then which of the following is going to be having an autosomal dominant inheritance? And the question made a mention of deficiency of factor 9, factor 10, factor 11, and von Willebrand factor. If that was a question, then please just be familiar with the fact, of course, that's going to be a von Willebrand factor that is going to be seen. Ringcase crystals was that also a question in the exam? No, nobody talked about that. In fact, that is going to be in addition to the questions. And perhaps then we had a question which a lot of people are not able to recall correctly. Some question related with pap smear, I believe, right? So pap smear, and then they gave you the presence of dark blue colored cells. I don't know what exactly was the question over here. So if you can just possibly help me recall that. So Ringcase crystals was there. Okay, so we can just get to know what exactly was Ringcase crystal. I mean, was there an image of Ringcase crystal and they asked you to identify it, or they asked you to identify the kind of tumor you would associate it with? Then couple of questions not related with the path as such, but then there were repeat questions with respect to the risk factors for development of carcinoma of the gallbladder, and a question about how to draw the blood sample in case of an individual suffering from infective endocarditis. right? So those were the questions I could recall, hoping for better recall and hoping for more information coming as the day progresses. And therefore, we are going to be having a discussion of these questions in the, I would say, a more formal manner, right? So since the next faculty is supposed to have a live session as well for the FMGs, I would just straight away pass on the baton to Dr. Rena Chawla ma'am, who's going to be discussing the OBG questions with you. Please discuss any options, any inputs from your side in the Telegram group so that we can perhaps frame better questions for you, right? Stay calm. All the very best. Thank you so much.
Thank you so much, sir. Hi, everybody. I hope you can hear me and see me. I'm also on the chat. So I would also like your help in getting the recalls. So Gynae was a little okay. I think I got 15 or 16 questions. So INI likes asking one cancer particularly. Last time it was all about cervical cancer. The year before that was all about vulval cancer. This year was all about ovarian cancer, right? So in ovarian cancer, the first question that I got is a 65-year-old woman with epithelial ovarian cancer with peritoneal metastasis and ascites. So what is the management? Okay, and here the answer would be, so whenever we have ovarian cancer, the treatment is always debulking. It is always surgical followed by chemotherapy. And if it's epithelial ovarian cancer, we always give carboplatin or cisplatin with paclitaxel. Okay, so radiotherapy doesn't have a role in ovarian cancer. And neoadjuvant, this would have been neoadjuvant if this was an option. This is an option in inoperable cancers. Nowhere is it mentioned that this is inoperable. If it was inoperable, they would have mentioned a frozen pelvis. Okay, so staging laparotomy followed by chemotherapy is the treatment of choice for this question. If there are any changes, any additions, please fill in the blanks. Okay, radiotherapy was not an option, somebody is saying, or mental caking was given. All right, but I don't think it would change the answer. Okay, next question is, which of the following has a risk of progression to borderline ovarian tumor? So borderline ovarian tumor is basically a tumor which is not malignant, but it is very near malignancy. Okay, if you put it that way. And the question asked was, which has a risk of progression to borderline ovarian tumor? So it's somewhere in between benign and malignant. Now, the answer to this is, so borderline ovarian tumor, whenever there is high estrogen exposure, okay, this becomes a risk factor for borderline ovarian tumors. Okay, and the answer here would be polycystic ovarian syndrome, I think, because I don't know if it was risk, no, which of the following is not a risk or it has a high risk. I'm not sure. Okay, it was they're asking which is not a risk. Okay, that makes it easier. If it's not a risk, then the answer should be multiparity, because multiparity is protective. Okay, so nulliparity was an option or multiparity was an option? Okay, it was low parity. Sorry, so this will change to low parity. Basically, whenever there is high estrogen exposure, that increases the risk of borderline ovarian tumors. So low parity will increase the risk. PCOS will increase the risk because PCOS has high estrogen. Okay, OC pills, remember, are protective for ovarian cancer. Okay, so what was the question? It was increases the risk, then the answer should be, the best of the answers would be low parity. If the question was increases the risk amongst PCOS and low parity should be the option. Okay. Next question is what pathology or you were just discussing. This was the question. I think there was a clinical scenario with an image and it was mentioned that there is Rinke's crystals. So this would be a Sertoli Leydig cell tumor. Okay. So it was increase the risk. Okay, fine. All right, let's go to the next question. I will, as I said, we are all going to come up with a formal discussion later on once we get the proper question. Okay, and Rinke's crystal was a question. The question was which tumor is associated with Rinke's crystal. It was an image-based question also. Okay. Then there's another question of ovarian tumor. The fourth question was virilizing ovarian tumor is. I don't know the other options. We had theca cell tumor, we had arenoblastomoma, and the answer is arenoblastomoma. Arenoblastomoma is a testosterone producing ovarian tumor. Okay, so this is why this would be the correct answer. If you have the other options, do let me know. Okay. Okay, I got it. It was high risk. What was asked was high risk. Fine. Okay. Then HPV vaccine is always asked. This is again part of pathology or gynae. Okay, it's a very commonly asked question. A lot of research also going on in AIIMS on the HPV vaccine. And that's why it was asked. This is also a previous year repeat question. So the answer is the L1 capsid protein. Okay. So this is a previous year direct repeat question. Okay. Next question. Okay, Brenner's and carcinoid were the other two options of the visualizing tumor. Okay, next question. A 13-year-old girl with abdominal pain diagnosed as 12 weeks pregnancy. What is the next best step? So if a patient comes and she's less than the age of 18 years old and she's pregnant, the immediate next step is going to inform the police and file a MLC. Okay, so that's the next best step because this becomes under the POCSO Act. You have to file a police information if you're getting a minor girl who is pregnant. Okay, so that will be the next best option. And then you move on to the other things. But the next best step, if it's asked, you have to inform the police and file an MLC. Okay. Okay, it was 8 weeks, not 12 weeks. Okay, anything else? She refused examination. Okay, she refused examination. But whatever the case, you will inform the police. Was this a question? Was this an option? Okay. Why does the blood volume increase by the time a woman reaches term pregnancy? Was this a question? Okay, because there was a little doubt in the options here. Okay, so here the answer would be, so whenever there is the blood volume does increase in pregnancy, and that's because of stimulation of the renin, angiotensin, aldosterone system, and also because of increased estrogen. Okay, so the best answer would be D option if these were the correct options. All right. Moving on. So there were a few clinical obstetric scenarios. One was on uterine inversion, one was on cord presentation. On uterine inversion with placenta still attached, okay, what would you do? So if the placenta is still attached, you're not supposed to take the placenta out or separate the placenta. You're supposed to first invert the uterus, first reposition the uterus and then do a MRP. So the best option is put the uterus inside without removing the placenta and then do a manual removal of the placenta. This is the golden rule for uterine inversion. Okay, but if the placenta, many times we come with the placenta already separated, then you have to reposition the uterus. Okay, so always reposition the uterus with the placenta in situ if the placenta is still there. Okay. Then there's another question on in obstetrics, woman in labor, cervix is 70% effaced, 3 centimeters dilated, and bag of worms felt. Now, even if you don't know what bag of worms is, okay, what would you do? Even if you don't know what bag of worms is, bag of worms would be what? It's basically the membranes which are intact, okay, and you're feeling worms through it. So this is nothing but the umbilical cord. So this is a case of cord presentation. That means prolapse hasn't happened, but you can feel the cord there. So what should you not do? You should never ever rupture the membrane, because if you're going to rupture the membranes, the cords are going to prolapse out. So you will immediately do an emergency LSCS for any patient with cord presentation. Okay. Then there was a question of missing DMPA. So a patient has been taking DMPA. What is DMPA? It is Antara dipomedroxyprogesterone acetate. What is the next step in this? Okay, so whenever a patient comes with, what is the schedule of giving DMPA? We give it every 3 months. If the woman has missed the DMPA, even by up to a month, okay, these are the Government of India guidelines. So if she comes 2 weeks earlier for her injection, up till 4 weeks later, nothing needs to be done. You just give the next dose without any backup, without any UPT needing to be done, but you counsel her that she needs to come on time. So DMPA is notorious for delayed return to fertility. That's why you don't have to be so worried, even if she misses her injection for up to a month. But if she goes beyond that, more than 4 months, then you have to do a UPT, then you have to use a backup method and counsel her to come on time. Okay, so this was the correct option. Give DMPA. You don't have to do a UPT. You don't have to give a backup period. Okay. Okay, next question. A pregnant woman at 30 weeks with painful vaginal bleeding. So whenever there's painful vaginal bleeding, you have to think of abruption. There were many clues given here for abruption. Okay, there were reduced fetal movements, fetal heart absent, hypertension. Hypertension is always associated with abruption, not placenta previa. The tone is increased, the uterine size is increased, so more of concealed abruption. And she's in labor. She's already 3 centimeter with the intact membranes. So what should you do? The baby is dead. You will just want to expedite delivery as fast as possible. So you will do an artificial rupture of membranes. Her blood pressure is high, so you can start antihypertensives. But basically, our aim is to expedite delivery, okay, by doing an artificial rupture of membranes. Anything else in this question? Urine albumin 2+ confirms she's preeclampsia. Preeclampsia is associated with abruption, and if it's abruption with preeclampsia, you have to expedite delivery. Last option was hypertensives, antihypertensives with tocolysis. All right. Okay, that was the last option. But the answer here would be an ARM. If the baby was alive, probably an LSCS would have been a better option, okay, because she's far from delivery. Okay. Yeah, no fetal heart I have mentioned. A fetal heart is absent. Okay. Next question, 39-year-old Gravida, this was Gravida 6, I think. G6, P3, A3, right? G6, P3, A3 with previous 3 LSCS with PS. What is PS? Can anyone tell me? The full form was not given. What is PS? It is placenta accreta or accrete syndromes. Yeah, I'm reading the chat. No FHS. I know, I saw there's no FHS in the previous question. Okay, previous 2 or previous 3 with placenta accrete syndromes. Okay, placenta accrete syndromes is PS. And what does that mean? She's at increased risk of several things. Okay, because of her multiple cesareans, she's increased risk of bladder injury. Also because PS, placenta accreta can go into the bladder. She's also at increased risk of bowel injury, okay? And she's also at increased risk of excessive bleeding because of placenta accreta, okay? So which will you not counsel was the option, right? Anything else? Okay. The question was having eclampsia in the previous question. Even if she's having eclampsia, it doesn't matter. You will do an ARM. Eclampsia is not an indication for a cesarean section. You will do an ARM and expedite delivery. Okay. Placenta accreta. Yeah. So, yeah, FHS is not heard means the baby is dead. So still it won't change. You will do expedite delivery and take the baby out. That's why you won't do a cesarean. Okay, so here, what was the 4th option? Was it PPCM or was it something else? Risk of blood transfusion. Okay, so basically this is placenta accreta with multiple cesareans, previous 2 or 3 doesn't matter. You will tell her there's increased risk of bladder injury, bowel injury, blood loss, risk of hysterectomy is also there. Okay, this is peripartum hysterectomy. This is not PPCM. Hysterectomy was the 4th option. Peripartum hysterectomy was one of the options. Okay. Okay. So in placenta accreta syndromes, you do explain that there will be a risk of hysterectomy. In fact, that is the treatment. You will do a hysterectomy. There is increased risk of bladder injury. There's increased risk of bleeding. Okay. So it's not PPCM. Got it. Got it. Okay. But what was the 4th option? Was there bowel injury? So risk of bowel injury would be more appropriate than in this scenario. Okay, so bladder injury ka risk hai, hysterectomy you will anyway do, excessive bleeding will be there, blood transfusion will be required, bowel injury would probably be the right answer. Okay, which infection won't be acquired in pregnancy, will not be teratogenic? Okay, so here we all know rubella, CMV, varicella, all of them are teratogenic. Okay, so the answer here would be HSV. HSV, the risk of transmission is in the intrapartum period because of the lesions on the genital area. Okay, so intrapartum transmission is highest with HSV. Rubella, CMV, and varicella are teratogenic. They cause congenital fetal syndromes. Okay. So this was another pathology question. I'm not sure what the question is. As Dr. Sparsh was also saying, we're not sure what the question is. Was this the image shown? And was it asked what the stain is? Okay, so this is the Papin-Collo stain. If this is what was asked, the stain used in pap smear. But please let me know what the question was. Okay, we won't spend time on this. We'll move on. There was a clinical scenario on PCOS, a young girl with hirsutism with a high BMI with a diabetic mother. Okay, what is not an option? Okay, was it, you'll obviously counsel her about lifestyle. You'll always tell her that she's at risk of metabolic syndrome. Okay, but amongst these two, what would be a better option? If hirsutism was given, you will give her an OCP. In fact, what we do is give an OCP which contains an anti-androgen as the progesterone part. So simply an OCP would probably be the answer here. Okay. Okay, so let's go to the next question. Let's leave the pap smear question. That is more from the pathology part. Why is it not toluid in blue? I think it is more from pathology than gynae. Okay. Okay, right. Ferryman score was given in this. Ferryman score was 6. Was it what is not an option or what is the next best option? Okay, OCPs is usually given if she has delayed cycles. Otherwise, we don't usually give OC pills for PCOS. It's only to correct her irregular cycles. Okay, so that's why if not was an option, this would be the best option. Okay. Okay, it was asked what is the best option. Someone is saying it was asked what is the best option. If it's the best option, then lifestyle would be the best option for this patient. Okay, she has to be counseled. The initial management of PCOS for a young girl with a high BMI is lifestyle. So this would be the best option. This would be not a very good option. Okay. A pregnant woman, okay, this I think Dr. Praveen has discussed the lithium question. So Williams clearly says that the manufacturer gives instructions when you're prescribing lithium in pregnancy that the last few days of pregnancy, you have to decrease the dose to reduce the incidence of neonatal lithium toxicity. So it's definitely decreasing the lithium dose. It's very clearly mentioned in Williams that the last few days you have to decrease the dose, okay, to prevent neonatal lithium toxicity. Okay. So those are the questions from Obs and Gynae. A lot of, so we'll definitely come to the formal discussion because I have to modify these recalls on many of them. Okay, but please keep adding them, especially on the Telegram channel, and we'll come out with a formal discussion soon. So I think Dr. Pooja is next. Physiology.
Dr. Amrit will be there.
Dr. Amrit
We
is there.
can introduce him and then he can come.
Yeah, so next is Dr. Amrit from surgery. And thank you everyone mentioning the recall, so I correct these. Thank you.
Thank you so much, ma'am. Hello, guys. So I got quite a few of the recalls, most of them. While I'll discuss them, just tell me if you got any questions on trauma, because I barely got any trauma recalls, which is strange for a surgery paper. So let me start and let us discuss quickly. So this was one of the common topics that they love asking. Open cardiac massage is what type of surgical wound? I hope most of you got this right. So it's definitely not clean. It's definitely not dirty. The best answer here is contaminated. Okay, this is there in Bailey in the table. So open cardiac massage, because there is a breach of sterile technique. So this is going to be a contaminated wound or class 3. Right. So straight away question. Yeah. Again, this was a question I have discussed many times. Which of these is not a risk factor for CA gallbladder? So is it porcelain gallbladder, PSC, polyp less than 10 millimeters? And I don't know what the D option was, But of course, polyp less than 10 millimeters is not a risk factor. Right? Polyp less than 10 millimeters, it should be polyp more than 10 millimeters, though that's a dangerous polyp, or polyp in a patient more than 50 years of age. So those are dangerous polyps. In those cases, you are going to opt for surgery. Again, try to give me a more clear recall on this. Bones question I got the bones question. Yeah. Okay, the fourth was stone more than 3 centimeters. Okay, easy. All this is standard question. Most of the questions in surgery were either very standard or they were very difficult even for me, which is how INI CET usually is. Some questions were very weird. Yeah. So after lap chole, histopatch shows adenocarcinoma infiltrating muscularis. This has been asked many years back. It's a PYQ जो बहुत बार पूछा है. So what is the next step? If it is invading muscularis, means it is T1B tumor, and that cannot be managed by surveillance. That will require you to go in again and complete the job. So answer would be radical cholecystectomy or completion cholecystectomy if that option was there. Basically, you have to go in again and finish the job. You have to do a complete job. Adjuvant chemo won't be the answer because this is a muscle invading. That means you have done an R1 resection. If it is muscle invading, the resection is inadequate. So you'll have to go in again and revise. Right? What was the D option? Revision of bile duct margin. Yeah, but you'll have to do lymphadenectomy. So definitely B and C is not the answer. All right. If there is a better answer than this, you let me know. Yeah. Observation nahi hai. That's not the answer. If there was this option, then go for it. No, revision of stump margin may not be enough. This was one of the tough questions. This, I can tell you, a lot of people won't be knowing. No one, I don't think this is expected. So they asked you about bile duct injury types, and they asked you which classification also takes into account cautery injury. Yeah, cautery injury with that. So you know Strasberg and Bismuth don't. Strasberg and Bismuth are based on level of injury, cystic duct, right posterior, common hepatic, that mechanism. But it does not take into account thermal injury. So answer here is Stewart way. I believe this was there in the option. So Stewart way is the one which takes into account vascular injury. You can see this is Stewart way. So they are saying which artery injured, which artery injured, which artery injured, and what is the effect. No, it won't be Hanover. Stewart way is the best answer. Okay. So vascular plus bile duct plus vascular. Right. So that is going to be Stewart way. If this kind of question, these two options you should eliminate, and then between the other two, you should take a chance. That's the best way. 50-50 is always good. Yeah, I changed it back. Bile duct and vascular. Ek hi baat hogi. Yeah, I got the Hanover. Thank you for the fourth option. Right. So this was one tricky question that I got. Yeah, I changed it from vascular to thermal. Incorrect statement about type 1 choledochal cyst. This was easy, straightforward. Cyst is opened and drainage is done. This is not correct. What you do is going to be excision. It is not an abscess. The treatment will be excision and reconstruction. Other options were simple. Uska to kuch recall bhi nahi aaya. That increased risk of cholangiocarcinoma. Then there was something about the location of the cyst. Right. Yeah, it was based on Todani classification. So you don't do opening and drainage in management. You have to do excision in the management. This is the incorrect statement. Hawkins classification is orthopedics. It's not general surgery. Again, this was another tricky one. If you can help me with the options. I am not sure if this was the incision. Okay, I am not sure if this was the incision. Is gallstone more than 3 centimeters? Is a risk factor. Yeah. So if the incision was like this, suprainguinal, something looking like this, then the answer is Gibson. Okay. What were the other options you can help me with? Yeah. Okay. It is due to pancreatic duct malformations. Fine. No, it's not Robson. Robson is not the answer. So this incision is Gibson's incision, which is used for nephrectomy. So it's a nephrectomy incision. Gibson and Abernathy. But I don't think Lance was there in the option. So sorry, it's not Lance. Okay. Baki ke easy the. Female presented with features of intestinal obstruction. Some history like this was given, and a swelling was noted below the pubic tubercle. Likely diagnosis. This will be femoral hernia. So below inguinal ligament, obstructed femoral hernia. Right? So I hope what were the other options you can tell me, otherwise it's straightforward. You won't miss it. Yeah. There was Lance, there was Battle. What most people expected were appendicectomy incisions. Yeah. Okay. Again, I have a nice question. The fibers of internal oblique muscle and transverse abdominis muscle contribute to which components of inguinal canal wall in context of inguinal hernia? So obviously it is not going to be anterior and it's not going to be floor. So best combination will be roof and maybe even posterior wall. If the best answer is roof, but if there was no choice where it is only roof, then go for roof with posterior wall. Okay, that will be the combination. Okay, yeah. So straightforward anatomy, surgery, integrated kind of a question. Wonderful. No, it's not going to be 3. Doesn't form the floor. Floor is formed by inguinal ligament. Okay. Now, adult, there was a Burns case, easy case, anterior chest and abdomen burns. So that together becomes 9 and 9, 18%. Then there were burns over thigh, that is half of 18, again 9%. And there was burns over right arm, that is again 9%. So this answer I think should be 36%. Okay. If roof and floor was not given, go for the one which has roof. Roof is a part. It is contributed by roof. Roof hona hi chahiye in whatever amsha. Okay. So anterior torso will be 80%, arm will be 9%, and thigh, they said thigh, they did not give full limb, so it will be 36%. Okay. This I'm again a very commonly asked topic. Neonate with breathlessness found to have scaphoid abdomen, which will not be done. Answer will be bag and mask ventilation. Yeah. Right. Easy question. Arm means full upper limb, na? They said full upper limb. Point front of chest, whole right upper limb, and circumference right thigh. Yeah, 36% seems the best answer there. A lot of people gave me this kind of recall. Then there was an image of a lesion over the face near the eye, which looked like basal cell carcinoma. It was not anything else. It was a rodent ulcer. I don't know if Spursar discussed this. Most important prognostic factor for CA breast. Answer will be lymph node mets. Overall, it is T and M. But you have to pick one, go for lymph node mets. Right? It will be lymph node mets. Okay. Right upper limb, BCC, very good. Female thigh, front of chest. No, both thighs nahi there. That was definitely not there. Fourth option was size. Okay. Best answer will be lymph node mets. This is a PYQ. Okay. Nodal status. That will be the answer. No. Nodal status was definitely there. And this was the one in which many people have given me different scenario. Many have given different scenario. If you can help me with this question, ye mujhe barabar se nahi mila. Question was on some primary cancer with secondaries to liver. When can you do a liver transplant? Was this the actual question? When can you do liver transplant in a patient with secondaries to liver? The answer will be lymph node status. That is the best answer. What was this question exactly? Option C was testicular cancer. सब मेरे को इसमें अलग दे रहे हैं. Secondaries were not mentioned. Testicular cancer. Then, can you do liver transplant? In which case? In which of the following liver transplant is not contraindicated? So, not a contraindication for liver transplant are skin cancers, but it should not be melanoma also. Skin cancers and endometrial cancer in situ. Okay, these are the ones which are not contraindicated. Endometrial carcinoma in situ. Okay, secondaries were not mentioned, not contraindication. Extrahepatic malignancy where liver transplantation can be done. See, this was the most controversial recall. आप लोगों ने recall बराबर नहीं लिया, इसलिए इसका आंसर नहीं मिल रहा है शायद. But these are the scenarios where you can do organ transplant as a whole despite a primary cancer. Okay, in this you can do a liver transplant. Okay. In which of these extrahepatic cancers is liver transplant not contraindicated? तो फिर यही होना चाहिए आंसर. One of these. ठीक है, not a contraindication. You can do liver transplant in this. Okay. So I am surprised there was nothing in trauma so far. These were all the questions that I have. You can take a screenshot if you want. One or two ambiguous, one or two difficult, other was straightforward. So I hope you were managing surgery. I believe other subjects were harder. So I guess those will be the deciding ones, not the surgery ones. So now Dr. Janvi will discuss her anesthesia questions. Over to you, Dr. Janvi. All the best, guys. Keep working hard.
Hello, everyone. So I'm going to quickly finish off the anesthesia recall. Literally just 2 questions from anesthesia. Now, the first one, this was a slightly trick question because what we have always studied is the maximum FiO2 of all our oxygen delivery devices. Okay, so in the oxygen delivery devices, one thing you could have ruled out when we talk about the maximum FiO2 of nasal cannula, simple nasal cannula. Okay, that is 40%. That is the maximum amount of FiO2. Now, maximum FiO2 is given only when you give it at the maximum oxygen flows, that is at 5 liters per minute. But here, they had added specifically that in the child, we are giving 3 liters of oxygen per minute. All right. So, definitely the answer has to be less than 40. Now, is it 30 or is it 35? So, how it is actually is if I'm giving oxygen flows at 1 liter per minute, then the starting FiO2 would be 24%. After this, for every liter per minute that I increase, the FiO2 increases by 4%. So for 2 liters per minute, FiO2 increases by 4%. It should be 28%. At 3 liters per minute, FiO2 increases further by 4%. So it should be 32%. And at 4, okay, 25% was there in the option, but that is not the answer. Don't worry. Okay. At 4 liters per minute, this goes up to 36%. So now we also had options of 30 and 35. Is that correct? So we had 25%, 30%, 35%, and 40%, if I'm not wrong. Okay. So I would go for the closest option to 32%. That is, I would go on the higher side and mark it as 35%. That is what my answer would be. The accurate answer for 3 liters per minute is actually 32%, but I would go higher at 35%. All right. 25% is definitely not the answer. All right. Okay. Now, the next one is what is the correct statement about ASA 3 classification? I think this was super duper duper simple. And this you only needed to know the definition of all the ASA classifications. As I always say, ASA 1 is a normal, healthy patient, no comorbidity. So this one was ASA 1. Okay. ASA 6 is a brain dead patient. ASA 5, 1 less from brain dead, is moribund patient who will die without surgery. Okay. Now we have in between ASA 2, 3, and 4. So ASA 2 is mild to moderate systemic disease. ASA 3 is severe systemic disease. ASA 4 is severe systemic disease, which is a constant threat to life. Okay, so by that definition, your ASA3 becomes severe illness. Severe illness. Okay. Now, a lot of you are saying that, ma'am, it can be moderate also. If you go in the ASA classification, if you see the whole thing, it is divided into two things. One is the definition, and one is the explanation of the definition with examples. Okay. So when we go in the definition, they write ASA3 as severe illness, and in the explanation, they have written moderate to severe illness, and then they have given the examples. But again, the catch situation over here is ASA4 is written as severe illness, which is constant threat to life. Okay, so what they are asking you over here is directly from the definition and not from the explanation. So please don't go in the explanation and mark the answer as moderate illness. ASA3 will be severe illness. ASA4 will be severe illness, which is a constant threat to life. Okay, so this is the other question that came from anesthesia. I don't think और कुछ आया था anesthesia से. That's it, just two questions, and I whatever you all have done, जो हो गया सो हो गया. अभी जाओ, मैच एंजॉय करो, आराम से अच्छा खाना खाओ, ठंडी ठंडी बियर पियो, and enjoy today's day. And then from next week onwards, start preparing for NEET PG and wait for your INI CET results. All right. Okay. Now, giving over to Dr. Pooja Nigade for the physio questions. Moderately severe, agar option mein tha, even that will not be the answer. Answer will be severe illness. All right. Giving over to Dr. Pooja. Thank you so much.
Hi, ma'am. Thank you, ma'am. Am I audible and visible? Please let me know. I'm watching your YouTube comments. So if I'm audible and visible, please let me know, guys. Okay, just give me a... All right. Ventilation question came. Okay, so am I audible and visible, right? Because last time it was not. So let me just check. Yes. Okay. So let's start with the first question, right? So can you see the screen, guys? Can you see the screen? Okay. I hope you see the screen also. Okay. Let's start with the first question. First question was about this thing. Is it the first question? Is it correct? All right. Action potential. And over here, the phase 3 was asked. Now, please remember, the phase 3 is nothing but your repolarization, isn't it? And repolarization is because of the potassium efflux. This was the question. No screen. Can you see the screen right now? I am able to see in my YouTube. So I'll wait. Okay, I hope this is visible because in the YouTube, I can see that there might be some delay. Okay, this was the question, potassium efflux. Yes. Okay, next question was about the nodal tissue for action potential. Phase 0 was asked, not the pacemaker potential. Please remember, both were there in the options, but this is not the option because they asked about phase 0 and not about the RMP or pacemaker potential. So answer over here is going to be calcium channel, long-acting calcium channel. Yes. Right. This was the question. Multiple answers were correct over here. A, B, and B, they are present in the early part of the PCT. I have already marked the answer over here because many a times we forget to, give the tick marks over there. Right. Phase 0 wala, one more question. What was it, Sanjana? Please let me know in the comments itself. Okay, so all of three are there, but the sodium bicarbonate co-transporter, because it takes time. It takes time to convert and have that carbonic anhydrase wala reaction. So that's why it is present in the later part of the PCT and not in the early part. So except this sodium bicarb, everything is present in the early part of the PCT, right? All right, next. Question, a reason for high cardiac output in the pregnancy. Remember, estrogen also helps indirectly to increase the aldosterone activity. So yes, both the aldosterone and estrogen, they are going to be in the options, right? And ADH was also there. So option D is the answer. Okay. What was the option? A and B was the option. Okay, whatever the combination was there of the last question, you can go, because I got such questions. So whatever combination was given, definitely it is going to be the answer, right? With the sodium, potassium, ATPase, that is going to be there. Okay, whatever is closest. Okay, so give me the questions properly, options later on. All right, then D was the answer over here. Water retention by the kidney, and aldosterone. Okay, ADH was also there. ADH is also going to help. Now, coming to the baroreceptor, this was question which was asked. Has a cation channels? No, they don't have any cation channels. These are the mechanoreceptors, right? And they're present in the muscular layer. Obviously, this they are stretch sensitive and they don't work on the cationic channels, right? So whatever A or B option, the option what I got over here, this I gave, right? This is the question which was asked, right? If any modification is there, please let me know. I'll modify accordingly. Okay, right. Then next question, Vibrio cholera, and they ask extracellular component of tight junction. In that, C for cholera, C for Claudine junction, not the afflurin. Please remember they affect the Claudines. Okay, Claudine. Okay, fine. Now, yes, stretch sensitive, absolutely correct, absolutely correct. Let's move on. 2,3-BPG binds to, it doesn't bind to myoglobin. Please remember only one seat is there in the myoglobin and oxygen binds to it very, very quickly, right? So there is no per se seat for the 2,3-BPG, and we know in the hemoglobin we do have alpha beta chains, right? In the adult hemoglobin, it binds to the beta globulin, right? Beta globulin and beta globin chain, and that's why in the infant, it cannot bind 2,3-BPG. Why? Because infants have alpha 2, gamma 2 chains, right? And that's why there is a left shift. We have covered that in the answers were there in the yellow marks, right? So has a cationic channel, that was a wrong statement. And a wrong statement was asked, there is no cation channel present. All right. So that is there. Globin part mein hemoglobin of globin part is going to be the answer over here, right? Wrong statement about the right. So next is this one, guys. Next question. All right, fine, absolutely correct, right? So next question, prognathism, and somebody said that crowding of the teeth was shown. I didn't get the exact image of it, but we'll come to it sooner or later, right? So acromegaly, crowding of teeth, if the gigantism is there, that won't be seen, because as the patient is going to have the growth hormone beforehand itself, so the crowding won't be seen. If the crowding of teeth is there, it is the acromegaly. Okay, right. Next, identify the conduction block. There is a skip beat which is seen, and if the skip beat is there, we call it as not only prolongation, skip beat. Prolongation hai first degree, skip beat hai to second degree after prolongation, right? After prolongation. And AV dissociation hai, that is going to be third degree. And this is the J reflex. We have very well discussed that. J reflex in the respiratory system, right? No graph came this time. So J reflex mein pneumoperitoneum ho, always pathological, usually happens with the pulmonary edema, pleural effusion, and over here vagal will be stimulated, and this is going to happen due to distension. Yes. Okay. Okay, gapping of the teeth was shown. Fine, fine. Now, this is the cystic fibrosis regarding chloride channel mechanism. Now, what is the mechanism? It decreases the chloride transport in both, because it's a genetic disorder. It cannot have a particular effect on a particular organ. It is going to affect all the organs, and chloride transporters are going to be defective. So chloride transport is going to decrease in both the pancreas as well as sweat glands. Okay. Comments about baroreceptor question. Wrong पूछा था ना बच्चे, और true पूछा था. True तो यार बहुत सारे options है यार. True नहीं हो सकता, wrong ही है. Okay, just let me know. True पूछा था पक्का से. Okay, fine. Many of them is saying, Sunida is saying wrong पूछा था, right? So wrong पूछा था. Okay, fine. Next question, ABG पे question आया हुआ था, and if I'm not wrong, the pH was given as 7.28. Is it? True statement पूछा था. Okay, we will go back to it. We'll go back to it. Okay. Multiple statement based. Okay, fine. So this was the answer or not? The respiratory acidosis, hyperventilation when inadequate. Why I'm saying inadequate? Because if it would have been adequate, then what would have happened? The 7.28 will not be there. The acidosis won't be there. The pH will be normalized back to normal, right? And because the main stimulus for the respiration is CO2, yes, and that's why it is going to cause hyperventilation. Okay. 7.3 is also acidosis, and a 7.35 to 7.45, and we say. Okay, somebody in the Telegram group gave me this pH 7.28, and 7.38 भी दिया है, तब भी inadequate ही आएगा. Hypoventilation नहीं आ सकता because it is the CO2 which is going to stimulate. See, CO2 is very, very high. It should be around 40 mmHg. It is almost double, right? So it is going to be hyperventilation that is going to occur, right? ये वाला सही है बच्चों? Lead to acidosis. Okay. All right. Hypoventilation क्यों होगा? Hyperventilation होगा. We want to get rid of that CO2, excessive CO2, right? Then the diagram was given like this, and what is the V1 to FVC ratio? That was 50%. Is it correct? Is it correct, guys? COPD की history दी हुई थी. Okay, I got it. COPD का history दिया हुआ था. I'll note it down over here. COPD history. Again, the same is going to happen. Obstructive lung disease है. इसमें दिया हुआ था, इसमें दिया हुआ था COPD disease. Okay, in this COPD was asked. Okay, इसमें दिया हुआ था तो यार, it's clear ना that it's OLD, है ना? Hyperventilation क्योंकि CO2 high है बच्चे. Mudit, because the CO2 levels were high. Okay. CO2 was 60. Shweta, still it is going to be hyperventilation. Why? Because we want to get rid of the extra CO2 that is present in our body, and the CO2 can stimulate both peripheral as well as central chemoreceptors. So hyperventilation is going to take place. Okay. यहाँ पे यही सिर्फ एक OLD है. And that's why it is reduced, है ना? हमने क्या पढ़ा था? Restrictive lung disease में the ratio FEV1 to FVC ratio is going to increase or normal. It is going to be normal or increase. Why? Because FEV1 ज़्यादा, बहुत ज़्यादा कम होता है as compared to the FVC. FEV नहीं, FVC is going to reduce a lot. जब denominator बहुत ज़्यादा decrease हो जाता है, that's why it is going to have, may have in the initial cases, increment in the ratio per se. Okay. All right. ABG पे क्या question था? बताओ बच्चे. Shweta, what was the question? Because this is the particular question I have got. है ना? All right. So mechanism of cough was asked. Is this the proper question? Just let me know. The answer is going to be forceful expiration and removal of harmful substances. Why? Because harmful substances, they only cause this cough reflex to be activated. All the muscles are going to be contracting, right? So irritable stimuli stimulating my airways, and that is going to cause the forceful expiration against open glottis because I want to excrete it out, right? So remove. एक और था, क्या था एक और ABG का question? Alpha, beta, gamma, delta. Beta chains. If it is alpha, beta, gamma, delta about the oxygen, it is going to be beta chain. Okay. Single options tha iska. I have got this question. Fibrosis wale ka single option tha. Okay, fine. Fine. And the last question I got is the insulin independent. What I told you, the mnemonic is insulin independent. If two I's are coming, that means it is GLUT2, and GLUT2 is present on the liver, pancreas, and kidney. And this is going to be except. This question was asked as except. So the answer is going to be adipose tissue, right? Guys, please message me on the group or on the Telegram channel. Whatever question you want to modify, we'll modify and we'll make a separate video, right? This is another question. Last question I got. PTH ka primary. What is the primary mechanism? Somebody told me both was given. That means resorption of bone as well as decrease in the excretion. If both in the option, both option was given, right, as option D, then both is going to be there. Okay. Brain में भी GLUT1 होता है बच्चे. GLUT1 is also dependent, right? All right. Is this the correct option or both were given, बच्चों? Within 4 hours of increase. Okay. I'll check about it. Anything else in the changes in the options? Yes. Both were there, then the both is going to be the answer. And both were there, that means both is going to be the best answer. Okay. Graph किसका था? GLUT4 का ग्राफ था. किसका ग्राफ था? Kidney excretion, right? Both is going to be there. Okay. So these were the question. If you want to add, you can add. Nerve supply का मुझे structure नहीं मिला. What was the image? I didn't get it. If you want, you can modify these questions. Okay. I'll put up the PPT. You can modify, right? So that is all from my side. I think Shrikant sir is going to be taking the next thing. Okay. So that is from all my side. Okay, who is next?
Dr. Shrikant sir, he's coming.
Shrikant sir, you can take over, sir.
Dr. Shrikant sir, are you there? Ma'am, he will take another 2 minutes to come.
Okay, okay. Then I'll modify my questions because still the comments are coming.
Yeah.
Right? Brain में कोई particular area दिया हुआ था in the brain, in the satiety center. Yes, we are going to have a change. But अगर नहीं दिया हुआ, then it is going to be different. Okay? इसमें ऐसी आंसर थे, only you have to choose one or except क्या था बच्चों? Okay, cystic fibrosis में right पूछा था. Okay. Cystic fibrosis में right पूछा था. Yes, we have corrected the right. Right answer is option D. Except नहीं पूछा, I agree on that. All right, Shrikant sir is taking 2 minutes. So I came back. ब्रोंकिएक्टासिस इस वजह से बचे बिकॉज आरएलडी में क्या होता है आपका आरएलडी में डिनोमिनेटर डिक्रीजेस अ लॉट एंड दैट्स व्हाई द रेशियो ओवरऑल इज गोइंग टू इंक्रीज राइट सो FeV1 percentage is going to increase but bronchiectasis that means you have a problem in the airways this is a obstructive lung disease neuromuscular disease है sarcoidosis है या pulmonary fibrosis है these are the type of restrictive lung diseases है ना यहाँ पर clearly आप देख सकते हो FeV1 percentage is reduced and that is going to be your obstructive lung disease है ना concentration किस में पूछा था बच्चे कीर्तिका yes Shri Renu the both are going to decrease but the decrement in the denominator is going to be much higher right so reduction is going to be higher in the denominator right that's why carotid sinus का क्या पूछा था बच्चे carotid sinus पूछा था baroreceptor नहीं पूछा था directly that's what you are saying is it both में ग्राफ दिए हुए थे आपको nerve का action potential and this thing yes I'm searching for it ये तो J reflex वाला था है ना you want baroreceptor baroreceptor में एक्सेप्ट तो नहीं पूछा था राइट हाँ Baroreceptor, carotid sinus was asked. This was your telling. Carotid sinus was there, is it? Okay, fine. Carotid sinus, again, sinuses. B never goes with B. So carotid body is going to be your chemoreceptor. Carotid sinus is baroreceptor. Baroreceptor, the sense stretch. You know? And we know that aortic body say 10th nerve and glossopharyngeal is a 9th nerve which is going to go from the carotid sinus. You know? So that is there. Okay. Yes. So Shrikant sir is online. So sir, hello sir. So you
Hello,
can
ma'am.
take over.
Thank you, ma'am. Thank you. Sorry, dear students, for little technical delay. So we are going to start our anatomy session. So hope your exam was good. And yesterday, our session anatomy conceptual brainstorm integrated session, it was very fruitful for all of us. All the best, everybody. Okay, so let's start without delay. The anatomy recall INI CET November 2023 by Dr. Shrikant Verma, Faculty of Anatomy at Cerebellum Academy. So look here. I told you yesterday in the our marathon INI CET session, definitely damn sure one question from the our joint topic, and the same thing happened. Okay, so just observe, there was the our M, I, and S, malleus, incus, and stapes. At that time, we studied that the joint between malleus and incus, this is concave convex, means it is the saddle joint. Okay, getting the point? Fine. Yes, hello everybody. Yes, Nimra, Rabel, hello everybody. Hope you all, yes, okay. And at that part, we had seen this is the part where there is the ball and socket variety. And yesterday, with the proper three-dimensional orientation, we had seen also. Yes, very good. Yes, thank you, Rabel, thank you. Anatomy was wow just because of you. Thank you, Rabel. So yesterday we had seen this all the three-dimensional orientation about the ear. I told you just it is not more than 24 hours ear also. So this was our tympanic membrane, and we had seen the malleus. Yes, this is the very, very small bone, malleus, and we had seen the our bone stapes also. Correct, sir? So yes, at that time we had seen this is having the convexo-concave surface. That's why it is our saddle kind of the variety, while here ball and socket variety. Okay, hope you all got this point perfect. Okay, now yes, Parul, tell me what are the other questions. Okay, so this was the our saddle joint. Agree? B is correct. Now look here, which muscles are supplied by the lateral plantar nerve? So I told you yesterday one question from the foot. In our recorded video, I also told you the bones of the foot, the ligaments, the joints, they are important. But this time they focused over the muscles and the nerves. Okay, so there is a slight deviation in the pattern, you can say. But yes, the topic is the same. Okay, so the which muscles are supplied with the lateral plantar nerve? Look here, this is the, yes, here was the one image. So at that time, in the our plantar area, look here, I'm showing you just one lateral plantar nerve image. So in our sole area, there are the two plantar nerves, medial plantar nerve and the lateral plantar nerve. Yes, these are the divisions of our, you can say, the tibial nerve. Agree? So the lateral plantar nerve, can you see in this image, sir? I'm just using this image. I had included this image in the PDF, but right now it is not showing. So right now I'm adding here. So look here. Can you see this image, beta? Yes, the tibial nerve comes and it is dividing into the medial and lateral plantar nerve. So here is the our lateral plantar nerve. Look here, this lateral plantar nerve is coming and it is supplying the flexor digitorum accessorius, then abductor digiti minimi. Remember, it will supply the lateral side. So whatever the muscle on the lateral side, they will be supplied by lateral plantar nerve. It is giving the deep branch and the superficial branch. So the deep branch, it is giving supplying to the interossei muscle, as well as it is giving the cutaneous muscle. Digiti minimi muscles, they are supplied. Okay, so try to catch this one, sir. Here the answer will be the flexor digitorum accessorius, abductor digiti minimi, and the interossei. So this is our food topic. Yes, I told you the food topic is important. So now look here, another question, the Papich circuit. This is the question from the Papich circuit. Can you tell me what was the exact image? Yes. Sure, Swati. So there was the question, thalamus. So I told you at that time, there are the different parts, anterior nucleus of the thalamus, then cingulate gyrus, then hippocampus, then mammillary body, and then this impulse go in such kind of the way. Yes, here was the fornix. So during this circuit, this is the papillary, this is our Papich circuit, the impulse reaches to the anterior nucleus of the thalamus. So answer, there was the arrow. Student, we are saying about the our fornix. So which image was there? Please inform me. Okay, yes. So answer will be the anterior nucleus of the thalamus. If any deviation, please inform me. Okay. Yes. Efferent from the fornix. Ankit is saying efferent from the fornix. So remember, this fornix is carrying the impulse from the hippocampus to the mammillary body. Okay. So remember, efferent from the fornix, if it is asked. So in that way, you can say the hippocampus, fornix is acting efferent for the hippocampus. So mammillary body will be the efferent for the fornix. So according to option, you have to remember. Okay. So anterior nucleus of the thalamus according to such kind of the pattern. Now come to the next. These are the different nucleus of the our thalamus. This is the anterior nucleus of the thalamus. Now look here, match the following muscles with their action. So the question from the upper limb. Look here, the latissimus dorsi. We all know it is the climber's muscle. So it is the extensor at the shoulder. Supraspinatus, we all know it is the abductor. Old edition, we are saying 0 to 15 degree, but the new edition, they are saying the 0 to 90 degree supraspinatus. So it is causing the abduction. And then infraspinatus, sir, it is the lateral rotator, and the pectoralis major is the our flexion at the shoulder. Getting the point, everybody? Okay. Yes. So according to it, A2, yes, sir, A2, and then B3. So this is the B3, and then C is going for the 4. So answer will be the D. So such kind of the multiple question was there, but it is simple question. 4 question in the one. Now come to the next. Look here. When asked to the patient to stand on right foot, I told you yesterday, the one question sure from the gluteal region. So it is not more than 24 hours even. The same question asked, okay, the Trendelenburg sign again. Okay, so when the patient is standing on the right foot, the left side was going down. So this is the situation of the damage of the right superior gluteal nerve. So superior gluteal nerve will get damaged on the right side. Right side gluteus minimus and medius, they are getting damaged. Tensor fascial lata also. So answer is the our 1, 2, 3. So 1, 2, 3 in the B. Okay, maybe different option, maybe different option. Okay. Yes, B3 only in one option. Okay. Yes. But such kind of question pattern was there. What I recalled from the students, that is, please comment what was the other kind of the modification. Okay. Okay. Except was asked. No? We will modify. Now come to the next question. Which sulcus would be affected and injury to the pointed area? So this is the most commonly asked question. This is our pterion. Below to it, there is the middle meningeal artery. But this time they ask about the sulcus. So remember, at this our pterion part, there is the our lateral sulcus stem part. What is your answer? Lateral sulcus stem part. So you can observe here, sir, this portion is our H-shaped area pterion. Yes. And just below to it, can you see? This is our lateral sulcus. Yes, sir. This is our brain. And here you can see the lateral sulcus part. Yes. So this is the stem of the lateral sulcus. Your answer will be the lateral sulcus. So we had seen this also. Lateral sulcus was there. Okay. Now come to the next one question from the embryology. And yesterday we had seen the CNS development. Which of the following structures derived from the mark point? So in this image, you can see, sir, this is the neural tube. So this is the notochord. So your mnemonic is L, I, and P. Lateral plate mesoderm, intermediate mesoderm, para-axial mesoderm. So arrow was over the para-axial mesoderm, lip was your mnemonic, and this para-axial mesoderm, it creates the somites, and somites are responsible for the axial skeleton. Answer will be the ribs. Okay, if any modification, please inform. Okay. Yes. Lateral sulcus. M's ka bachcha, lateral sulcus will be there. Answer, na? Now look here. Okay, I will modify the option. Frontal inferior was in the option, na? Okay, beta. Okay, frontal inferior I will include. So I am including you are saying the frontal inferior. Okay, thank you. Frontal inferior. Thank you, Zakar. We will include the frontal inferior. But even then, I had shown you the 3-dimensional orientation. The lateral sulcus will be the answer. Answer will not be changed. Okay, now look, identify the marked structure. So student told about such kind of the cadaveric image. Few students were saying the CT image, but at that part, arrow was, most of the students, they told arrow was over the pulmonary trunk area. Okay, so answer was the pulmonary trunk. Can you tell me bronchus, aortic arch, pulmonary trunk? What was the C option? Yes, C option, C option, C option. What was the C option? Anyone? Neural crystals? No, it was marked over the paraxial mesoderm. Maximum student told this one. Malik, okay. Identify the type of the bronchi in the given image. So there was the respiratory, terminal, alveolar sac, and transpulmonary bronchiole. But exactly image till now I had not catch till now. Okay, trachea carina. Okay, fine. So carina was the option. So let's see what will be the option. I was not getting exact part, but this was the one question pattern from the division of the respiratory tract. Okay, now look here, blood supply of the area. Yes, so this is the image of the our medulla. Can you see at the center there is the pyramid, and this is the olive part. This is the our lateral part of medulla. So this lateral part of the medulla, the 6th number, it is supplied by which artery? Remember, posterior inferior cerebellar artery, which is the branch of the vertebral artery. So again, there was the controversy. Few students were saying the different kind of the area. Okay, so few students are saying carina was not in the option. Okay, fine. So yes, we will modify according to it. Okay, now look here. There was also one question on the suprarenal gland, adrenal gland, cortex. Students, we are saying that this was the our histological image. Let's see what was the exact question pattern. Can you tell me better? Pica was not given. Okay. Yes, Ankit, congratulations. Okay, so okay, vertebral artery was not an option, was an option. Okay, so we will include that one. Okay, vertebral artery, we will include the vertebral artery. So remember, vertebral artery is giving the branch, that is the posterior inferior cerebral artery, no? Okay. Pica was not in the option. If the pica will not be in option, then answer will be the vertebral artery. Agree? Okay. Posterior cerebral artery will not be there. Okay. So vertebral artery will be option if pica is not given. If pica is not given. Now come to the next. There was the one image. I was not getting the exact 4th option as well as the image. Please help me. There was the histology image was there. Leydig cell, yolk sac, Sertoli cell, and one more option was there. Okay. Okay, Parul, few are saying posterior cerebral artery was not there. Few are saying the posterior cerebral artery was there. So we will do more discussion about it. Okay. Artery of which branch? Vertebral artery. Vertebral artery will give the pica, and this pica will supply the lateral part of the medulla. If there is the damage, then lateral medullary syndrome or the Wallenberg syndrome. Okay. Yes, adrenal is yellow. Okay, we will see. Now, there was the one question, midbrain or pons, and its blood supply was asked. So few students we are saying the midbrain or pons, or few students we are saying the lateral part of the medulla. Okay, if this is the lateral part of medulla, then definitely the arterial supply will be the pica, and this pica is the branch of the vertebral artery. So this is the still one controversial question. Let's see what the other discussion occurs. Okay, yes, few students were saying the blood supply of the corpus callosum, and yesterday I told you that this is located on the medial surface. It is located on the medial surface, and medial surface blood supply will be the anterior cerebral artery. This is the topic related with the circle of Willis. Can you recall? Yes, and this anterior cerebral artery is giving the branch, that is the anterior communicating artery. So our answer will be the anterior cerebral artery and anterior communicating artery. Okay, fine. Cilia we are present in that question, probably suggest the terminal bronchiole, maybe better. Okay, not us. Okay, fine. So these are the points. Also, there are the one question related to the orthopedics of fracture at the head or the neck of the fibula part. Okay, and there was a changes in the gait. So such kind of the question was there integrated with the anatomy. Okay, so these are the points. Few more questions are there, but let's see. And integrated anatomy, we will do more discussion. So please comment. Yes, okay, not us, so leave them. So up to this question, these were the question. We will collect more exact framing of the question after this discussion. So thank you very much. God bless you all. Hope you all done very well. All the best for your results better. Okay, yes, stamping gate you will see in your orthopedics part. Okay, yes, okay better. Okay, fine. Whatever the correct question pattern I discussed here, and the further more updates we will do. Thank you. Okay, so thank you, everybody. I'm looking for our next respected teacher.
Dr. Srinivasa will be taking it.
Yeah, so our hero from the dermatology, Srinivas sir, is here. So thank you very much, sir. Please. So any more thing, beta? About the gate, you will get the knowledge in the your respected subject, beta. Just I got the information, but that is the anatomy question, orthopedics question is still not clear. I think if it is the gate question, then it will go to the orthopedics part. Okay, and hope this is the again repeated question. Yes, so we are waiting for the Srinivas sir. If any more doubt. Yes, about the adrenal gland, we will see.
Join फिर बोल देना. Sir, he is coming in another 5 minutes. In the meanwhile, you can discuss if you want.
Okay, sure. Okay, ma'am. Okay. Yeah. Any more thing, beta? Can you inform me about this question? I'm not getting the exact question about this adrenal gland. Adrenal gland question. Adrenal gland, what was the question? Adrenal gland relation. Yes, thank you, Cham. Thank you. Hope our yesterday session was very useful. All the question directly came from our discussion. Okay, few question more depth because it is the INICET, the joint topic we discussed yesterday. Definitely the joint topic will be asked, and the same hour. This was the little more depth question from the foot topic, so we will discuss about it more. And yes, this was the expected question. I told you the question from the fornix and the question from the corpus callosum is sure. White matter one question, and your basal nuclei one another question. Yes, and this was the our muscles. So from the upper limb one question asked. The one question was consisting of the 4 things. Okay. Yes, Talim, what the question you are asking, beta? Fibular neck fracture. Okay, so fibular neck fracture is there, then our lateral compartment, peroneus longus and peroneus brevis will be involved. Okay. And about the gait, you will see in your orthopedics, beta. Okay. Adrenal is in yellow color. Heart cut section. So heart cut section was, so I'm writing about the heart cut section. I will include that one because I included only the heart cut section. So hope our yesterday session was good. Yes, anastomosis between uterine and gonadal artery. This question, uterine artery and the ovarian artery in PPH, but this question was in the PPH, na? So you will see in the your obs-gynae part, na? Okay, so I'm writing this one, adrenal semi-lunar surface relation. So one student is saying about the adrenal gland relation, semi-lunar surface relation. So I will frame this question. Okay, relation of the left and right adrenal. Okay, right and left adrenal. Is image was given Chandranshu. Image was given relation of the left and right adrenal. Adrenal as yellow. Okay, adrenal as yellow. Okay, Vaibhav, kacha badam during the class. Okay. Okay. Mitral valve, heart cut section. So if the bicuspid valve, tricuspid valve had been asked, I'm showing you in the 3-dimensional orientation. Na? Yes, look here. And meal same time we are waiting for the Srinivas sir also. As he will come, I will handle the platform for him. So just to see here, this is our heart. Can you see this is our aorta? So students are saying that bicuspid valve. Can you see this is the pulmonary trunk? Can you see the bicuspid valve part which you will go inside? So this front structure is our pulmonary trunk, and this behind structure is our aorta. Okay. So please tell me which valve had been asked. It was the pulmonary trunk or the aorta or your bicuspid valve. What is correct for adrenal? Okay. Inferior vena cava tributaries. Yes, Talim Khan, please again type. There are the flow of the message, so I'm not getting what your question was. Okay, if adrenal semilunar, so look here for the adrenal glands. So just look here. Sir, there are the two adrenal glands. Yes, pyramidal shape is the right side and semilunar shape is on the left side. Getting the point? So you can see the pyramidal shape adrenal gland on the right side, the yellow color gland. You all are saying the yellow color gland. So semilunar shape is on the our left side. Agree? Okay. So false regarding adrenal gland was asked. Right semilunar, left related to the spleen. False. Okay, spleen is not related with the adrenal gland. Second is false. Tail of pancreas not related. Okay, so I think sir is here. Good evening, sir.
Very good evening, sir.
Sir, so please now handle the platform. Thank you, dear
Yes,
students.
sir.
Whatever you are saying, what are the modification, we will do. But hope our anatomy session was very useful for all of you. So thank you very much. God bless you all. Sir, please.
So dear students, I hope your exam went awesome. So please confirm if my screen is visible for all of you. So thank you so much, Shrikant sir, for elaborately discussing about the anatomy questions. And yes, is my okay, I think it is visible. So hello dear students, so welcome to this session. I hope you have done great. So I'm just checking the open. Okay. Thank you so much, students, for the confirmation. So was this question asked? Yeah, young male age 24 had presented with asymptomatic scaly skin lesions on his back, which were symmetrically distributed. And they have provided these images where you are able to see this image is showing Collarette scale. And this image, which was showing a Christmas tree pattern. So were these the images which were actually shown? So then the question says the provided images showcase the lesions. So this is the classical lesions which we can see Collarette scales and Christmas tree pattern in the case of pityriasis rosea. So now the examiner is asking identify the pattern of these lesions and the specific disease. So this was actually a question of May 2023. Okay, so these were the options, and if anything is given other than these options, please do let me know in the comment section. So Collarette scale, Christmas tree pattern, pityriasis rosea. This is the correct answer. The rest of the options, they are related to lichen planus and seborrheic dermatitis. So option B says Wickham striae and lichen planus. Yes, lichen planus has Wickham striae, but Collarette scales and Christmas tree pattern is not going to be seen, so that is not the answer. And option C says Christmas tree pattern, lichen planus. No, the lesions are not going to be seen in Christmas tree pattern and lichen planus. And seborrheic dermatitis and worn-off ring. So please tell students in which disease we are going to see worn-off ring. So were these the images? Is there anything anterior trunk was shown in the image? So yes, even if the anterior trunk was shown and if the image was having annular lesions, small annular lesions, which are having this peripheral activity and central clearing with scaling, then you should think of pityriasis rosea. Lichen planus cannot be the answer. Okay. Christmas tree pattern. Yeah. Not scales, flocks, psoriasis. But psoriasis in the options? But annular plaques were shown. Were annular plaques shown? Yes, in pityriasis rosea also there can be mild itching. Itchy lesions can be found in pityriasis rosea also. This was not the image. Okay. Yeah, Voronov can be seen in psoriasis, right? Mild pruritus, yes, it can be associated with pityriasis rosea. Voronov's ring, it is nothing but the hypopigmented rim which can be seen around the psoriatic lesion. So this is associated with psoriasis. So this is also wrong option. So if yeah, sir, please answers only. Okay, so I know that you have woke up in the morning and you are almost awake. So let us move on to the next question. So was this question asked in this today's session? This was actually May. This was May 2023 question. So I will just try to tell the answers only. Okay, so the exam is asking non-scarring alopecia. I can understand the plight of you. You have woke up at 5 o'clock. So yes, non-scarring alopecia, alopecia areata, telogen effluvium, androgenetic alopecia. All these three are non-scarring alopecia, whereas frontal fibrosing alopecia is a scarring alopecia. So here the answer is going to be 1, 2, and 3. That is option B. Option B is the answer here. Okay. This was also discussed in the marathon session. And 1 second. So was this question asked in the today's exam? Related to statement 1, statement B, asking as an assertion reason? Yes, was this there in the today's exam? So the question says, clinically a patient with flaccid bulle and painful erosions will show suprabasal split and inflammatory infiltrate in the blister cleft on histopathological examination. So reason statement 2 says, row of tombstone appearance is diagnostic of pemphigus vulgaris. Okay, so this was not the question. Image was given, IBQ. Okay, so it was an image based question, and in the image, just give me one. So in the image, so was this the image which was given? Was it looking something like this, where you are able to appreciate that the oral mucosal lesions and image? Okay, oral mucosal lesions and image was given. So in the image, are you able to see this row of tombstone appearance and the suprabasal cleft? Suprabasal cleft or split? Okay, yes. DIF was given. Acha, DIF was given or histopathology image was given? So were you shown DIF image where you are able to see this kind of fishnet pattern? Not similar, but something like this. Okay. Row of tombstone, yes. So histopath image and mucosal lesions. Whenever you get to see these two, the combination of these two, that is mucosal lesions. Along with the row of tombstone appearance, the answer is going to be pemphigus vulgaris. Okay. Pemphigus vulgaris. Okay. And this also we have discussed in the marathon session. Okay, and this the question asked based on the image, identify this condition. Was it asked? Yeah, a old person. Okay, 60-year-old male patient. Okay. Yeah, different question. I think that was something related to pathology, I think, immunofluorescence. Okay. So was this question present? So 60-year-old person presenting with progressive lesion, and you are shown this kind of image where you are able to see ulcer present. Yes. Okay, lesion near the nose and medial canthus. Lesion near the nose and medial canthus. So always remember basal cell carcinoma, which is also called as rodent ulcer, is usually seen in elderly patient. Whenever you see this age group mentioned as elderly, always think about malignancy. So you can rule out melasma. It will present with hyperpigmentation over the cheeks bilaterally. Discoid lupus erythematosus is going to present with scaling and surrounding hyperpigmentation and central scarring. This is not going to, ulcer is not going to be the presentation. So whenever you get to see any lesion above this line joining the angle of the mouth to the tragus, always think about basal cell carcinoma in an elderly. Okay. And this was the image based question which many students told came in the today's exam. So image of velvety neck or nape of the neck. So that was the what students told, present in a 13-year obese female. So what is the diagnosis? That was the question. And students told that acanthosis nigricans and along with that insulin resistance, both of them were present in the options. Okay. Yes. So can you please tell me what were the other options which were present in the exam? What were the other options which were given in the exam? Yes, insulin resistant. So if you are able to see this kind of a velvety pattern over the nape of the neck, always think about acanthosis nigricans and insulin resistance. I hope you all do remember Hyran syndrome, hyperandrogenism, insulin resistance, and acanthosis nigricans. So all of these go hand in hand. Okay. Yes, insulin resistance. Right. So these were the questions which I was told came. And one more question. One second. Yeah. So one more question is apocrine glands, related to apocrine glands. Apocrine glands are seen in, apocrine glands seen in. So this was the question, and options told something like this: axilla, not groin. Option was something else, face. And what are the other options? Can you please give me the other options? Axilla, face, and what are the other options? Apocrine glands are seen in. Was this the question they have simply asked? Yes, students. Palms and soles. Okay, palms and soles. Axilla. So here the answer is going to be axilla. Axilla was there. Yes, the apocrine glands, they are present in axilla. Okay, this also we have discussed in our class. And yes, one more question was asked that was related to HIV patient. HIV patient. And there was mention of non-scrapable white patch in the mucosa. And the options were EBV and something else. So if you know what were the other options, please put in the comments. I will check them. But the answer is here is going to be EBV. EBV is the answer. Epstein-Barr virus can lead to oral hairy leukoplakia. So please remember the important differential for OHL is going to be candidiasis. But remember the white patch which can be seen in candidiasis is going to be scrapable. That is how you can differentiate between OHL producing a white patch and candidiasis producing a white patch. So in OHL, it is going to be non-scrapable. You try to remove it with the white patch with the help of a gauze piece. You cannot remove it. Okay, you cannot remove it. Whereas in candidiasis, if there is a white patch in the mucosa, if you try to remove it with the gauze piece of the patient's mucosa, if you wear glove and try to remove it with the gauze piece, okay, that is going to be easily scrapable. So this is how you can differentiate between oral hairy leukoplakia and candidiasis. I hope everyone has answered it as OHL only, OHL, oral hairy leukoplakia. Okay, and were there any more questions? HHV8 and HSV1 were also there. Please remember HHV8 is associated with Kaposi sarcoma. HHV8 is associated with Kaposi sarcoma. Okay. Any other questions were asked? I was told that these were the questions which were actually asked in the examination. Yes, if anyone feels that any more question was asked, was there any question related to this question asked? So person undergoing treatment with nivolumab and itching and eczema, hive-like rashes, that is urticarial rashes were there, and upon histopathological analysis, blister beneath the outer skin layer is observed. DIF finding showed linear C3 and IgG along the basement membrane zone. What is the diagnosis? Was this question asked in the today's exam? Please put in the chat section, students. No, it's okay. It's okay, Khan. It's okay, Adiba Khan. Do not worry. Okay. Okay, this question was not asked. But students told me that some question related to immunofluorescence of bullous pemphigoid came in the today's exam. Maybe that was some other question. Okay, fine. Okay, so these were the dermatology questions which I got. If you feel any more questions were asked from dermatology, please put those questions in the comment section. I will read your comments, and we are going to make a new video after filtering out the question and the options properly. Okay. Okay.
Dr. Parineet sir is there.
Okay.
Yeah.
Okay. Okay, students. Now I'm handing over this lecture to our ENT sir, Dr. Pranit sir. Now we are going to discuss about the ENT recall questions. Thank you so much, friends, for your patient listening.
Yeah, thank you, sir.
Welcome. Very warm welcome, sir.
Very nice session.
Thank you, sir.
Yeah.
Please
Dear
take.
students, hope your ENT went well today. So still in the comment section, I can see Dharma questions were being asked. Right, fine. So shall we shift to ENT? So there was one question on otosclerosis in ENT. That is, a lady was presenting with bilateral hearing loss and it was more on right side, and it was decided to do stapedectomy after examination. So stapedectomy is done where? It is done in otosclerosis. So the condition is otosclerosis. So what is the tuning fork test finding in case of otosclerosis? That was the question asked, right? See, Rinne, Weber, right side, left side. So the patient is having bilateral hearing loss. So in case of otosclerosis, the type of hearing loss is conductive hearing loss. Why it is conductive hearing loss? If you take your ear, this is middle ear. So any pathology in the middle ear should cause conductive hearing loss. So in case of conductive hearing loss, Rinne will be negative on both sides. And see, one more clue is given. It is more on the right side. So if it is more on the right side, then Weber should lateralize towards the more worse side in case of conductive hearing loss. So this should be the findings, right? Okay. Yeah. So this is the finding. Rinne negative bilaterally and Weber's lateralizing towards the right side. So these are the tuning fork test findings in case of otosclerosis. I hope this is a very easy question, right? So we shall move on to the next one. Okay, if it is more on the left side, then the lateralization of the Weber will be towards the left side. It depends on the question. Right, done. Now, upsloping audiometry. Where do you see upsloping audiometry? This was the question asked, right? So an upsloping audiometry is seen in cases of early stages of Meniere's disease. Meniere's is also called as endolymphatic hydrops. I hope this was the option given in one of the 4 options, right? Endolymphatic hydrops, right? Am I right? Yeah. Semilunar option. What do you mean by that semilunar? Option was bilateral and Weber to right side. Yeah, that's what I'm saying. Yeah, manias, endolymphatic hydrops. You can see more amount of fluid, endolymph inside that causes bulge in the endolymphatic membrane. That is your membranous labyrinth. So in the early stages, you will get a upsloping, and the later stages, you can get a downsloping. Of course, downsloping is also seen in your presbycusis. Okay, that's the different thing. So the answer for this question is endolymphatic hydrops or Meniere's disease. Clear? Okay, tinnitus was in option. So one more question. There was a unilateral mass and occasional bleed, right? So unilateral mass projecting from one side nasal cavity, a strawberry-like and occasional bleeding episodes. That is typically of rhinosporidiosis. And here you can see the sporangium, okay? The sporangium having all the small endospores inside. So this chitinous wall will break down and these endospores will get released and they will infect this one, okay? Clear? Vertigo and tinnitus. Tinnitus was in option. I didn't get that actually. What are the options? Can you recollect? Options were about that Meniere's question. Fine. It's okay. Fine. Let it be. So once we get the clear questions and options, again, we will make a video and we'll put it in the app. So one more question, that is sinusitis in the left nasal cavity. You can see that is not, it won't be described as left nasal cavity, left-sided sinuses, paranasal sinuses it should be, and causing blurring of the left eye vision. You can see all the ethmoids getting complete left side ethmoids getting infected, and it is breaching the lamina and it is spreading into the orbital space, right? So it was spreading into the orbital space. So you can see a periorbital periosteal abscess over here. Okay, if there is a periosteal abscess, it should be the answer. Also, mild proptosis is also there. If you can see the level of the eyeballs, mild proptosis is also there. Okay. Yeah, this session will be not exactly this session with exact question and exact options. We'll be uploading later. Okay. Fine. Okay. Orbital cellulitis. Yes. Even in periosteal abscess or orbital cellulitis, if it has progressed to the orbital cellulitis, definitely you will be having visual blurring also, because the optic nerve running behind will be having will be under huge pressure compression. So that will cause blurring of the vision. And if you don't operate early, it will be causing, yeah, CT is showing towards right side, but the question is of the left side. Let it be. Yeah, you are getting the idea. So whichever side it is, I have got this image from in the group only. Okay. So sinusitis in nasal cavity. So whichever side nasal cavity, be it left or right. Okay. To that side, it will spread, right? If it is there on this side, this will spread towards this side. So obviously it will cause sinusitis with, first of all, it will cause periosteal abscess, and then it will spread and it will cause orbital cellulitis. And then though both of these will cause proptosis also, and both of these will cause your visual blurring also. The optic canal here will be very compressed and it can cause your visual blurring, right? Now, COVID-19 patient, history of steroid intake, nasal obstruction, complaining of nasal obstruction. Now, very clearly, it indicates a case of mucormycosis. Definitely, COVID-19 patient with history of corticosteroid intake. Definitely, it is a mucormycosis. No doubt about that. Okay. There was a question on middle ear relations. I think that middle ear question was on ossicles, I think. We'll come to it. So steroid intake. So definitely the patient is having now mucormycosis suffering. I think there was a pathology slide was given, right? And see how to identify the mucor between aspergillus and mucor. In aspergillus, you have a 45-degree branching and septate hyphae, right? In mucor, the aseptate hyphae will be there. Okay, if I'm not wrong, aseptate hyphae will be there in the mucor, in the pathological image, right? Okay, and obtuse angle will be there, right? More than acute angle, right? Okay. Now, coming to the type of joints, you have two types of joints in the middle ear. If you take the middle ear, in the middle ear, in between the malleus and incus, you have a joint that is incudomalleolar joint. And incudomalleolar is a saddle kind of joint. And you have another joint that is incus and stapes, incudostapedial joint. And this is of a ball and socket joint. Remember these points, okay? So if orbital cellulitis was given, that should be the answer. Fine. Yeah, in mucormycosis, bleeding history will be there. Definitely bleeding history. As there is mucosal erosions, completely, definitely bleeding will be there in the initial phases. Yes, mucor aseptate hyphae, right? Okay. So only in the middle ear, you will be having these two joints. Just remember, incudomalleolar. First, you will get the saddle joint, and then you will get a ball and socket joint, right? Okay. Okay. Already in anatomy also, sir has discussed this question, right? Okay. Now, yeah, there was a lot of confusion going on regarding this question. So there was a foreign body given. If, see, just try to know the anatomy. This is the hyoid bone, and see your epiglottis over here. This is the vallecula, and see here, your epiglottis is attached to your thyroid cartilage, and thyroid, below the thyroid, your cricoid will be lying, right? Isn't it? And the cricoid is a continuous ring, isn't it? The cricoid is a ring-like. So this is your cricoid area. So this area is the cricopharynx area. So in this area, okay, in this area, if the coin is there, you can identify laterally, that is a foreign body here. Okay, that will be a coin here. You should identify the area here. Okay, if this was the area given in your question, then it should be a foreign body. Okay. So be it button battery, whatever. Okay. If it is button battery shape will be like this. You all know that. Okay, it will be button battery, but a coin won't look like that, right? A coin will be looking like this. Clear? So heterogeneous opacity means should be battery only, no? Yeah, if heterogeneous opacity is not uniform everywhere, then it should be a battery. So whatever, see, whatever the question is given there, according this should be a coin and this should be a battery. Okay. So identify the anatomy first. So start from your hyoid. That will become easy for your anatomical orientation. Otherwise, you will get confused. So this is your hyoid, and see the epiglottis here, right? So epiglottis attaches to the thyroid cartilage. Below the thyroid, you will be having cricoid. So cricoid is a complete ring forming structure, right? So posteriorly, this is the cricoid area. Posteriorly, this is the cricopharynx area. So your foreign bodies most of the time stuck in this area, cricopharynx area, right? Okay. Yeah, if edges are looking serrated, it should be a button battery. So, and one more question from the inner ear was given about your inner hair cells and outer hair cells. So you all know inner hair cells are arranged in single row, and outer hair cells are arranged in multiple rows. And remember one point, your inner hair cells, the sensory input is carried, if that is afferent, sensory input is carried by your inner hair cell. The outer hair cells are motor. Okay, they get the motor supply, that is efferent. Motor supply will be towards the this one, your outer hair cells. Remember this point. Okay, so always remember this point, because whenever the sound comes, the outer hair cells will vibrate first. The motor movements of these outer hair cells are controlled by your cochlear nucleus. So right inside in the brainstem, cochlear nucleus will be lying. So from there, the motor output will be coming, and it will be modulating the vibrations of the outer hair cells. So outer hair cells will be having motor motor innervation, and inner hair cells will be having sensory innervation. So remember this point. Okay. Inner hair cells, sensory. Inner hair cells, sensory. There's no doubt about that. Inner hair cells, sensory. Outer hair cells, motor. Is it clear? So these are the few questions asked from your ENT side. Any more questions? You want me to discuss any more questions? IHC is responsible for basilar membrane movement. No, OHC. Even not even OHC, your fluid wave. Okay, traveling wave theory of von Bekesi. The fluid waves will vibrate the basilar membrane. Once the basilar membrane moves, so this is your basilar membrane. So once the basilar membrane moves, this is the basilar membrane. So when this complex vibrates, see the outer hair cells, then they will vibrate and they will rub against the tectorial membrane over here. Fine, done. So with this, we complete the ENT session now. If any of you recollect any more ENT with exact question and exact answer, please do
Yes,
share
sir.
me personally.
Great. Is my voice coming to everyone? Please let me know. Thank you. Yeah, hi. Good evening. Coming to everyone, please let me know. Thank you very much. I hope my voice is coming to everyone. So I will be quickly telling you the recall questions. Hello, everyone. I hope my voice is audible. So number one, very importantly, we had a question regarding the IMNCA guidelines. The question was regarding IMNCA guidelines, integrated management of neonatal and childhood illnesses. So you all know that fast breathing with or without chest indrawing is known as pneumonia. And if there are danger signs, that is known as severe pneumonia. The first question today we had was regarding IMNCA guidelines. And we all know fast breathing with or without chest indrawing is known as pneumonia. And in the MCQ, if there are danger signs, as in the child is not feeding well, having lethargy, seizure, or shock, that is severe pneumonia. Very importantly, for pneumonia, we all know we give the scaphoid abdomen. So I hope you all know that there was a question, a baby having distress with say scaphoid abdomen. Should we give a back end mask ventilation? Should we intubate the child? What should we do? So very, very important. We all know that scaphoid abdomen with distress in the baby, I think we are talking about congenital diaphragmatic hernia. And for congenital diaphragmatic hernia, that bag and mask ventilation or positive pressure ventilation is absolutely contraindicated. So in that case, we will intubate the child. So intubate the child would be a better answer in this case. Next, very importantly, there was a question regarding the perinatal asphyxia, the definition of perinatal asphyxia. The question was regarding that. Little tricky question the students were saying. So perinatal asphyxia depends on multiple levels. If the umbilical cord pH is less than 7, if the umbilical cord pH is less than 7, that is one thing for perinatal asphyxia, number one. Number two, very, very important, Apgar score. If Apgar score, very importantly, persistence of low Apgar score less than 3 for more than 5 minutes. Persistence of Apgar score less than 3 for more than 5 minutes. That is one component for what is called perinatal asphyxia. Or you can say Apgar 0 to 3 also at first minute of life. That is one definition for perinatal asphyxia. I'll repeat again. There was a short question today recall for perinatal asphyxia. Number one, umbilical cord pH. The baby's umbilical cord pH is less than 7. Or Apgar score, basically, it is less than 3 for more than 5 minutes, or the at birth asphyxia. And one more question my junior was saying regarding the meningitis. A baby was having Kernig sign, meningitis was suspected, CSF was done. So if that was the case, like in general, if we talk about tubercular meningitis, like normally the patient has meningitis with Kernig's positive. So Kernig's positive or Brudzinski positive, they are the signs of meningitis. And CSF was done. That was another question, like in the question it was given. So if you talk about tubercular meningitis, then we all know that we have low sugar, high protein, and lymphocyte. So those were the recall questions right now I'm able to remember out of it. And thank you so much, ma'am. I'm done. I hope we can give the thing to the next candidate. Thank you so much. Thank you.
Dr. Atul is just joining. We will take another 5 minutes to start. Dr. Govind sir will come. Thank you, sir. We can start.
मेरे से बात हो रही है?
हाँ जी, हाँ जी सर।
ओके, मुझे वो ऐड करने के लिए अलाउ कर दीजिए।
कर दिया सर।
Please wait. Screen. Let me find the screen first. Screen. Wait, please.
Can I help, sir?
I'm not able to find my
अच्छा, PPT.
PPT. कहाँ चला गया पता नहीं. Just a minute. Wait. Where is my PPT? मैं 2 मिनट में ज्वाइन करता हूँ ढूंढ के.
ठीक है सर.
Hello everyone. Am I audible?
Yes sir.
इसमें मेरे पास कमेंट्स कहाँ पे आएंगे?
So YouTube पे.
Oh, I have to open YouTube also. Wait. Hi everyone. Good, I have opened the YouTube. So we can start discussing. Guys, are you ready? Can we start the discussion? Hi Janvi, hi Kaushik, hi Champ. So first question, it is a child with type 1 diabetes mellitus, presents with acidosis and blood sugar of 400 milligram per deciliter. He was started on IV fluids. What is the further management? Was there a question like this? पारुल, फार्मा वाज नॉट डिफिकल्ट यार, मोस्ट ऑफ द क्वेश्चंस तो हमने ऑलरेडी कर ही रखे थे. चलो लेट्स डिस्कस द क्वेश्चंस. दिस वाज अ केस ऑफ डायबिटिक कीटोएसिडोसिस, ये क्वेश्चन था. वाज देयर अ क्वेश्चन? और ऑप्शंस यही थी: इंसुलिन आईवी इन्फ्यूजन, insulin stat dose followed by intravenous infusion, first 1 hour normal saline followed by infusion of insulin. मलिक फास्ट तो मैं तभी जाऊंगा ना अगर आप ऑप्शंस बताओगे यार. फोर्थ ऑप्शन, व्हाट वाज द फोर्थ ऑप्शन? फोर्थ ऑप्शन क्या था? एनीवन? स्टार्ट स्टैट इंसुलिन कंटीन्यूअस इन्फ्यूजन, ये तो है ही ऑप्शन में ना. स्टैट डोज फॉलोड बाय आईवी इन्फ्यूजन. Different options. Ananya, please try to give the options. Doses were also given. Okay, great. Parul, can you tell me what were the dose given? Can you please tell what was the dose given? Regular insulin subcutaneous with IV fluids, insulin stat and continuous. इसमें doses तो कोई भी नहीं बता रहा. So basically, I will tell you the treatment. What is the actual treatment? IV fluid we have to start immediately, and they have already started that in the question. The patient was started on IV fluids. Apart from that, what we need to do, we need to immediately give 1 stat dose of insulin. Insulin की stat dose होती है 0.1 unit per kg. ठीक है, 0.1 यूनिट पर केजी, मिलीग्राम नहीं, यूनिट. 0.1 यूनिट पर केजी ये स्टैट हमें देनी है आईवी डायरेक्ट. और उसके बाद उसी को, दैट मींस 0.1 यूनिट पर केजी को वी विल डिसॉल्व इन 500 ml ऑफ नॉर्मल सलाइन एंड देन वी विल स्टार्ट इट एज इन्फ्यूजन. ठीक है, सो दैट इज इंपॉर्टेंट. तो पर आर के हिसाब से तो 1 इज 0.1 यूनिट पर केजी स्टैट and immediately we will start 0.1 unit per r per kg. ठीक है, दो चीजें करेंगे, स्टैट इंसुलिन लगा देंगे, इन्फ्यूजन स्टार्ट कर देंगे. सो द राइट आंसर विल बी दिस: इंसुलिन स्टैट डोज फॉलोड बाय इंट्रावेनस इन्फ्यूजन. 0.1 यूनिट स्टैट पर केजी प्लस 0.1 यूनिट पर केजी पर आर. ओके, नो नीड टू स्टार्ट इंसुलिन, गिव आईवी फ्लूइड इंसुलिन. ओके, नो नीड टू स्टार्ट इंसुलिन गिवन आईवी फ्लूइड. अरे इंसुलिन फिर भी लिख दिया इसमें. One option was only IV fluids. Okay, only IV fluids. So among these, the best answer will be B here. ठीक है, 0.1 यूनिट के हिसाब से डोज है. ओके, चलिए नेक्स्ट क्वेश्चन. This is a repeat question. I hope everyone knows this. Which of the following organism is intrinsically resistant to the given drug? I hope this everyone knows. This is a repeat question. आंसर इज डी हेयर, कैंडिडा क्रूजियाई फ्लूकोनाजोल. ठीक है, ये रिपीट क्वेश्चन है, डायरेक्ट विद सेम ऑप्शंस. ऐसी क्वेश्चन आया था अराउंड 2-3 साल पहले. सो आंसर टू दिस क्वेश्चन इज दिस. आंसर टू दिस क्वेश्चन इज कैंडिडा क्रूजाई फ्लूकोनाजोल. ये रिपीट क्वेश्चन है. ओके, ऐसा कोई क्वेश्चन था? A patient on fluoxetine therapy was given another drug for pain control. After 2 weeks, he developed altered consciousness. Likely drug given. ग्लैब्रेटा वाला भी ऑप्शन है तो यार. नहीं, ग्लैब्रेटा कहाँ गया? सी में ग्लैब्रेटा लिखा हुआ था. ओके, ग्लैब्रेटा लिखो यार, ग्लैब्रेटा. ये क्यूटी प्रोलोंगेशन वाला इसी क्वेश्चन में था या इट वाज अ डिफरेंट क्वेश्चन? QT prolongation was in this question only or is with some other? Guys, please let me know. पेप्रिडीन था, पैथिडीन नहीं था. two questions on QT prolongation different. This question, sir. Operator was the other. QT prolongation was in this question. This only, sir. So I got two questions. One question like this and second question like this. So QT is in interval of 447 millisecond was given. So were they two different questions और एक ही क्वेश्चन था? इस क्वेश्चन में आई सीन पैथिडिन वाज इन दी ऑप्शन. तो अगर इसमें पैथिडिन ऑप्शन में था तो पैथिडिन शुड बी द आंसर. आई थिंक दे आर टॉकिंग अबाउट द सेरोटोनिन सिंड्रोम है. इसमें सेरोटोनिन सिंड्रोम की बात कर रहे हैं. सेकेंड क्वेश्चन वाज QT प्रोलॉन्गेशन, दैट शुड बी मिथाडोन. ठीक, अगर QT प्रोलॉन्गेशन और ये अलग अलग हैं या सेम है, जस्ट लेट मी नो दैट. देयर वाज ओनली वन क्वेश्चन. उसी क्वेश्चन में देयर वाज 400 QTC था. सेम क्वेश्चन. तो इसी में QTC वाज प्रोलॉन्ग. Okay. So if they are talking about only altered consciousness QT prolongation, so then answer should be methadone here. तो piperidine होगा फिर ये. They are not talking about serotonin syndrome here. ठीक है, तो इस क्वेश्चन को हम डिलीट कर देते हैं. तो मोस्ट लाइकली दिस इज द क्वेश्चन. सो आंसर शुड बी methadone, बट आई विल कंफर्म. एक बार क्वेश्चन को ठीक से बना के आई विल कंफर्म द आंसर. ओके, चलिए नेक्स्ट क्वेश्चन. Pethidine not in the option. So look good. So then serotonin syndrome is simply out. They do not want to ask serotonin syndrome. So they must be asking only about QT prolongation. And QT prolongation is most likely answer is methadone. But let me confirm this. Okay. Okay. Patient of mood disorder developed liver dysfunction. Which drug is likely to cause this? Was there the question? Please explain this question. ये वाला question. इसमें तो बेसिकली दे आर सिंपली आस्किंग विच ड्रग कैन कॉज QT प्रोलॉन्गेशन. तो दैट इज डायरेक्टली रेक्टिफाई क्वेश्चन. चलो, वाज देयर अ क्वेश्चन लाइक दिस? पेशेंट ऑफ मूड डिसऑर्डर डेवलप्ड लिवर डिसफंक्शन. ऐसा था कोई क्वेश्चन? यस. सो आई थिंक दिस इज द इजी वन. सो एवरीवन नोज वालप्रोट इज हेपेटोटॉक्सिक. हाँ शशि भाई, पता है मेरे को. डॉक्टर गोविंद वाला भी है. आई हैव रिटन दैट. ये क्वेश्चन था, जल्दी बताओ यार. सेम. अच्छा, डिस्कस हो. ये सेक्रेटरी में कौन सा डिस्कस हो गया? हाइपर अमोनीमिया इज विद लिवर डिस्फंक्शन ओनली ना. हाइपर अमोनीमिया कर देते हैं इसको. हाइपर अमोनीमिया. ठीक है, that is liver dysfunction only. So answer is this. So here the question, treatment of scrub typhus. I feel the answer should be only IV doxycycline. Okay, the primary treatment is IV doxycycline. It is combined with other drugs only if alone is not able to treat. Image of scrub typhus was given. Okay. Picture also given of the black chrysalis in scrub typhus, liver dysfunction with hyperammonemia. Okay. So it here image was given. Scrub typhus की image दी हुई थी. ठीक है. And then the treatment is asked. So answer will be only IV doxycycline, because doxycycline is first line. If the person is not responding to that, then we will go for the adding other drugs. ये बताओ भैया, ये क्वेश्चन था, इसके ऑप्शन सही है? प्रोपॉक्सिफेन भी था उसमें, प्रोपॉक्सिफेन है तो सही? टेल मी दिस. स्क्रब टाइफस एंड रेस्पिरेटरी प्रॉब्लम, ठीक है, एंड रेस्पिरेटरी प्रॉब्लम. I will make a complete question and then give the answers with them. Okay, so don't worry about answers. ये कोई क्वेश्चन बताओ यार, ऑप्शंस बता दो. Are all the options correct? ड्रग इनहिबिटिंग ATP बाइंडिंग कैसेट डोमेन ही था सिर्फ. As far as I know, answer should be verapamil, but I need to confirm this. ये confirm करना पड़ेगा. I will give you the confirmed answer. So tacrolimus is not ATP binding domain inhibitor. Verapamil should be the answer, but I need to confirm this. Okay, options correct हैं, good. So we'll check and let you know. This is the easy one. ये तो अपने वीडियो से डायरेक्ट क्वेश्चन है ना. संजना, मैकेनिज्म ऑफ एक्शन ऑफ वालप्रोट पे भी आएंगे. फर्स्ट आंसर दिस क्वेश्चन. Iron chelator used to prevent donorubicin induced cardiotoxicity. ये क्वेश्चन था, and the options were these only. ऑप्शन यही थे. वाइटली अनस्टेबल मोस्टली. ओके, वाइटली अनस्टेबल भी था, कोई बात नहीं. आई विल राइट एवरीथिंग. अनस्टेबल. Iron chelator used to prevent doxorubicin donorubicin induced cardiotoxicity. Were these the options? So it was a direct question. Yes sir, dexamethasone was in the option. अच्छा, हाइड्रोकॉर्टिसोन की जगह dexamethasone होगा. These were the options. Okay, ये तो डायरेक्ट क्वेश्चन है फ्रॉम आवर वीडियो. डेक्सराजोक्सेन आयरन चेलेटर है, यूज्ड फॉर डॉक्सोरुबिसिन डोनोसिबिन इंड्यूस्ड कार्डियोटॉक्सिसिटी. आयरन चेलेटर नहीं लिखा हुआ था. शुभम में सिंह नहीं लिखा हुआ था. प्लीज कंफर्म, लिखा हुआ था कि नहीं लिखा हुआ था? आयरन चेलेटर वाज नॉट मेंशन, नहीं लिखा था. पारुल इज आल्सो सेइंग, संजना इज सेइंग नॉट आयरन चेलेटर. ओके, ये यहाँ पे आयरन चेलेटर नहीं था. आयरन चेलेटर वाज अ डिफरेंट क्वेश्चन. ओके, राशिरी प्लीज स्क्रब टाइफस से आगे बढ़ो यार, बहुत आगे पहुंच गए हम. एटीपी बाइंडिंग कैसेट इफ्लक्स इनहिबिटर वाज आस्क्ड. ओके, वो तो एक ही बात है. एटीपी बाइंडिंग कैसेट इफ्लक्स, इसका काम ही इफ्लक्स होता है, तो क्वेश्चन इज सेम. ठीक है, आयरन चेलेटर मैंने हटा दिया. आयरन चेलेटर हटा दिया. आंसर विल स्टिल रिमेन डेक्सराजोक्सेन. आंसर विल स्टिल रिमेन डेक्सराजोक्सेन. ओके ओके, आयरन चेलेटर वाला क्वेश्चन आएगा अभी. चलो नेक्स्ट क्वेश्चन आते हैं. सिकल सेल अनीमिया, प्लीज टेल मी व्हाट इज द एग्जैक्ट क्वेश्चन. व्हाट इज द एग्जैक्ट क्वेश्चन इन सिकल सेल अनीमिया, प्लीज टेल मी. विक्रम भाई आएगा, टेंशन क्यों ले रहे हो यार, आएगा वो क्वेश्चन आयरन चिलेशन वाला. हियर टेल मी व्हाट इज द क्वेश्चन ऑन सिकल सेल अनीमिया. स्नेहा मैडम आएगा, आएगा, डोंट वरी, वो क्वेश्चन आएगा. आई हैव रिटन दैट क्वेश्चन. जो मैंने नहीं लिखा होगा आई विल टेल यू. टेल मी दिस क्वेश्चन सिकल सेल अनीमिया, इसमें क्या क्वेश्चन था, क्या ऑप्शंस थे? टू रिड्यूस hemolysis टू प्रिवेंट सिकल सेल एनीमिया। ये क्या है क्वेश्चन? ऑप्शन क्या, स्टेम क्या था? What prevents long-term complications of sickle cell anemia? Which of the following drug is used to prevent long-term complications of sickle cell anemia? ये क्वेश्चन था। Vascular crisis, to prevent vascular crisis in sickle cell anemia. Okay. ठीक है, यही था क्वेश्चन। नो स्टेम डायरेक्ट, स्टेम इसी को कहते हैं मैडम, नो स्टेम नहीं होता कुछ भी। पेन क्राइसिस एंड टू प्रिवेंट लॉन्ग टर्म कॉम्प्लिकेशन। ओके, पेनफुल वास्कुलर क्राइसिस कर देते हैं एंड कॉम्प्लिकेशंस, लॉन्ग टर्म कॉम्प्लिकेशंस। ठीक है, ऑप्शंस बताओ आप मुझे। टेल मी द ऑप्शंस। हाइड्रोक्सीयूरिया के अलावा व्हाट आर द ऑप्शंस, अदर ऑप्शंस? काफी बड़ा क्वेश्चन था। ओके, आई गॉट इट। फाइनली वो यही पूछ रहे थे सिकल सेल एनीमिया में कौन सी दवाई लॉन्ग टर्म के लिए यूज करेंगे, है ना? डिक्रीज ब्लड ट्रांसफ्यूजन भी होगा, बहुत कुछ होगा। ठीक है, गुड गुड। डिक्रीज ब्लड ट्रांसफ्यूजन, ठीक है। डिक्रीज दी वेसोक्लूसिव क्राइसिस, पेन क्राइसिस, डिक्रीज द नीड फॉर, ठीक है। ठीक है, ये सब हो गया। बट वर द अदर ऑप्शंस? एल ट्रोम्बोपैक इसी में ऑप्शन में था या दूसरे क्वेश्चन में था? एल ट्रोम्बोपैक तो एक और क्वेश्चन था, मिथोट्रेक्सेट, नीड फॉर बीटी लिख दिया भाई मैंने। वास्कुलर क्राइसिस के फीचर थे सर, ठीक है, वो आई गॉट इट। मिथियोनिन वाज वन ऑफ द ऑप्शंस, गुड। मिथियोनिन, और कोई ऑप्शन? मिथोट्रेक्सेट प्लस ल्यूकोवेरिन प्लस ल्यू, और बताइए। मिथियोनिन लिख दिया मैंने। एल ट्रोम्बोपैक इसमें था? हाँ सर, दो क्वेश्चन में था एल ट्रोम्बोपैक। अच्छा, ओके, एल ट्रोम्बोपैक वाज इन दिस क्वेश्चन आल्सो। एल ट्रोम्बोपैक, तो आंसर टू दिस इज हाइड्रोक्सीयूरिया, बिकॉज बाकी तो सिकल सेल एनीमिया में यूज ही नहीं करते। so the answer to this question will be hydroxyurea. PAG क्या है? What is PAG, शुभम? आंसर इज हाइड्रोक्सीयूरिया, नो अदर ड्रग इज यूज। हमने अपने उसमें ये डिस्कस किया था ना, ये वी ऑलरेडी डिस्कस दैट इन आवर मैराथन सेशन, INICET मैराथन में किया था डिस्कशन ना। तीन ही दवाइयां मैंने बताई थी आपको यूज्ड इन सिकल सेल एनीमिया। सो ओनली 3 ड्रग्स यूज्ड इन सिकल सेल एनीमिया, वॉक्सिलेटोर हो गया, हाइड्रोक्सीयूरिया हो गया और ग्लूटामिन हो गया। ठीक है, नथिंग एल्स नीड टू बी रिमेंबर्ड फॉर सिकल सेल एनीमिया। विक्रांत गोयल आएगा भाई थ्रोम्बोसाइटोपेनिया वाला, रुक जाओ। दिस वाज अनदर क्वेश्चन, डायरेक्ट क्वेश्चन। मीथोल्यूकोवरिन क्या होता है विश्वेश्वर? चलो, दिस वाज द डायरेक्ट क्वेश्चन, है ना? अगेन रिपीट क्वेश्चन, वी ऑलरेडी डिस्कस्ड, INICET मैराथन में भी हमने डिस्कस किया था। साइड इफेक्ट ऑफ एंटी ट्यूबरकुलर ड्रग्स पे क्वेश्चन आता ही आता है। सो विच एंटी ट्यूबरकुलर ड्रग कॉज हाइपोथायरॉयडिज्म? इसमें ऑप्शन आइसोनाइजिड भी था। पायराजिनामाइड था, आइसोनाइजिड था? पायराजिनामाइड वाला दूसरा क्वेश्चन था, आई थे। So answer to this question is ethionamide directly है, hepatotoxic है, sorry, hepatotoxic भी है and hypothyroidism भी करती है. Pyrazinamide was in the option. Okay, चलो pyrazinamide ले लो भाई. And I hope everyone knows कि pyrazinamide आंसर नहीं है इसमें, है ना? Pyrazinamide ऑप्शन में होगा, but that is not the answer. This only pyrazinamide था, ठीक है, था या नहीं था doesn't matter. Answer is not that. Answer is ethionamide. Okay. ऐसा कुछ क्वेश्चन था? ऑप्शंस देख लो प्लीज. आर दी ऑप्शंस करेक्ट? ऑप्शंस ठीक है कि नहीं? साइक्लोसिरिन तो यार कौशिक, साइक्लोसिरिन इज साइकोसिरिन, नाम में लिखा है साइकोसिस करती है. इट इज साइकोसिस कॉजिंग सिरिन. 6 mercaptopurine इज इन द ऑप्शन. किसकी जगह पे था गेमर? 5-ASA and 5-FU. ओके, 5-FU वाज इन प्लेस ऑफ विच? असांकी फुल फॉर्म लिखी थी. असांकी मींस, अच्छा 5-ASA की, ASA की फुल फॉर्म लिखी थी. mercaptopurine से सारी ऑप्शन चेंज हो गई है. तो 5 अमाइनो सैलिस से अब बन गया कुछ कुछ क्वेश्चन. नाउ द क्वेश्चन सीम्स राइट. ठीक है, आंसर विल बी 5 अमाइनो सैलिसिलिक एसिड. तो आसान बन गया क्वेश्चन. अर्लियर द क्वेश्चन वाज रिलेटिवली डिफिकल्ट, बट नाउ द क्वेश्चन बिकम्स इजियर, है ना? ये तो और भी आसान कर दिया आप लोगों ने. स्टेरॉइड को हटा दिया ऑप्शंस में से, सब कुछ करा दिया. 6 mercaptopurine कर दिया मैडम. So this become easier one. 5-ASA is drug of choice for ulcerative colitis. ASA mercaptopurine नहीं था फुल फॉर्म, 5-ASA था. चलो था नहीं था यार, क्या फर्क पड़ता है? ये छोटी बातें मत करो यार. 5-ASA लिखा था, 5 अमाइनो सैलिसिलिक एसिड लिखा था, बात एक ही है ना? ब्यूडेसोनाइड था तो भी फर्क नहीं पड़ता. आंसर विल बी 5-ASA. ब्यूडेसोनाइड इज इनहेलेशनल स्टेरॉइड. तो दूसरा स्टेरॉइड लिखते तो शायद हम कंफ्यूज होते. ओके, तो डू नॉट गेट कंफ्यूज विद ब्यूडेसोनाइड. अगर आपको डालना है ब्यूडेसोनाइड, इसकी जगह डाल देता हूँ, बिकॉज नो वन हैज सेड अबाउट दिस. ब्यूडेसोनाइड ले लो. ओके, था या नहीं था फर्क नहीं पड़ता, डजंट मैटर. आंसर इज ए राइट. यस, 5 अमाइनो सैलिसिलिक एसिड इज द आंसर. हाँ, ये तो इजी था बिल्कुल ही अनन्य. चलो, ये क्वेश्चन था मैकेनिज्म ऑफ एक्शन ऑफ एजिट्रियोनम. ओके, मोहित कर दिया ब्यूडेसोनाइड, ऑप्शन में कर दिया मैंने. mechanism of action of erythritol. Was there a question like this? Patient was stable also maintained. Okay, patient stable कर देते हैं इसको. Patient stable. Patient stable. Okay. Some were saying no, ऐसा क्वेश्चन नहीं था. कुछ कह रहे हैं था. सर मैच भी देखना है प्लीज हरी. मुझे भी देखना है मैच अनन्या, आप भी जल्दी जल्दी करो, मुझे आंसर बताओ जल्दी जल्दी. एजिट्रियोन डेप्टोमाइसिन वाज आल्सो. मैच दी इनकरेक्ट था ये. अच्छा वो अच्छा अच्छा, तुमने मैच वाले क्वेश्चन में है ये एजिट्रियोनम का. ओके, सो वी हैव दैट क्वेश्चन, हम बाद में चलेंगे, ठीक है ना? मैचिंग वाले में विल गो टू दैट लेटर ऑन. सो दिस वाज द क्वेश्चन. टायरोसिन काइनेज इनहिबिटर यूज्ड इन आइसोलेटेड थ्रोम्बोसाइटोपेनिया. ऐसा कुछ क्वेश्चन था. डेप्टोलिनेजोलाइड पेनिसिलिन, हाँ वो आएगा भाई। Now tell me the right question. I don't think the question is right. टायरोसिन काइनेज इनहिबिटर था ऑप्शन में। ऑपरेल वेकिन भी था, फिर क्या नहीं था? लिनेजोलाइड वाला आएगा मयंक, वो आएगा। दैट्स व्हाई आई स्टॉप्ड हियर, वो आएगा। डार्सन, अंशुल, ये सब आएगा, डोंट वरी। फास्टोमेटिनिब, आई थिंक ये वाला गड़बड़ होगा तुम्हारा, फोस्टामेटिनिब होगा। दिस मस्ट बी द ऑप्शन। A patient present with purpura, okay, present with purpura, purpura and diagnosed as isolated ये क्वेश्चन सही है। अब फॉस्टामेसाविर नहीं था, उसके जगह फॉस्टामेटिनिब होगा, है ना। And at the last diagnosis of isolated TCP was given. Okay, great. ऑपरेल वेकिन was in the option. कोई बात नहीं भैया, खुश हो जाओ, ऑपरेल वेकिन लिख देते हैं ऑप्शन में। किसकी जगह लिखूं? ऑपरेल वेकिन इसकी जगह लिख देता हूं लो, ऑपरेल वेकिन। ऑपरेल वेकिन कैन नॉट बी द आंसर। रीड द क्वेश्चन केयरफुली। मैंने आपको क्या बताया था, बिल्कुल ध्यान में रखना। क्वेश्चन इज विच इज टायरोसिन काइनेज इनहिबिटर्स। अगर आपने मेरा लेक्चर सुना है तो आई वाज टेलिंग यू दैट टायरोसिन काइनेज इनहिबिटर आर द ड्रग्स हुज नेम एंड विद निब। जिसका नाम निब में खत्म होता है वही टायरोसिन काइनेज इनहिबिटर है। सो दैट वाज द क्वेश्चन, विच ऑफ द फॉलोइंग ड्रग नेम एंड्स विद निब। ठीक है, तो आंसर विल बी फॉस्टामेटिनिब हियर। इट इज अ स्प्लीन टायरोसिन काइनेज इनहिबिटर। ये न्यू ड्रग है, रोमिप्लोस्टिम नहीं था, कोई फर्क नहीं पड़ता। ठीक है, आंसर इज फॉस्टामेटिनिब। एल्ट्रम्बोपिक है नहीं था, कोई फर्क नहीं पड़ता। ठीक है, द क्वेश्चन आस्क्ड वाज विच ड्रग एंड्स विद निब। सटुनिब, बोसुटिनिब होगा, कोई बात नहीं, बोसुटिनिब होगा। बोसुटिनिब इज फॉर लंग कैंसर। बाइंड टू प्रोटीन्स पढ़ा था ना हमने, जो मेरे एंटी कैंसर ड्रग वाले लेक्चर में टायरोसिन काइनेज इनहिबिटर हमने पढ़े हैं। एट दैट टाइम आई टोल्ड यू द ड्रग्स यूज्ड इन लंग कैंसर आर बाइंड प्रोटीन्स। पढ़ा था ना, बाइंड, BIND, बाइंड। उसमें बोसुटिनिब सबसे पहली दवाई थी, है ना। तो बोसुटिनिब इज यूज्ड इन लंग कैंसर। फॉस्टामेटिनिब इज अ न्यू ड्रग विच इज यूज्ड फॉर आइसोलेटेड थ्रोम्बोसाइटोपेनिया। ठीक है, एल ट्रोम्बोपैक नहीं है आंसर। ओके, रीड क्वेश्चन केयरफुली। टायरोसिन काइनेज इनहिबिटर पूछा है, टायरोसिन काइनेज इनहिबिटर पूछा है। They have not asked which is used in thrombocytopenia. दो निब कर दिए मैंने भाई, फॉस्टामेटिनिब और बोसुटिनिब। बोसुटिनिब was in the option but that is used for lung cancer. Okay, चलिए नेक्स्ट पे आते हैं। This is a repeat question. I hope no one has any problem in this. Repeat question है। हाँ, बोसुट, sorry, not lung cancer, it is CML. Sorry. Sneha, thanks for correction. It is for CML. Thanks for correction. Bind protein is for CML. चलिए नेक्स्ट पे आते हैं। दिस क्वेश्चन इज रिपीट क्वेश्चन। आई होप नो वन हैज प्रॉब्लम विद दिस। डायरेक्ट रिपीट क्वेश्चन था, ये हमने पढ़ा भी था, अपने सारे सेशंस में पढ़ा है, हमारे लेक्चर्स में भी पढ़ा है, हमारे मिशन वाले में भी पढ़ा है, और हमारा यूनिवर्सिटी बूस्टर था उसमें भी पढ़ा है. दिस वाज रिपीट क्वेश्चन, देयर इज नो प्रॉब्लम इन दैट. आई होप एवरीवन गॉट इट राइट. जीजीटी रेज्ड इन ऑप्शन. ओके, हेपेटाइटिस की जगह जीजीटी रेज्ड होगा यार. जीजीटी रेज्ड. मोहन मैडम, मोहन भाई, ऑपरल वेकिन ऑप्शन में है बट आंसर नहीं है. ओके, चलिए नेक्स्ट क्वेश्चन. मैकेनिज्म ऑफ एक्शन सोडियम वालप्रोएट. गिव मी द ऑप्शंस प्लीज. Mechanism of action of sodium valproate. Please give me the options. I have come to next question, gamer. नहीं, किस तरह के था इमेज में? वही दिया होगा ना, सोडियम चैनल, पोटेशियम चैनल, कहीं किसी चैनल्स पे होगा ना. आई गॉट इट वाज इमेज, बट विच टाइप ऑफ इमेज इट वाज? वही वही ना, गेट वन, गेट, ये सब होगा ना. सो देयर वाज सम सोडियम चैनल ब्लॉकर, सोडियम चैनल की जगह पे होगा. इमेज बेस्ड था, डायग्राम वाज देयर. गाबा, गाबा एंड सक्सिनिक गेट. सर ओनली गाबा एक्शन परचेज था, इमेज फॉर्म. चलो, जस्ट लेट मी नो वेदर इट वाज ऑल एक्सेप्ट और व्हाट इज द मैकेनिज्म, दैट वाज द क्वेश्चन. ये बता दो मुझे बस. गाबा सिंथेसिस के एंजाइम इनहिबिट करता है. यस, नो. गेट वन था. एक्सेप्ट पूछा था या नहीं पूछा था? एक्सेप्ट पूछा था कि नहीं पूछा था, ये बता दो. सोडियम चैनल मेंशन नहीं था. गॉट इट. ओनली वन इज करेक्ट मैकेनिज्म. ठीक है, करेक्ट मैकेनिज्म पूछा था तो इट इनहिबिट द फॉर्मेशन ऑफ गाबा. ये गाबा की फॉर्मेशन के एंजाइम्स को इनहिबिट करता है. ठीक है, एक्सेप्ट नहीं था. चलो ठीक है. इट इनहिबिट द फॉर्मेशन ऑफ गाबा. गाबा की फॉर्मेशन में जो एंजाइम्स इन्वॉल्व हैं वहां पे इनहिबिट करता है. दैट विल बी द आंसर. तो आई विल फाइंड द इमेज एंड आई विल ऐड एंड लेट यू नो. गॉट इट. चलिए नेक्स्ट. टीसीए पॉइजनिंग, डायरेक्ट क्वेश्चन. 10 बार 100 बार बोला था मैंने, एंटीकोलिनर्जिक एक्शन है तो देयर विल बी नो हाइपोथर्मिया. इट विल ऑलवेज बी हाइपरथर्मिया. गैट वन आंसर नहीं होगा ना यार इसका. गैट वन आंसर वाज फॉर टियागाबेन. गाबा के अलग अलग. गॉट इट, गॉट इट. आई विल मेक द क्वेश्चन एंड पोस्ट यू. नाउ टेल मी दिस. रिपीट क्वेश्चन, नो प्रॉब्लम इन दिस. एंड एवरीवन रेडी विद आंसर? इसमें तो कोई दिक्कत नहीं है ना किसी को? नो प्रॉब्लम. आई टोल्ड यू सेवरल टाइम, एंटीकोलिनर्जिक पॉइजनिंग में हाइपोथर्मिया नहीं होगा. इट इज हाइपरथर्मिया ओनली. वालप्रोएट सोडियम चैनल पे भी होता है एंड गाबा की फॉर्मेशन को भी रोकता है, बट गेट वन को नहीं रोकता. गेट वन को नहीं रोकता. ओके, चलिए नेक्स्ट क्वेश्चन. ये क्वेश्चन था, प्लीज टेल मी. ये क्वेश्चन था. Was this the question, same question? Yes. So you need to remember one extra point. Rivastigmine, it is available as transdermal patch also. Yes, hard questions हैं. So rivastigmine is available as transdermal patch also. Okay. Okay. भाई एंटीकोलिनर्जिक क्या तो पिपुलरी डायलेशन तो होगा ना। मैं इसलिए आपको बोलता हूँ कि ज्यादा दिमाग नहीं लगाना होता। आई टोल्ड यू टीसीए पॉइजनिंग में, एंटीकोलिनर्जिक पॉइजनिंग में हाइपोथर्मिया आंसर नहीं होगा। ठीक है, तो हाइपोथर्मिया ही ऑप्शन आता है हमेशा हमेशा। मैंने ये क्लास में भी बताया था, बाकी सिम्टम याद करने हैं कर लो, नहीं करने मत करो, हाइपोथर्मिया नहीं होगा उसमें, ये ध्यान रखना है। एंटीकोलिनर्जिक स्ट्रेस, हाँ सेम थिंग। ठीक है, एस्टाइलकोलिन एस्ट्रेस इनहिबिटर पूछा है तो 3 आर एस्टाइलकोलिन एस्ट्रेस इनहिबिटर, out of that rivastigmine can be given by transdermal patch. नॉन कंप्लायंस लिख तो दिया यार, रिफ्यूज टू टेक ओरल ड्रग्स। मेमेंटेन तो एस्टाइलकोलिन एस्ट्रेस इनहिबिटर है ही नहीं। ओके, चलिए नेक्स्ट चलते हैं। डिमेंशिया वाज द क्वेश्चन एंड डिडंट मेंशन एज अदर यूज्ड इन। इजियर रूट लिखा हो, कुछ और रूट लिखा होगा ना, ओरल लेने से मना कर दिया तो अल्टरनेटिव यही बचता है। ओके, so do not unnecessarily complicate the questions. Now this was the easy one. All of the following drugs are used for treatment of heavy metal toxicity except. Was the question same, option same? Was the question same, option same? Okay, which acetylcholine esterase is used हमने मान लिया। सिर्फ ऑक्साइम लिखा था, पैरेलेट ऑक्साइम नहीं था। माइल्ड टू मॉडरेट डिमेंशिया वाज मेंशन, गुड। ठीक है, अल्जाइमर डिजीज की जगह माइल्ड टू मॉडरेट डिमेंशिया कर दूंगा, तब आपको ठीक लगेगा। माइल्ड टू मॉडरेट डिमेंशिया। ओके, अब खुश हो? आई होप नाउ यू आर हैप्पी। तो आंसर इज ऑक्साइम्स। Yes sir, just oxime. Good. Chalo, it's good to go. Let's go to next question. Was the question like this? Okay. A patient presents to emergency with some symptom दिए होंगे कुछ। Kaushik, only thing you need to remember is rivastigmine can be given by transdermal route also, because the patient refused to take the drug orally. So other two are automatically out because they can be given only orally. Rivastigmine can be given by transdermal route also. So this is the easy question. I think ये question यही था। Which drug could be life saving? कह दो, same, it was the same thing. Waiting treatment for rheumatoid arthritis. Okay, rheumatoid arthritis. Okay, sodium was 139. Okay, sodium was 139. Okay, hyperkalemia, hyponatremia, dehydration, hypotension. Okay, dehydration, hypotension was also there. Dehydration, hypotension. HP एक्सिस सप्रेशन है, इसमें किसी को डाउट तो नहीं है? 90/40. I hope no one has problem. It is a adrenal suppression. HP एक्सिस सप्रेशन हो गया तो हमें स्टेरॉइड को रिप्लेस करना पड़ेगा। लाइफ सेविंग ड्रग पूछा है तो लाइफ सेविंग ऐड कर देंगे हम, तो आंसर विल बी स्टेरॉइड्स ओनली। ओके, आंसर विल बी स्टेरॉइड। ओके, चलते हैं आगे। चलिए नेक्स्ट। इसमें कोई क्वेश्चन था ऐसा? पोटाशियम 6, कोई बात नहीं, 6 कर लो यार। पोटाशियम लेवल को 6 कर दो, बच्चे खुश हो जाएंगे। 7 की जगह 6 कर दो। नाउ हैप्पी? मेटाबॉलिक एसिडोसिस भी था। चलो ओके, वी विल डू दैट। चलो कम टू दिस क्वेश्चन। Antiretroviral drug side effects like mental status, 4 NAVIRs were given. So what was the question? हीमोफीलिया का पेशेंट था ये प्रोटीज वाला। क्वेश्चन क्या था? व्हाट वाज द क्वेश्चन? ऑप्शन ठीक है, रिटोनाविर लोपिनाविर ठीक है, बट व्हाट वाज द क्वेश्चन? क्या पूछा क्वेश्चन? दारुनाविर लोपिनाविर सब ठीक है, बट व्हाट वाज द क्वेश्चन गाइस? अब भैया क्वेश्चन तो बता दो। लोपिनाविर, रिटोनाविर, दारुनाविर, लो सब लिख दिए मैंने। अब आप क्वेश्चन बता दोगे? अब हीमोफीलिया का पेशेंट था, उसने एआरटी लिया और उसको एएमएस हो गया। एएमएस इंट्राक्रेनियल हेमरेज हो गया। हीमोफीलिया पेशेंट took antiretroviral drug and developed altered mental status। altered mental status हो गया। जितना ही क्वेश्चन था। drug response, depressed patient, fluoxetine plus opioid, few days later presents with OPD for patient came to OPD with AMS, history of ARTU, which is the side effect। ये मैं चेक करना पड़ेगा। आई नीड टू चेक अल्टर्ड मेंटल स्टेटस। आई होप लोपिनाविर ही करता है, बट आई नीड टू चेक। टिप्रानाविर इज अनदर ऑप्शन। टिप्रानाविर, so we'll check and let you know। altered sensorium है, I will check the answer and let you know। चल नेक्स्ट पे चलते हैं। इसका मुझे ये बताओ, ऑप्शंस आर राइट? पीसीएम की जगह एस्टामाइनोफेन, दैट इज द सेम थिंग। so the best answer among these seem to be aspirin, because propranolol तो देते ही हैं, आयोडाइड्स देते ही हैं, ठीक है। एस्टामाइनोफेन इफ फीवर इज देयर तो फीवर के लिए दे देंगे, तो आई डोंट थिंक एस्पिरिन हैज एनी रोल इन थायराइड स्टॉर्म। वन ऑप्शनल लूगोल्स आयोडीन, आयोडीन की जगह लूगोल्स आयोडीन होगा यार, और क्या? लूगोल्स आयोडीन। पीसीएम नहीं था, एसिटामाइनोफेन कर दिया मैंने। लूगोल्स आयोडीन, सो आंसर सीम टू बी एस्पिरिन। एस्पिरिन होगा इसका मोस्ट लाइकली आंसर। ओके, acetaminophen can be used in fever, although acetaminophen is also not commonly used, but among these the best answers seem to be aspirin। चलिए, ये मैंने आपको क्लास में बार बार कराया था, मिशन नीट पीजी में भी। हाइपरथायरॉइड क्राइसिस, एस्पिरिन, एस्पिरिन, लोकोजारिन, हाँ ये सेम क्वेश्चन है। दिस क्वेश्चन आई टोल्ड यू इन द क्लास सेवरल टाइम्स, ठीक है, अपने मिशन वाले में भी बताया था मैंने आपको INICET बूस्टर में भी बताया था, है ना। आई टोल्ड यू दिस क्वेश्चन सेवरल टाइम्स के SGLT2 inhibitors are now separately approved for treatment of CHF apart from use in diabetes. अब ये डायबिटीज के अलावा, irrespective of diabetes, whether the person is non-diabetic, still they have been approved for treatment of congestive heart failure. Champ acetaminophen is not commonly used, but many patients of thyroid storm develop fever. तो उस फीवर के लिए दे सकते हैं, है ना। ग्लिफ्लोजिन कोई और था, मेरे ख्याल से तो एम्पाई ग्लिफ्लोजिन था, रिसेंटली तो ये अप्रूव हुआ है, यही था। सेम क्वेश्चन एंड ऑप्शन होगा। मैंने आपको ग्लिफ्लोजिन के बारे में बताया था ना, आपको मिशन वाले में भी बताया था, INICET बूस्टर में भी बताया था कि CHF में सेपरेटली अप्रूव हुआ है ग्लिफ्लोजिन। वेरी गुड, OPD अटेंड करने का ये फायदा होता है शशि। ओके, चलो नेक्स्ट क्वेश्चन पे चलते हैं। क्रेटिनिन वाज 9 मिलीग्राम पर डेसीलीटर, किसका भाई, इस वाले क्वेश्चन में? हाँ, लो यूरिन आउटपुट में दे सकते हैं यार। इट विल कॉज इनहिबिशन ऑफ सोडियम SGLT2, तो सोडियम एंड वाटर एक्सक्रीशन इंक्रीजेस। यूरिक एसिड लेवल वाज गिवन एज 10। ओके, रुक जाइए, पास 10। ठीक है, 0.9 क्रेटिनिन तो नॉर्मल होता है यार। क्रेटिनिन एंड यूरिक एसिड, अरे क्रेटिनिन 0.9 तो ऑलमोस्ट नॉर्मल है। सीरम क्रेटिनिन इज 0.9। ठीक है, आर यू ओके विद दिस क्वेश्चन नाउ? Option B also had left KFT monitoring, and option D had stopped till labs normal. Okay, still ठीक है। ऑप्शन और में क्या बोला था? ऑप्शन B also had LFT KFT monitoring. Okay, ठीक है। सो आई थिंक हाँ, बाकी सब कुछ तो नॉर्मल है। क्रेटिनिन वाज नॉर्मल फॉर दिस पेशेंट, हिस्ट्री ऑफ rheumatic was mentioned. So what's the answer? I think answer should be stop pyrazinamide and replace it with some other drug and continue rest. ठीक है, तो यूरिक एसिड 10 हो गया है, pyrazinamide बंद कर सकते हैं, ठीक है, बट आई विल कंफर्म। जॉइंट पेन भी था, ओके। अगर हाँ एसिम्प्टोमेटिक होता फिर तो बंद करने की जरूरत नहीं है। जॉइंट पेन भी, आई विल कंफर्म द आंसर, ठीक है ना। Two similar question came. I think data being mixed up by us. Option A also had monitoring. Okay, KFT monitoring. चलो आई विल गेट द एग्जैक्ट क्वेश्चन एंड देन गिव यू द आंसर. इसको छोड़ते हैं. चलो नेक्स्ट क्वेश्चन देखो. Shashi Bhushan, question was not for diabetes, question was for congestive heart failure. Okay, the question was which drug is recently approved for CHF. ये question था. Okay, the question was not for CKD and diabetes, question was which is approved for congestive heart failure. Just stop ATT and start again when parameters normal was one option. Okay, stop all ATT till levels are normal. हाँ ये लिखा तो है. B भी हो सकता है, but it will, if the patient is symptomatic, then it become little difficult. ये लो. ऑप्शन वाज कार्बेडिलॉल था. ओके, मेटोप्रोलोल की जगह कार्बेडिलॉल था. कार्बेडिलॉल. और बताओ. देयर इज कैप्टोप्रिल. कैप्टोप्रिल भी था. ओके, किसकी जगह था कैप्टोप्रिल? कार्बेडिलॉल आई हैव डन. कैप्टोप्रिल किसकी जगह था? अम्लोडिपिन की जगह था कैप्टोप्रिल. क्वेश्चन में कुछ और था. पर्सन हैज डिस्नी ऑन एक्सर्शन, कार्डियोमेगाली. No amlodipine. ठीक हो. If both are option, ideally answer both of them. Both of them can reduce the progression. But अगर हमें एक चूज करना तो the best will be captopril. Obviously AC inhibitors will be preferred. Digoxin नहीं था. Furosemide amlodipine की जगह, place amlodipine की जगह captopril कर दिया वो मैंने. Okay. Ideally both can reduce the mortality. Both can reduce the disease progression. ठीक है. AC inhibitors भी, beta blockers भी. And if both are given in the option, we will prefer AC inhibitors. Pedal edema was there. Okay, basically CHF confirm कर रहे हैं. Pedal edema भी था. So if both are given in the option, the preferred answer should be AC inhibitors. Exertional and nocturnal dyspnea. Okay, ठीक है. Pedal edema and gallop rhythm भी था. ठीक है. ठीक है. एस्थमा भी था क्या इस पेशेंट को? Artha Clay saying asthma was also there. Why not A? अगर आपने लेक्चर सुने होते, you would not have asked this question. Why not A? Remember, only those drugs will decrease mortality or decrease disease progression which stop the renin-angiotensin pathway. That's why furosemide is not the answer. Okay? Read the question carefully. क्या question पूछा है? Which drug can be used to prevent the progression of the disease? Progression of the disease, mortality is reduced by drugs inhibiting renin-angiotensin pathway which decrease left ventricular hypertrophy. Okay? Asthmatic भी था क्या ये patient? मैं बता रहा हूं दोनों यूज कर सकते हैं, बट आउट ऑफ द टू प्रेफर्ड विल बी कैप्टोप्रिल. मोहन राज, मैं आपको अभी भी बता रहा हूं कि द क्वेश्चन इज नॉट आस्क्ड अबाउट अक्यूट सिम्टम्स. क्वेश्चन इज आस्क्ड व्हिच ड्रग कैन डिक्रीज प्रिवेंट द प्रोग्रेशन ऑफ द डिजीज. प्रोग्रेशन ऑफ द डिजीज. रीड द क्वेश्चन केयरफुली. कार्बेडिलॉल भी हो सकता है, बट आउट ऑफ द टू प्रेफर्ड इज कैप्टोप्रिल. ठीक है ना. आउट ऑफ द टू ऑलवेज प्रेफर्ड आर एसी इनहिबिटर्स और एआरबीज. ठीक है. बीटा ब्लॉकर्स कैन बी यूज्ड, बट अगर एसी इनहिबिटर से कंट्रोल ना हो तो बीटा ब्लॉकर्स ऐड करते हैं. ओके. हाँ. ओके, चलिए नेक्स्ट क्वेश्चन. हाँ, इसमें ये वाले में था ना, वो आप क्वेश्चन कर रहे थे. व्हिच द फॉलोइंग इज फॉल्स रिगार्डिंग द मैकेनिज्म ऑफ एक्शन. So here you were saying the question was also on agtrionum, huh? साहिल, आई एब्सोल्युटली एग्री विद यू कि कार्बेडिलॉल के एडिशनल एक्शंस भी होते हैं, बट Carvedilol you cannot start directly. It is started in very low dose and gradually the dose should be increased. Okay. Azithromycin क्या option था? Inhibit cell wall synthesis. Daptomycin cause depolarization of membranes. ठीक था? DNA dependent RNA polymerase inhibitor. Azithromycin cell wall. ठीक है. So I made the question correct. So answer is linezolide. We discussed several times. ये भी अपने मेन में डिस्कस किया था हमने कि linezolide जो है या कोई भी drug, whichever drug inhibit protein synthesis, they inhibit bind to 50S. Only two drugs inhibit 30S, bind to 30S. One is A and second is T, aminoglycoside tetracycline. Rifampicin inhibit DNA dependent RNA polymerase, linezolide वाला daptomycin inhibit cell membrane, azithromycin से बिल्कुल सही कर दिया मैंने, है ना? I have made absolutely good question. Linezolide is the answer, okay? Linezolide is the answer. ये सारे मैकेनिज्म मैंने आपको INICET बूस्टर में भी कराए थे. 15 मिनट का एंटीमाइक्रोबियल था, उसमें ये सारे करवाए थे, ओके? चलिए नेक्स्ट क्वेश्चन. ये क्वेश्चन सही है? इसमें कुछ और था क्वेश्चन में? नैनोग्राम पर या माइक्रोग्राम पर लीटर की बात है. हाँ, फर्स्ट लेट मी नो यार, ये इसमें ये क्वेश्चन सही है कि नहीं है? वाज दिस द एग्जैक्ट क्वेश्चन या कुछ और भी था इसमें? So I think forensic people, Dr. Atul will tell better regarding this. As far as I know, in children it should be above 1000 nanogram per liter, but इसमें maximum 500 है तो
sorry.
Hello. Hi sir.
Yeah, Dr. Garg, Atul this side. Good evening. You were saying something. I missed something. You said something forensic, but I don't know what exactly you were discussing.
I said, sir, this question will be discussed by you because at what level we will should start desferrioxamine in iron poisoning.
Oh, I was not knowing that. I did not get this question actually.
Okay. कोई बात नहीं सर, मैं आपको बाद में दे दूंगा.
ठीक.
So as far as I know, it should be above 1000. बट 1000 तो ऑप्शन में है ही नहीं, तो हाईएस्ट वाला 500 आई विल चूज. 500 वाला मैं चूज करूंगा. सो आई विल स्किप दिस, हम बाद में डिस्कस कर लेंगे. ओके. आई थिंक दिस वाज नॉट सेपरेट क्वेश्चन. ऐसा कुछ क्वेश्चन था? हाइपर कैलीमिया के लिए व्हाट इज लाइफ सेविंग ड्रग नहीं था ना? लाइफ सेविंग वाज ओनली विद एड्रिनल सप्रेशन वाला ना? ये नहीं था ना क्वेश्चन कुछ भी? लाइफ सेविंग वाज ओनली द क्वेश्चन व्हिच वाज ऑफ एड्रिनल सप्रेशन, है ना? तो आई एम डिलीटिंग दिस. ओके. चलिए, दिस क्वेश्चन यू मस्ट हैव डिस्कस्ड इन साइकेट्री. आई थिंक आई विल स्किप दिस क्वेश्चन. ECG रिलेटेड क्वेश्चन था, दैट विल बी कवर्ड बाय मेडिसिन पीपल. ठीक है. ECG वाला that will be covered in medicine. Okay. So I think this must be discussed in psychiatry. I will leave this question. Okay, chaliye. So these were the question I got. Now, if you have any other questions, please add. Please add the questions if you have any more. कोई question मैंने miss कर दिया हो तो. Did I miss any question? So I will correct this question, rectify the question, make proper questions with proper answer, and then I will post. Okay. लिथियम वाला सेक्रेटरी सर विल कवर. ओके, आई थिंक कर ही लिया होगा उन्होंने.
Dr. Atul sir can start, sir, then if.
Thank you guys. Thank you very much. And Atul sir, please come. Thank you guys. Bye bye. फिर मिलते हैं.
Hello. Thank you, sir. Thank you, Dr. Garg.
Bye, sir.
Hello. So I'm just sharing my screen. I have got around 12 questions I was able to get. Let me just share that. Is my screen visible? Hello?
Yes,
Hello?
sir. Yes,
Is my
sir. Visible. Yes.
Okay. So the first question was, which of the following is not seen in a road traffic accident? Are the choices correct? Because I have just got this recall from different students. Chop wound, contusion, abrasion, laceration. But anyhow, the answer, if chop wound was in the choice, the answer will definitely be chop wound, because chop wound occurs by heavy cutting weapons like axe, which causes deep gaping wounds. In road traffic accident, due to friction by the ground, there can be blunt force. There will be blunt force injuries like contusion, abrasion, laceration. All these are blunt force injuries which can occur in road traffic accidents, but not the chop wound. Is this question clear or not? Are you writing on the chat box? Mukta, are they writing on the chat box?
So you have to check it on YouTube also, because the remarks are coming from YouTube.
Oh, okay.
Ah.
So I'm not sure, but okay. Then another question was that in 18th century, East India Company was smuggling which of the following from to China? This was a very unusual question asked, but anyhow, since it was asked, the answer is opium. It was smuggled to exchange the tea and the silk from China. A very strange kind of question asked. This cannabis, magic mushroom, and cocaine are not the answer. I believe these were the choices. Magic mushroom is mostly found in North and South America. So opium was grown in India and smuggled to China, and return tea and silk was taken up. Then a patient came to casualty with meiosis, which is the most likely poisoning. So here, I think it's very clear. Cocaine, amphetamine, both are sympathomimetics. So they cause pupillary dilatation. Datura is anticholinergic. So that also causes pupillary dilatation. So they are all causing mydriasis, whereas opium is a CNS depressant, which typically causes pinpoint pupils. So pinpointed pupils are typically found with the CNS depressants and cholinergics. Especially the pinpoint pupil is a feature of opiums and organophosphate poisoning. So this was a straightforward question, I believe. Then this kind of question is repeatedly coming in INICET on how to manage a case, a clinical examination approach to a patient who is coming with a history of rape. So this was a 13-year-old girl with complaints of pain in abdomen, 8 weeks of amenorrhea. UPT came out positive. So it is confirmed that she is pregnant. So if it is pregnant, definitely it is a case of rape. Any sexual intercourse, even with consent, with a girl below the age of 18 years is always rape. So The thing is, definitely we have to inform the police. Medical termination of pregnancy has to be decided. Now, see, MTP cannot be decided just by the girl, because for doing the medical examination, the age is 12 years, but for doing MTP, the age is 18 years. And for doing the MTP, you will have to ask the guardian or parent to come. Take consent from the mother for examination of genital. See, examination of genitals after she's coming after 8 weeks of amenorrhea. The rape evidences are all get lost within 3 to 4 days only. So at this time, the medical examination as such will be of limited use. The clothes would have been changed, so their preservation will have only no use. It is, but definitely it's a case of rape, and one has to inform the police. Then a patient came to casualty with burn wounds involving full circumference of right thigh, right upper limb, and anterior chest. So I don't know whether this was, I think it should have been covered in surgery itself, but in case it was not covered, so this was right thigh. So right thigh, whole of right thigh was involved, so that becomes 9%. Plus right upper limb, that is again 9%, so 9 plus 9, 18. Then anterior of chest, this is 9, so 18 plus 9, 27. And then I think there were anterior chest and anterior abdomen also, and abdomen also was there. So all were 9, 9, 9, and 9. So that is the reason the answer became 36%. Then blackening, the cause of blackening is smoking. We all know unburnt particles causes tattooing, whereas and the flame causes singeing. I don't know what was the fourth choice, but smoke causes blackening. Okay. Now, death due to dry drowning. So the main feature of dry drowning is that the water is not going into the water does not go into the lungs. The water goes till the laryngospasm. Water goes till the larynx. Laryngospasm occurs and the patient dies. This is a kind of atypical drowning. So pulmonary edema, electrolyte imbalances, secondary lung infection, these will occur in the usual cases of drowning, and the water is going into the lungs. But here the water is not even going to the lungs. Then I don't know whether I believe this should have been discussed in pharmacology, but so in tricyclic antidepressant, why tricyclics can affect many receptors, including alpha adrenergic blockade and many other receptors also. One of the predominant effect is anticholinergic, and in anticholinergic effect you will get hyperthermia, not hypothermia. So though hypothermia can be seen rarely, but that is not a common phenomena. Commonly it is the anticholinergic effects which predominate, which leads to hyperthermia. Again, mydriasis is also an anticholinergic feature. Arrhythmias can occur because of direct cardiotoxicity, and confusion can occur again because of multiple reasons, including anticholinergic effect. But definitely, hypothermia is a very rare phenomenon. Usually, it is hyperthermia. Then this was a bit tricky question. What do you not take in cadaver for identification? Actually, earlier the DNA. See, teeth is definitely very much useful. First of all, we can take DNA. Then dental charting can be of great use. Blood is a very good source for DNA. Now, nail and muscle. So earlier, muscle is a good source for DNA, but if you consider nail, earlier the amount of DNA in nail is very less. It is basically present only in the nail matrix and all. So earlier it was not considered to be a good sample for DNA. But now with the latest advanced techniques, even with that less amount of DNA into the nail matrix, we can do the identification. Moreover, recently the nail printing is also started. Like we do fingerprinting, now we can do nail printing also. So I was also a bit skeptical because this was a very subjective thing. Different people, there are different school of thoughts. Earlier, I thought maybe nail will be the answer, but I will prefer to go with muscle if we go with the latest developments. That muscle is of least useful. I'm not saying it cannot be used. It can be used, but if I have to consider all the choices, I will say that muscle is of least useful in identification. This question, I think this was a straightforward question. Enzyme is the reactivator of the enzyme of acetylcholinesterase. All other are chelators. EDTA is a chelator mainly used for lead poisoning. BAL is the chelator used for multiple heavy metals like arsenic, mercury, lead. Penicillamine is mainly used for copper, but oxime is the enzyme reactivator, which is basically used for organophosphate poisoning. Cadaveric spasm is seen. Basically, cadaveric spasm can be seen whenever there is a lot of excitement and neurological excitement is there. That leads, for example, in drowning, electrocution, person trying to commit suicide. These are the tips. So drowning, you would have seen that a person holding the grass and weeds in the hand. That's a typical drowning picture we show for cadaveric spasm. Suicidal firearm wound, if someone tries to is committing suicide, the firearm sometimes remains like this only. So that is also cadaveric spasm can be seen. Electrocution is also a very sudden death, and all of the muscles get activated. So amongst these, the best answer will be traumatic asphyxia. Now, match the following that these poisons act on which body system. So nicotine, we all know, is a cardiac poison, so it will go with CVS. We know that there are few poisons like datura, hydrogen cyanide, oleander, nicotine, aconite, and quinine. These are the poisons which act on CVS, cardiac system. So nicotine is CVS. HNO3 it's an inorganic acid, so it acts locally, it does not have a remote action. Nux vomica is a spinal poison, CNS spinal stimulant. So actually, nux vomica can act on whole of the CNS, but we have to choose the best possible answer. The preferred, the most important site for nux vomica is spine only. Datura basically it's an antimuscarinic agent. So here it has a lot of neurological symptoms or CNS. So if we have to go, it will be coming something like this: nicotine CVS, HNO3 skin, nux vomica spinal, and datura CNS. And I don't know, this question I have not got, but if this was the question that desferoxamine is used above what level, I will see in case I can get the complete question. I just heard about it. We usually advocate the use of desferoxamine above the level of 500 micrograms per deciliter. So I think these were the only questions which came from forensic medicine. I will further look in case any rectification is required, or I can get more recalls. So thank you very much. I think
Dr. Priyanka, sir.
Okay. Good evening, ma'am.
Hello, sir. Hello. Good evening, everyone. Thank you so much. Thank you for just a second. Let me share my screen. I guess you can see my screen, right? You all people can see my screen. Just a second. Just a second. I guess, yes, you can see it. Okay. So let me continue. Okay. So here I'm going to discuss. Hopefully you all have great exam today. The paper was moderate. It was not very difficult. And micro questions were relatively easy, not very difficult. So let me discuss the micro question quickly. The first question is in front of you. You can see the question. There is a patient who is recovered from the COVID recently, and patient is given the treatment as steroid. But after 3 weeks, there is complaint of the bloody nasal discharge, and image of the nasal discharge swab is given to you. Was it a question? Was it a question? Maybe the image may be different. The image is not exactly same, but in the image, you have to see the angle. You have to see the angle. Was the angle obtuse or is it acute? I guess the angle was given obtuse. Hana, the biggest clue given to you, the patient is on recovered from COVID and patient is given steroid. So basically they want to tell you the patient is immunocompromised. Now all the fungus given to you, they are opportunistic fungus only in the option, right? Now post-COVID mucor, is the most common fungus. We have seen in COVID pandemic also, most common fungus after COVID due to steroid treatment. Patient is immunocompromised, right? So here you can see if the angle is obtuse, the answer is going to be mucor. Okay. Was it given diabetic? The most common risk factor for the mucon is diabetic ketoacidosis. Was something mentioned in the question regarding the diabetic ketoacidosis? If not, also still the answer is going to be mucor. If the angle is obtuse and septa, you have to see the septa, septate or aseptate. Here we can see it is aseptate. You know, in aspergillus, the branching is typically acute, 45 degree. 45 degree. Here the angle, it is either right angle or it is obtuse angle, and it is aseptate. So I guess most of the students said that the image given, that is the key. In the image, it was an obtuse angle and aseptate fungus was there. So answer is going to be mucor. Right. So other options you can help me. What were the other option? So was the option mucor, and was the image showing obtuse angle? If the image is showing obtuse angle and aseptate and the broad hyphae, the answer is going to be mucor. Right. Okay. Septa not visible. No. Yes, that's what I'm saying. If the septa is not visible, it is going to be aseptate and mucor. We have seen many cases of mucor clinically also post-COVID because of steroid as a treatment. The patient become immunocompromised. It was a very easy question. The next question is also very easy, I guess. The HIV, in the HIV virus, which of the following is required for the entry of the virus in CD14 lymphocyte? You can see the diagram. The four options, I guess, glycoprotein 120, glycoprotein 41, CCR5, and CXCR4. So what is the correct answer? These were the four options? Was this the exact question, or any change is there in the question? I guess these were the exact options I'm telling you. So here CCR5 and CXCR4, these are required as co-receptor. These are not for the main receptor. Okay, these are the co-receptor. Glycoprotein 120 is required for the entry, and glycoprotein 41 is required for the fusion. I guess in the question, entry is asked. So answer is going to be glycoprotein 120. If instead of entry, if they are asking for the fusion, answer is going to be GP41, but I guess entry is asked. You can see for the entry, the bond is formed between the glycoprotein 120 of the virus with the CD4 receptor of the T lymphocyte. Okay. I guess the correct answer is glycoprotein 120. There is no doubt in that. And this question is going to be easiest question. Just a second. I cannot see the screen, I guess. Just a second. There is some technical issue. Okay. Just a second. The screen share is stopped. I don't know why. I guess you can see it now, right? Okay, coming on the next question. I guess. Let me see if the screen I can share it. Is it shared or not? I guess it's there. So the next question you can see, let me discuss elongation factor 2 inhibition mechanism in which bacteria? That is the next question. I don't know all the option, but the two option was diphtheria and Clostridium. So I taught you many times that is always there is a question on the mechanism of action of the toxin, I guess. So the toxin that act by inhibiting the protein synthesis and the toxin that act by increasing cyclic AMP. So protein synthesis inhibit kaise hota hai? The bacteria, the toxin of the bacteria enter inside the host cell and inhibit the ribosome. Inhibit the elongation factor 2 by doing ADP ribosylation of the elongation factor 2. Elongation factor 2 का ADP ribosylation करके elongation factor 2 को inhibit कर देंगे तो ribosome is non-functional. If the ribosome is non-functional, protein synthesis नहीं होगा. Protein synthesis नहीं होगा तो cell will die. And this is how these bacteria are going to cause the disease. So there is a mnemonic I always tell you, that is DPSS. So diphtheria is one of them. The answer is going to be Corynebacterium diphtheria. DPSS में D is diphtheria, P is Pseudomonas, and two S's are there. One is Shiga toxin, one is Shiga like toxin. So अगर ऑप्शन में डिप्थीरिया है, रेस्ट ऑफ द ऑप्शन में भी तुम्हें जो भी होंगे, बट आंसर इज गोइंग टू बी डिप्थीरिया अगर डिप्थीरिया इज द देयर इन द ऑप्शन. सो elongation factor 2 inhibition, diphtheria is the answer, right? अगर कुछ और क्वेश्चन है और कुछ और ऑप्शन है तो काइंडली लेट मी नो. ठीक है. द नेक्स्ट क्वेश्चन, ऑल ऑफ द फॉलोइंग टेस्ट आर पॉसिबल इन द डेंगू 3-day history of fever except. इस क्वेश्चन में कैन यू हेल्प मी? व्हाट वाज द एग्जैक्ट क्वेश्चन? व्हाट वर द ऑप्शन? I guess one of the option is PCR, one of the option is NS1 antigen, one of the option is IgM ELISA. What is the fourth option? And was it a 3-day history of fever or 1-day history of fever? Or question में accept हाँ कि नहीं? You have to help me in the comment. You have to help me in the comment, please. Yes. So I guess 3-day history hai ya 1-day history hai. PCR is positive from day 1 only. From day 1 only, we can do the PCR. है ना? From day 1, NS1 antigen also we can do from day 1 only. है ना? ELISA, IgM is coming after 5 days. So if they are asking, accept, I will go with IgM ELISA. Question में accept था कि नहीं था? So there is a confusion. Question में accept था कि नहीं था? Kindly let me know. Kindly let me know. So if question में accept था, answer is going to be IgM ELISA, क्योंकि IgM comes after 5 days. So अगर 3 days पे हमें कोई टेस्ट लगाना है, तो we can prefer PCR, we can prefer NS1 antigen. NS1 antigen से we can do the serotyping also. There are 5 type of dengue, 1, 2, 3, 4, 5. We can do the serotyping. The best test NS1 antigen कर सकते हैं, PCR कर सकते हैं. NS1 antigen day 1 से day 18 तक पॉजिटिव होता है, PCR day 1 onwards पॉजिटिव होता है, right? लेकिन IgM antibody later on, IgG तो और later होती है, after 18 days it comes, 80 days it comes, 2 to 3 weeks, right? So accept था तो answer is going to be IgM ELISA. अगर ऑप्शन में यही थे तो, और क्वेश्चन में यही पूछा था तो. ओके ओके, सो कैन वी गो हेड. 2-day फीवर हिस्ट्री था और एक्सेप्ट नहीं था. नो सम स्टूडेंट्स सेइंग कि एक्सेप्ट था, सम आर सेइंग एक्सेप्ट नहीं था. सेम क्वेश्चन 2 वर्जन नहीं हो सकते. सो आई डोंट नो. अगर एक्सेप्ट था तो आंसर इज गोइंग टू बी दिस. एक्सेप्ट नहीं था तो फिर मल्टीपल ऑप्शंस होंगे ना. लाइक 3rd डे पे बेस्ट कौन है वो नहीं कह सकते हैं. पीसीआर और NS1 बोथ आर इक्वल एंड गुड. ठीक है. सो कमिंग ऑन द नेक्स्ट क्वेश्चन. Immunocompromised person था. White patches on the tongue, on the lateral side of the tongue, I guess. They cannot be rubbed off. So this is a typical scenario they are talking for oral hairy leukoplakia. Oral hairy leukoplakia mein, this is the typical scenario they are talking about, and it is caused by Epstein-Barr virus. So answer is going to be Epstein-Barr virus, है ना? So Candida may be oral thrush होता है, लेकिन this is not the typical scenario, है ना? यहाँ पे जो typical scenario दिया, it cannot be rubbed off. They are talking for the oral hairy leukoplakia, and answer is going to be Epstein-Barr virus, क्योंकि उसी से ही होता है. Which of the following virus need reverse transcriptase PCR? So इस क्वेश्चन में accept था क्या और need था. So reverse transcriptase PCR बहुत ही simple question है. Reverse transcriptase PCR, as the name indicate, we use reverse transcriptase PCR in RNA virus. RNA virus में होता है because it convert RNA to DNA. Reverse transcriptase is the enzyme. तो इनमें से कौन RNA virus है? So it's an indirect question. They are just asking the classification. इनमें से कौन RNA virus है? So whatever is the option, उनमें एक ही RNA virus होगा. I guess syncytial virus is given to you. It is a RNA virus. Rest जो भी option है, I'm not sure about the option. लेकिन I'm sure, लेकिन बचे हुए सारे option आपके DNA होंगे. One of them is RNA, क्योंकि RNA virus में ही RT-PCR होता है. अगर reverse transcriptase PCR पूछा है और RSV ऑप्शन में है, तो RSV is going to be the answer. और make sure कि बाकी तीनों ऑप्शन आपके DNA होंगे, right? बाकी तीनों DNA होंगे. मे बी एडिनो इज वन ऑफ देम. तो इनमें से कौन नहीं था? एक कोई नहीं होगा और साथ में एडिनो होगा, लेकिन एडिनो भी DNA है. सो द कॉन्सेप्ट रिमेन सेम. ठीक है. सो आंसर इज RSV, क्योंकि वो RNA है. ठीक है. द नेक्स्ट क्वेश्चन, ट्रांससेल्युलर मूवमेंट कौन सा बैक्टीरिया दिखाता है? ऐसा कोई क्वेश्चन था क्या? वाज देयर सम मोशन फ्रॉम सेल टू सेल मूवमेंट? इस पे कोई क्वेश्चन था? सो इफ देयर इज द क्वेश्चन, आंसर इज गोइंग टू बी लिस्टेरिया, है ना? 3 ऑप्शन तो मुझे मिले हैं, साल्मोनेला, Enteroinvasive E. coli, and the 4th option I don't know. If listeria is there, तो listeria में क्या होता है? These are the host cell. These are the host cell. This is the listeria. Listeria listopods बना के actin use करके एक bridge बनाता है between the host cell and jump from one cell to another cell. This is the, you know, it is one of the virulence factor for the listeria. Listeria इस तरह से one host cell से दूसरे host cell में using the actin polymerization making a bridge, listeriopods बना के वो jump करता है. So answer is going to be listeria, cell to cell movement by jumping from one cell to another. So this is listeria. अगर listeria option में है तो listeria. So 4th option is H. pylori. Okay. So still the answer is going to be listeria. Yes, actin may be question में actin तुम्हें mention किया होगा. So actin use करके, utilize करके, उसका polymerization करके cell to cell movement is listeria. The next question, Vibrio cholerae disrupt which cell adhesion? If option contains zona occludens, occludens is going to be the answer, है ना? One of the virulence factor for Vibrio cholerae, है ना? ये zona occludens toxin जो tight junctions है उसको disrupt करके डायरिया कराता है. Main mechanism of the diarrhea is the Vibrio cholerae toxin. Vibrio cholerae toxin हमें पता है, it increase cyclic AMP. साइक्लिक EMP इंक्रीज करके सोडियम चैनल्स को इनहिबिट करके वो डायरिया कराता है. दैट इज द मेन मैकेनिज्म. लेकिन अदर मैकेनिज्म में जोना ऑक्लूडेंस एक टॉक्सिन निकालता है जो कि टाइट जंक्शन को डिस्टर्ब करके भी डायरिया करा सकता है. सो ऑक्लूडेंस ऑप्शन में था तो ऑक्लूडेंस इज गोइंग टू बी द आंसर. ऑक्लूडेंस था आंसर में, ऑप्शंस में. सो ऑक्लूडेंस इज गोइंग टू बी द आंसर. इट इज नॉट इंटीग्रिन, इट इज नॉट कैडहेरिन, है ना? विब्रियो कोलेरी. द नेक्स्ट क्वेश्चन, आई गेस देयर वाज अ क्वेश्चन ऑन द a clinical question. There is a patient having the fever, black discharge, single black discharge, एंड OXK पॉजिटिव। ये OXK पॉजिटिव व्हील पैलिक्स मेंशन किया था क्या? स्क्रब टाइफस पे क्लिनिकल क्वेश्चन था, स्टूडेंट्स वर सेइंग, बट आई एम नॉट कमिंग विद द एग्जैक्ट क्वेश्चन क्या था। सो दे मेंशन द ब्लैक इश्चार और आई गेस व्हील पैलिक्स दिया था, है ना? व्हील पैलिक्स दिया था तो OXK पॉजिटिव ओनली इन स्क्रब टाइफस, और किसी में OXK पॉजिटिव नहीं होता है। अमंग द रिकेट्शिएशी फैमिली में जितने भी मेंबर्स होते हैं, OXK इज पॉजिटिव ओनली इन स्क्रब टाइफस, और ब्लैक इश्चार भी उसमें होता है। सो आंसर इज गोइंग टू बी स्क्रब टाइफस, right? Okay, so it is not mentioned. So what is the other clue given to you apart from black star? और क्या clue था? You have to come up with the question. और भी तो कुछ clue होगा ना? Okay, OXK positive option में था, maybe. Okay, so they are not giving you directly scrub typhus. अगर option में OXK positive था तो भी आंसर वही होना है ना? Right, क्वेश्चन में ब्लैक स्टार के अलावा और क्या क्लू था कि वो ओरिएंशिया सुसुगामुशी कहीं मेंशन था क्या? द कॉजेटिव एजेंट इज द ओरिएंशिया सुसुगामुशी, जिसके वेक्टर पे भी एक क्वेश्चन है। आई केम टू नो कि तुम्हारे पास वेक्टर की इमेज पे एक क्वेश्चन था, बट अमंग दीज कोई वेक्टर नहीं था। आई गेस हार्ट टिक का इमेज था वो, है ना? सो आई एम कमिंग ऑन दैट ऑल्सो। ठीक है, चलो, ओरिएंशिया सुसुगामुशी पे जो क्वेश्चन था, अदर ऑप्शन वाज टाइफॉइड फीवर। ओके, so let's see, I will come with the exact question, है ना? Later on मैं exact question पता करके वो करती हूँ। एक क्वेश्चन था, there is a rural area जिसमें स्विमिंग का हिस्ट्री दिया था, और स्विमिंग के बाद पर्सन को पैरालिसिस या कुछ CNS सिम्टम्स या नेक रिजिडिटी जैसे सिम्टम थे। सो वाज इट अ क्वेश्चन? एग्जैक्टली आपको क्वेश्चन का सिनेरियो बताना पड़ेगा। रूरल एरिया में स्विमिंग, तो स्विमिंग ऑलवेज इंडिकेट टुवर्ड्स निग्लेरिया फ्लावरी। निग्लेरिया फ्लावरी इज वन ऑफ द पैरासाइट, इट इज अ फ्री लिविंग अमीबा जो आपको मेनिंजाइटिस कराता है। वन ऑफ द अमीबा व्हिच कॉज इन मेनिंगो इंकेफ्लाइटिस, प्राइमरी अमीबिक मेनिंगो इंकेफ्लाइटिस। एंड वन इमेज इज गिवन, स्टूडेंट्स आर सेइंग एग्जैक्टली वो इमेज इलेक्ट्रॉन माइक्रोस्कोपी है या क्या इमेज दिया है? इलेक्ट्रॉन माइक्रोस्कोपी इमेज दिया है। और व्हाट इमेज इज गिवन टू यू? नो हिस्ट्री ऑफ स्विमिंग, स्विमिंग पूल का कोई हिस्ट्री नहीं है, या स्विमिंग का, या स्विमिंग इन कंटेमिनेटेड। इफ स्विमिंग हिस्ट्री इज नॉट गिवन तो आंसर एक्केंथमीबा भी सोच सकते हैं, बालमुथिया भी सोच सकते हैं। नॉट द कंप्लीट क्लिंच गोस की इमेज क्या है, क्योंकि तीनों के तीनों आपके मेनिंजाइटिस तो कराते ही हैं। निग्लेरिया फ्लावरी मेनिंगो इंकेफ्लाइटिस कराता है जो कि फैटल होता है। बचे हुए दोनों सिर्फ मेनिंजाइटिस, सिर्फ इंकेफ्लाइटिस कराते हैं, मेनिंजाइटिस नहीं कराते, लेकिन सिम्टम्स सभी में सेम होंगे, है ना? द पेशेंट मे बी हैविंग द CNS सिम्टम्स। ठीक है, तो अब एग्जैक्टली तो डिपेंड करता है कि इमेज कौन सी थी, इनमें इलेक्ट्रॉन माइक्रोस्कोपी का कौन सी इमेज था। एक्केंथमीबा का बहुत ही पिक्यूलियर इमेज होता है। इफ एक्केंथमीबा का इमेज बहुत पिक्यूलियर है, वो इलेक्ट्रॉन माइक्रोस्कोपी, क्योंकि आई डोंट थिंक निग्लेरिया फ्लावरी के इलेक्ट्रॉन माइक्रोस्कोपी में कोई पिक्यूलियरिटी है जो इमेज में तुम पिक कर पाओ और तुम्हें दिया हो। आई डोंट थिंक सो। कैन यू टेल मी? मल्टीपल स्पाइक्स ऑन द अमीबा, स्विमिंग पूल से तो स्प्रेड होता है डेफिनेटली, लेकिन एग्जाम में स्विमिंग पूल था क्या क्वेश्चन में? अगर स्विमिंग पूल था तो नो डाउट आंसर इज गोइंग टू बी निग्लेरिया, क्योंकि एक्केंथमीबा एंड मालमुथिया आर नॉट स्प्रेडिंग विद स्विमिंग, दे आर स्प्रेडिंग वाया इनहेलेशन। सो और क्या क्लू था? वाज इट फैटल, पेशेंट डाइड, या ऐसा कुछ मेंशन किया था क्या? यस, लुक लाइक इकोलाई। इकोलाई के जैसा कैसा दिख सकता है? ऑप्शन में इकोलाई नहीं है, इट्स अ पैरासाइट ना। इकोलाई जैसा कैसे? उसके ऊपर एंटीजेंस थे क्या? ओके, हाउ इज इट इकोलाई? सो कैन यू डिस्क्राइब द इमेज? ठीक है, इन द रिकॉल लेटर आई विल कम विद द एग्जैक्ट इमेज, कि एग्जैक्ट इमेज क्या था और क्या आंसर होना चाहिए। आई फीचर्स गिवन, पॉन्ड गिवन। नाउ सम स्टूडेंट प्रिया इज सेइंग द पॉन्ड इज गिवन, द पॉन्ड इज गिवन। पॉन्ड यानी स्विमिंग ही तो हुआ ना फिर, द पॉन्ड का कोई हिस्ट्री है, पॉन्ड यानी तो स्विमिंग हुआ ना। नो स्विमिंग हिस्ट्री, नो स्विमिंग हिस्ट्री, तो वी कैन नॉट कम ऑन द कंक्लूजन। क्रेनियल नर्व पाल्सीज, इट वाज फैटल, फैटल है तो अगेन इट इंडिकेट्स निग्लेरिया, निग्लेरिया इज फैटल, है ना? हार्डली एनी ट्रीटमेंट, है ना? So, okay. So let's see, patient with coma. So let's see, I will come with the detail. Let me see कि exact image क्या था. So everything image पे आके अटकता है। ठीक है, next question. Patient again ये meningitis का question था, typical question था। Next stiffness है, कर्निंग साइन पॉजिटिव है, सो दे आर इंडिकेटिंग कि मेनिंजाइटिस का केस है। लेकिन लिम्फोसाइटोसिस है, लिम्फोसाइटोसिस है तो रूल आउट पायोजेनिक, पायोजेनिक तो नहीं हो सकता। वी आर लेफ्ट विद टू ऑप्शन, वायरल है कि टीबी है ना? नो प्रोटीन एलिवेटेड है और ग्लूकोज फॉल हो रहा है तो वायरल भी रिमूव कर दो, क्योंकि वायरल में प्रोटीन और ग्लूकोज नॉर्मल होते हैं। वायरस डोंट कंज्यूम ग्लूकोज, वायरस की सेल वॉल नहीं होती है तो प्रोटीन भी नॉर्मल होता है। लेकिन टीबी मेनिंजाइटिस में प्रोटीन एलिवेटेड होता है बिकॉज ऑफ द सेल वॉल, ग्लूकोज फॉल होता है बिकॉज द ग्लूकोज इज कंज्यूम्ड बाय द ऑर्गेनिज्म, और लिम्फोसाइटोसिस होता है। सो आंसर इज टीबी मेनिंजाइटिस, अगर ये एग्जैक्ट क्वेश्चन है तो। अगर एग्जैक्ट क्वेश्चन है तो राइट, यू कैन सी टीबी मेनिंजाइटिस में लिम्फोसाइटोसिस होता है, पायोजेनिक में न्यूट्रोफिल होते हैं, है ना? वायरल में भी लिम्फोसाइट होते हैं, लेकिन यहाँ पे ग्लूकोज नॉर्मल होगा। कि अगर ग्लूकोज रिड्यूस्ड है तो इट हैज टू बी टीबी। फोर्थ ऑप्शन क्या था? यू हैव टू टेल मी। पायोजेनिक, वायरल, टीबी, फोर्थ ऑप्शन क्या था? अगर फोर्थ ऑप्शन भी इररिलेवेंट है तो टीबी इज गोइंग टू बी द आंसर, राइट? नेक्स्ट क्वेश्चन भी एक मेनिंजाइटिस का एक और सिनेरियो तुम्हें मेंशन था, आई डोंट नो द एग्जैक्ट सिनेरियो, लेकिन तुम्हें इंडिया इंक पॉजिटिव मेंशन किया था, एंड आई गेस द पेशेंट इज HIV. इंडिया इंक है ना, इट इज पॉजिटिव ओनली इन कैप्सुलेटेड ऑर्गेनिज्म. सो ऑप्शंस में क्रिप्टोकोकस था, तो इट इज क्रिप्टोकोकल मेनिंजाइटिस, राइट? इट हैज टू बी क्रिप्टोकोकल मेनिंजाइटिस. प्रोटीन इज हाई, ओके, प्रोटीन हाई तो यहाँ पे भी होगा, प्रोटीन हाई दोनों में होगा, बैक्टीरिया में भी होगा, टीबी में भी होगा, लेकिन लिम्फोसाइटोसिस इंडिकेट्स टुवर्ड्स टीबी. इट इज नॉट बैक्टीरियल मेनिंजाइटिस, राइट? गॉट इट? मे बी आपको वैल्यूज दी होंगी, ग्लूकोज इज 20 मिलीग्राम and maybe protein is 60 milligram. So you should know the normal range. Glucose का normal range 20 है, तो वो 50 से कम है, so it is reduced. और protein का normal range up to 45 है, so it is elevated. So maybe whatever value is given to you, come on the conclusion कि वो reduced है कि elevated है. So I guess glucose reduced है, ऑप्शन में क्वेश्चन में 20 दिया था, और प्रोटीन एलिवेटेड है क्योंकि 60 दिया था, राइट? सो अल्टीमेटली लिम्फोसाइटोसिस इज द की, और आंसर टीबी है, पायोजेनिक नहीं है, वायरल नहीं है, राइट? गॉट इट? द नेक्स्ट क्वेश्चन इज इंडिया इंक पॉजिटिव. अच्छा, ड्रग पूछा था इसमें, सो मे बी ये फार्मा में डिस्कस हुआ होगा आपको, ड्रग ऑफ चॉइस. ट्रीटमेंट ऑफ क्रिप्टो, ओके, द इमेज बेस्ड क्वेश्चन ऑफ क्रिप्टो इज नॉट देयर, आई गेस इमेज बेस्ड क्वेश्चन ऑफ द क्रिप्टो इज देयर, ओके. वाज देयर द क्वेश्चन ऑफ द डेंगू, डेंगू के वार्निंग साइंस या फिर सीवियर डेंगू का क्राइटेरिया पे कोई क्वेश्चन था? आई एम नॉट नोइंग द एग्जैक्ट क्वेश्चन, बट स्टूडेंट्स टोल्ड मी द क्राइटेरिया फॉर द सीवियर डेंगू पे. देयर वाज अ सिनेरियो डिस्क्राइब्ड जिसमें पेशेंट को थ्रोम्बोसाइटोपेनिया था एंड सस्पेक्टिंग डेंगू. So it was not a definitive case, but we were suspecting dengue, and they were asking the criteria for severe dengue. So you have to tell me the options. I guess अगर criteria for severe dengue they are asking, तो आपको one of the option ये होगा, है ना? Maybe the patient is mentioned as shock or fluid accumulation. दोनों में से एक चीज होगा. ये प्लाज्मा लीकेज के साइंस हैं, और या फिर सीवियर ब्लीडिंग का कोई ना कोई साइन होगा, या फिर सीवियर ऑर्गन फेलियर, या तो लीवर के एंजाइम्स आर रेस्ड, या तो impaired consciousness, that is CNS is involved, या heart is involved. So these are the signs of the severe dengue. Options में आपको मुझे बताना पड़ेगा. So was there a question? डेंगू पे क्वेश्चन था, और डेंगू में क्वेश्चन में पूछा क्या था? क्राइटेरिया फॉर द सीवियर डेंगू. अगर ये पूछा था तो ऑप्शंस क्या थे? वन ऑफ द ऑप्शन ये होना चाहिए. तो टेल मी 3 ऑप्शंस क्या थे और 4th क्या था? आई डू नॉट नो द एग्जैक्ट ऑप्शंस. हाँ, transaminase, very good. If transaminase is more than 1000, ये ऑप्शन में था, तो go with that, because it is one of the criteria for severe dengue. It indicates liver failure. So organ failure, या तो liver failure, या brain involvement, या heart involvement. तीनों में से कोई organ failure का साइन होना चाहिए. एक साइन bleeding का होना चाहिए, और एक साइन plasma leakage का होना चाहिए. So इनमें से जो भी है, that is severe dengue. अगर transaminase raised है, तो that is going to be the answer. What were the other options? अदर ऑप्शंस क्या थे? सो यू हैव टू कंफर्म कि अदर ऑप्शंस या तो प्रोबेबल डेंगू में से थे या वार्निंग डेंगू में से. दीज वर नॉट सीवियर डेंगू. तो आई गेस अदर 3 ऑप्शन आपको कंफ्यूज करने के लिए यहां से देना चाहिए. एक ऑप्शन वॉमिटिंग था, सो इट इज कमिंग इन वार्निंग साइन. और क्या ऑप्शंस थे? थ्रोम्बोसाइटोपिनिया था, ओके, थ्रोम्बोसाइटोपिनिया तो होगा ही डेंगू में. सो अदर ऑप्शंस वर दिस, है ना? सो सीवियर में से आई गेस अगर ट्रांसामिनेज है, तो इट इज गोइंग टू बी द आंसर. नेक्स्ट क्वेश्चन, आई गेस बायोसेफ्टी लेवल 3 आपको पूछा था. बायोसेफ्टी लेवल, यू नो देयर आर 4 बायोसेफ्टी लेवल, 1 2 3 4. 3 में टीबी आता है ना? सो XDR TB इज गोइंग टू बी द आंसर. इबोला टाइप 4 में आता है ना? इबोला और साल्मोनेला और CCF यहाँ पे नहीं आएगा, राइट? सो करेक्ट आंसर इज XDR TB. देयर इज नो कंफ्यूजन. आई गेस ये बहुत सिंपल क्वेश्चन था. आई गेस वन क्वेश्चन इज ऑन द सीरोलॉजी ऑफ हेपेटाइटिस. इट वाज अ डिफिकल्ट क्वेश्चन, आई गेस, है ना? सीरोलॉजी ऑफ द हेपेटाइटिस में ओनली anti-HBC इज पॉजिटिव, एंड दे डोंट मेंशन IgG के IgM, दे मेंशन टोटल. सो अगर ये टोटल मेंशन कर रहे हैं, तो आई विल अज्यूम इट इज IgG ओनली. अगर IgM होता, IgM इंडिकेट एक्यूट, वी नो anti-HBC 2 टाइप का होता है, IgM IgG. IgM इंडिकेट एक्यूट और IgG इंडिकेट क्रॉनिक, है ना? इफ दे मेंशन कि टोटल रेज्ड है, तो हम अज्यूमिंग IgG होगा, क्योंकि IgM होता तो वो अलग से मेंशन करते, है ना? नाउ इट कैन नॉट बी विंडो पीरियड. विंडो पीरियड में तो एंटीबॉडीज आती नहीं है ना, ओनली एंटीजन इज देयर, एंटीबॉडी डू नॉट देयर. उसी को तो विंडो पीरियड कहते हैं. तो दे आर सेइंग कि एंटीबॉडी पॉजिटिव है, तो विंडो पीरियड तो नहीं हो सकता. ना ही ये एक्यूट हेपेटाइटिस है. एक्यूट हेपेटाइटिस है तो एंटीजन भी पॉजिटिव होगा. यहाँ पे आपको बाकी सारा नॉन रिएक्टिव दिया है. HBS एंटीजन इज नॉन रिएक्टिव. इट इज गिवन इन द क्वेश्चन, दैट इज नॉन रिएक्टिव, है ना? HBS एंटीजन नेगेटिव है, तो एक्यूट हेपेटाइटिस नहीं हो सकता, ठीक है? सो आई गेस द आंसर, द बेस्ट इज टू बी गोइंग विद इनएक्टिव कैरियर, है ना? तो इनएक्टिव कैरियर, so IgM negative, everything is negative ना, तो inactive carrier will be the answer. Only one thing is positive, that is anti-HBC. So according to me, other options अगर नहीं है, तो inactive carrier is going to be the best answer. Acute नहीं होगा, window period नहीं होगा, चौथा ऑप्शन मुझे पता नहीं है. इन तीनों में से best answer is carrier. Got it? What is the 4th? Past infection, remote. No, तो remote और past अगर infection होगा, तो anti-HBS should be positive. हाँ ना, वंस द इन्फेक्शन अकर, रिकवरी हो गई तो एंटी एचबीएस इज पॉजिटिव फॉर एवर। लेकिन एंटी एचबीएस भी आपको नॉन रिएक्टिव दिया है तो रिमोट इन्फेक्शन भी नहीं होगा, सो दैट रूल्स आउट रिमोट इन्फेक्शन ऑल्सो। एक्यूट भी नहीं होगा क्योंकि एंटी एचबीएस एंटीजन नेगेटिव है। विंडो नहीं होगा क्योंकि विंडो में तो एंटीबॉडी नहीं होती, यहाँ तो एंटीबॉडी पॉजिटिव है। सो वी आर लेफ्ट विथ ओनली वन ऑप्शन, दैट इज inactive carrier, right? So you know that I'm not describing. Vector shown in the image, पहले तो identify करो and tell me which diseases do not transmit. I guess question में except था. So first of all, image अच्छे से देखो, it's a typical image of the heart tick. I guess यही image आपको आया था. Anti-IgM was reactive. Was it anti-IgM or anti-HBC total? Because many students told me कि ma'am total is positive. IgM is not mentioned. So kindly confirm. IgM mention किया था तो answer फिर acute हो जाएगा. इफ टोटल मेंशन किया था तो वी विल गो फॉर, लेकिन अगर आईजीएम भी मेंशन किया है तो साथ में एंटी एचबीएस भी, एंटीजन भी पॉजिटिव देना पड़ेगा। इफ वी से एक्यूट तो एंटीजन और एंटीबॉडी दोनों आएगी ना, है ना? तो इन द कैरियर ओनली, है ना, इनएक्टिव कैरियर हम कहते हैं मोर देन 6 मंथ होगा, इट इज इनएक्टिव कैरियर, है ना? सो इट विल बी इनएक्टिव कैरियर अगर टोटल इज पॉजिटिव, सो एंटीजन इज नेगेटिव हियर। गॉट इट? चलो, सो वेक्टर शोन इज द हार्ट टिक। आई गेस टिपिकल इमेज दी गई थी आपको हार्ट टिक की। हार्ट टिक ये सब कराता है एक्सेप्ट ओरिएंशिया सुसुगामोशी। ओरिएंशिया सुसुगामोशी इज ट्रांसमिटेड, it is transmitted by mite. Actually, not mite, the larva of the mite. The larva of the mite is known as chigar. That's why it causes a disease known as chigarosis, जिसे scrub typhus भी कहते हैं, right? जिसमें वो इश्चार होता है। I guess तुम्हें 2 क्वेश्चन थे scrub typhus पे। So Orientia susugamoshi is not transmitted by heart tick. Actually, it is transmitted by chigar. It is transmitted by chigar. I hope you got it. Right, I hope you got it. So currently I'm having these many questions only, but a detailed description we will come very soon. And जिसमें सारे options, सारे questions you helped a lot. We will compile और detailed description के साथ, सारे questions के साथ we will soon come. Wishing you all the best for your results. And after this, I would like to
Dr. Gaurav sir.
Yes, Dr. Gaurav sir. Sir, it's all up to you. Just a second. Let me stop share. Okay. Thank you. Thank you so much. All the best.
Thank you, ma'am. Thank you very much. Just let me share my screen. Okay. So there were 5 questions in ophthalmology which are there in INICET. Hello, everyone. Okay, how many questions finished? वो तो अभी टोटल करना पड़ेगा अभी, ठीक है? टोटल करके तभी पता लगेगा, ठीक है? Let us start with ophthalmology. Okay, hello everyone. Okay, some Priya is saying 128 done. That is good. You are keeping a count. Very good. So 21-year-old boxer with surgery is contraindicated. Question था contraindicated. Okay, yes. Good. Okay. See, RK is a surgery where you are giving cuts like this. Okay, in RK, this surgery is done where cuts are given like this. Okay, so RK is a contraindication. RK surgery is not done nowadays. I don't know why the examiner has given this question, क्योंकि RK अब कहीं पर भी world में हो नहीं रहा है. Nobody, it's an obsolete surgery now. ठीक है? Rest all surgeries जो है ना, LASIK, PRK, smile surgeries, ठीक है? ये सारे के सारे laser based surgeries हैं. ठीक है? PRK जो होता है, ये मैंने पढ़ाया हुआ है, इट इज फोटो रिफ्रैक्टिव केराटेक्टमी। ओके, इसके अंदर हम लोग कोई फ्लैप नहीं बनाते हैं। दिस इज अ फ्लैपलेस सर्जरी। तो अगर हमारे को पूछा जाए कि विच इज द बेस्ट, ठीक है, तो PRK सर्जरी वुड बी द बेस्ट। ठीक है, PRK सेफेस्ट है किसी भी ऐसे कॉन्टैक्ट स्पोर्ट्स के लिए। ठीक है, तो कॉन्टैक्ट स्पोर्ट के अंदर हम लोग PRK सर्जरी प्रेफर करते हैं। RK सर्जरी इसके अंदर कट्स दिए जाते हैं, वो हम नहीं करते हैं। ठीक है, करेक्ट है? ओके, आई होप दिस इज ओके, दिस क्वेश्चन, दिस चॉइस, एवरीथिंग वाज गुड। ठीक है, या PRK कैन बी डन फॉर हाइपरमेट्रोपिया आल्सो। यस, PRK कैन बी डन फॉर मायोपिया, हाइपरमेट्रोपिया, एस्टिग्मेटिज्म, फॉर ऑल सर्जरीज। ठीक है, LASIK डन 21 ईयर्स पे कर सकते हैं। दे आस्क व्हिच इज बेस्ट। अगर हाँ बेस्ट पूछे तो स्माइल होगा। ठीक है, लेटेस्ट जो है वो स्माइल है। ठीक है, बट मेरे को जो चॉइसेस मिली हैं उसके हिसाब से कॉन्ट्रा इंडिकेटेड था। ठीक है, विच वुड नॉट डू। ठीक है, तो इफ द आंसर इज अगर कॉन्ट्रा इंडिकेटेड था तो फिर RK सर्जरी इज कॉन्ट्रा इंडिकेटेड। करेक्ट, आई होप दिस वाज ओके। नहीं, LASIK के अंदर फ्लैप बनता है बेटे। ठीक है, LASIK पे भी फ्लैप है, स्माइल के अंदर भी फ्लैप होता है। ठीक है, थोड़ा सा छोटा सा कट होता है, फ्लैप होता है। PRK में कुछ भी फ्लैप नहीं है। PRK के अंदर क्या है, आप डायरेक्टली सरफेस के ऊपर ही लेजर कर दिया, बस दैट्स इट। और उसको छोड़ दिया एज इट इज, उसके ऊपर एपिथेलियम ग्रो कर जाता है, ठीक है, करेक्ट है। बेस्ट नहीं पूछा था, ओके, कॉन्ट्राइंडिकेशन आज, वेरी गुड। चलो तो फिर नो कंफ्यूजन, हियर द आंसर वुड रिमेन एज पी आर के, ठीक है, हियर द करेक्ट आंसर इज आर के, कोई कंफ्यूजन नहीं है, कॉन्ट्राइंडिकेटेड था, ठीक है। लेट अस मूव टू द नेक्स्ट क्वेश्चन। ये भी क्वेश्चन हम लोग उसमें रिवीजन में कर चुके हैं, वी हैव डन दिस, ओके, कोई बात नहीं, स्टाफ करी, डोंट वरी, ठीक है। यस, फॉलोइंग इंस्ट्रूमेंट इज यूज्ड टू मेजर, ठीक है, 3 चॉइसेस जो मुझे मिली हैं, देवर प्रोप्टोसिस, डिप्रोपिया, स्क्विंट। ये दिस इमेज वाज डन, या कुछ ऐसा इमेज दिया था, ये हम लोगों ने अपने अपने उसमें करा हुआ है। हर्टल्स एक्सोप्थेल्मोमीटर बोलते हैं, ये प्रोप्टोसिस के लिए होता है, ठीक है, ये प्रोप्टोसिस के लिए होता है, तो ये हमने करा हुआ है, करेक्ट। चौथी चॉइस किसी को याद है? एनीबडी कैन? हाँ, लैसिक खत्म हो गया, जितेश आ जाओ। फ्लैप हो तो JGH बनते हैं, नहीं ऐसा कुछ नहीं होता, ठीक है। हाँ, प्रोप्टोसिस, करेक्ट, प्रोप्टोसिस। अच्छा, फोर्थ चॉइस वाज स्टीरियोप्सिस, somebody is saying fourth choice was स्टीरियोप्सिस। स्टीरियोप्सिस के लिए हम लोग टिटमस फ्लाई टेस्ट करते हैं, ठीक है, टिटमस फ्लाई की मैंने इमेजेस दिखा रखी हैं, ठीक है। स्टीरियोप्सिस में वो होता है। स्क्विंट के अंदर हम लोग मैडॉक्स रॉड, मैडॉक्स फैन वाला करते हैं, ठीक है, मैडॉक्स रॉड, मैडॉक्स फैन, मैडॉक्स विंग, ठीक है, मैडॉक्स विंग टेस्ट होता है, वो स्क्विंट में होता है। प्रोप्टोसिस, ठीक है, डिप्लोपिया में भी वही होगा, मैडॉक्स रॉड, मैडॉक्स फैन, मैडॉक्स विंग, ठीक है, करेक्ट है। सो हियर द आंसर इज, नो कंफ्यूजन, द आंसर इज प्रोप्टोसिस। फॉलोइंग इंस्ट्रूमेंट इज यूज्ड टू मेजर प्रोप्टोसिस, करेक्ट। कुछ और कंफ्यूजन तो नहीं इसके अंदर। चले आगे, नेक्स्ट क्वेश्चन, ठीक है। ये एक और होता है ल्यूट्स एक्सोप्थेल्मोमीटर, ये भी पता होना चाहिए, ये भी कभी एग्जाम में आ सकता है। यस, गुड, थैंक यू डॉक्टर अंशु, वेरी गुड। चलो नेक्स्ट क्वेश्चन, विच ऑफ द फॉलोइंग इज नॉट सीन इन NPDR? NPDR ही लिखा था या पूरा फुल फॉर्म लिखा था? NPDR ही आया था या फुल फॉर्म आया था कुछ? खाली NPDR लिखा था, फुल फॉर्म नहीं लिखा था, तो इसकी फुल फॉर्म में पता होना चाहिए, नॉन प्रोलिफरेटिव डायबिटिक रेटिनोपैथी, है ना, NPDR। तो नॉन प्रोलिफरेटिव है, बिल्कुल। तो डिस्क न्यू वेस्कुलेशन में क्या होता है? न्यू वेसल्स का मतलब क्या होता है? न्यू वेसल्स का मतलब होता है ये न्यू वेसल प्रोलिफरेशन, न्यू वेसल प्रोलिफरेशन, करेक्ट ना। और यहां हम कह रहे हैं NPDR, फुल फॉर्म था, वेरी गुड। तो नॉन प्रोलिफरेटिव में तो फिर आराम से मिलना चाहिए। वेरी सीवियर हो, कैसा भी हो, अच्छा वेरी सीवियर लिखा था इसके आगे, चलो ठीक है, तो यहाँ पे हम लोग वेरी सीवियर ऐड कर देंगे, ओके, वेरी सीवियर ऐड कर देंगे। सीवियर पूछा है, वेरी सीवियर पूछा, कुछ भी पूछा, तो विच ऑफ द फॉलोइंग इज नॉट सीन, ठीक है, नॉट सीन था ना, नॉट सीन था। हाँ, वीनस चेंजेस था या वीनस ब्लीडिंग था? ओके, वीनस चेंजेस था या वीनस ब्लीडिंग था, ओके, गुड। तो डिस्क न्यूवैस्कुलर नहीं मिलेगा, ऑब्वियस ही बात है ना। डिस्क न्यूवैस्कुलर का मतलब ये है कि जब वेसल शुरू होगी तो प्रोलिफरेटिव हो गया, वीनस ब्लीडेड था, वेरी गुड। तो वीनस चेंजेस नहीं, वीनस ब्लीडिंग हो जाएगा ये। नहीं जितेश, माइक्रोनिज्म क्यों होगा बेटे? दिस ऑल थ्री दिस चेंजेस आर सीन इन NPDR। ये पूछ रहे हैं विच इज नॉट सीन, है ना, नॉट सीन। सीन था, सीन नहीं होगा, क्योंकि सीन में तो तीनों मिलेंगे, ठीक है, वेरी सिवियर में तो तीनों मिलेंगे। नॉट सीन के अंदर डिसनिवेशन नॉट सीन हो जाएगा, करेक्ट। फटाफट चार्ट में बताओ जल्दी से। इरमा, हाँ यस, इरमास भी मिलते हैं, नॉट सीन था। रिची इज सेइंग नॉट सीन था, डॉक्टर अंशु इज सेइंग सीन था, डॉक्टर अंशु गुप्ता, ठीक है, हमने ये करा हुआ है डायबिटिक रेटिनोपैथी में, नॉट सीन था, है ना। तो प्रोलिफरेटिव में, दिस इज अ स्लाइड डायरेक्टली फ्रॉम द INICET मैराथन में पढ़ा था हमने ये, और मैंने तब दिखाया भी था कि देखो वेसल पे प्रोलिफरेशन हो रही है, ठीक है, सी वेसल प्रोलिफरेशन हो रही है, ठीक है, दिस इज द डायग्राम दैट आई हैड शोन। यस, इजीएस्ट क्वेश्चन, बिल्कुल, नॉट सीन था ना, तो दिस न्यू एस्केशन इज सीन इन प्रोलिफरेटिव, ठीक है, ठीक है। नॉन प्रोलिफरेटिव में, एनपीडीआर में यू हैव माइल्ड, मॉडरेट, सिवियर एंड वेरी सिवियर। ये हमने उसके अंदर किया हुआ है, अपनी क्लासेस में किया हुआ है। माइल्ड, मॉडरेट, सिवियर एंड वेरी सिवियर। माइल्ड के अंदर आपका माइक्रो एन्यूरिज्म शुरू हो जाएंगे, माइक्रो एन्यूरिज्म आ जाएंगे। सिवियर, वेरी सिवियर में HVI, ठीक है, हेमरेजेस, वीनस ब्लीडिंग और इरमा, ठीक है, ठीक है। अनिल कपूर को याद करो, 1 2 का 4, 4 2 का 1, ठीक है। अनिल कपूर कहता ना 1 2 का 4, माय नेम इज लखन, ठीक है। तो HVI 4 2 1, ठीक है। हाँ, विद द रूल अगेंस्ट द रूल भी था, यस। आस्तिक मैटिज्म वाला भी था, यस। उस पे आ रहे हैं, एक क्वेश्चन वो भी था, आएंगे उस पे। पहले ये एक बार रिवाइज कर लो। HVI 4 2 1, 4 क्वाड्रेंट हेमरेजेस, 2 क्वाड्रेंट वीनस ब्लीडिंग, 1 क्वाड्रेंट इरमा, ठीक है। एनी 1 इज प्रेजेंट तो सिवियर, एनी 2 आर प्रेजेंट तो वेरी सिवियर। ऑफ्था टफ नहीं थी भाई, इस बार तो ऑफ्था काफी सिंपल आई है। एक क्वेश्चन है जो थोड़ा कंफ्यूजिंग है, वो अभी देखते हैं, नेक्स्ट आ रहे हैं, चलो गुड, ठीक है। ये क्वेश्चन है, द फॉलोइंग इमेज शोज। मुझे अभी पता चला कि देयर वर 2 इमेजेस, टिल नाउ आई वाज अवेयर कि ओनली 1 इमेजेस वाज देयर, पर अभी किसी ने मेरे को, एक हमारा दोस्त है, उसने बताया कि देयर वर 2 इमेजेस, ही सेंड मी दिस इमेज आल्सो, आई एम ऑब्लाइज्ड टू हिम, ठीक है। उसने ये वाली इमेज भी भेजी है। ये था ऐसा सेम 2 इमेजेस का सेट? Was there a set of these 2 images? एक नॉर्मल इमेज थी, दिस इज अ स्लिट लैम्प इमेज, एंड दिस इज अ स्टेनिंग इमेज, ठीक है। ये इस तरह से स्टेनिंग वाली इमेज, यस, ओके। रिची सेज यस, थैंक यू डॉक्टर रिची। बताओ चॉइसेस, बता दो मेरे को इसके अंदर क्या थी। इसकी चॉइसेस थोड़ी मुश्किल हो रही है, किसको कोई रिकॉल नहीं कर पा रहा है। थैंक यू अर्ता, थैंक यू नपांड्या, थैंक यू इंटरगुमेंट, भाई साहब कितना बड़ा नाम रखा है। उत्सव, वेरी गुड। जानवी, थर्ड ऑप्शन, यस सर, यस सर, यस सर, यस सर, यस, बट सेकंड वाज नॉट द सेम। अच्छा, सेकंड वाज नॉट द सेम बट सिमिलर था, ओनली कॉर्निया वाज स्टेन्ड, सिमिलर था। रवि रंजन, आई होप इट वाज सिमिलर। और थैंक यू डॉक्टर अंशु गुप्ता, आई एम ऑब्लाइज्ड, ठीक है। व्हाट्सएप पे नाम अंशु गुप्ता करके सेव कर दो तो मुझे नाम याद रहेगा, ब्रदर या मैडम, जो भी आप, सॉरी डॉक्टर अंशु, ठीक है। ग्रीन वॉज वेरी ब्राइट, पहले इमेज में अल्सर जैसा था सर। यार अल्सर ना दिख नहीं रहा, जिन्होंने मेरे को जितने भी स्टूडेंट्स ने इमेजेस भेजी हैं उसके अंदर अल्सर दिख नहीं रहा, देयर इज नो अल्सर व्हिच इज विजिबल, ठीक है। और मैंने वही कहा कि इंटरस्टिशियल केराटाइटिस स्ट्रोमा के अंदर होता है, ठीक है। तो उसके अंदर कोई स्टेनिंग आएगी नहीं, उसमें ऐसा डिफ्यूज ग्रीन सा आ जाएगा, सी इट इज अ डिफ्यूज ग्रीन, ठीक है। सो कोबाल्ट ब्लू, कोबाल्ट ग्रीन, बोथ आर इन ऑप्शन। कोबाल्ट ग्रीन नाम की कोई लाइट नहीं होती, कोबाल्ट ब्लू ही होता है। वेरी गुड, थैंक यू मिसेस अंशु, आई एम रियली ऑब्लाइज्ड, ठीक है। चलो ऑप्शन 3 राइट, सो आई वुड गो विद दिस ऑप्शन ओनली, कोबाल्ट ब्लू, फ्लोरेसेंस स्टेयर, इंसिशन केराटाइटिस, दिस इज द करेक्ट आंसर डेफिनेटली, क्योंकि इंसिशन केराटाइटिस के अंदर स्ट्रोमा के अंदर होता है, कोई स्टेन नहीं लगा, वो डिफ्यूज सी स्टेनिंग आ जाएगी पूरे के ऊपर, ठीक है। एंड ब्लू लाइट की फिल्टर, ये तो हम कई बार देख चुके हैं, ये तो बहुत बार हम लोग, ये वाली इमेज है, ठीक है। ये हमारे उसके अंदर भी था, जो अपना आईएनआईसीटी मैराथन अभी किया था, उसके अंदर भी इमेज दिखाई थी, सी दिस, ये देखो, अगर अल्सर होगा तो ऐसा इमेज लेगा, ठीक है। अल्सर होगा तो ऐसा, सिर्फ अल्सर वो लेगा, पर क्योंकि अल्सर नहीं था तो इसलिए पूरा डिफ्यूज आ गया, ठीक है। और इंटरस्टिशियल केराटाइटिस ऐसा, ये बिल्कुल करेक्ट है, एब्सोल्युटली फाइन। लिसामीन नहीं होगा, लिसामीन स्टेन्स द कंजक्टाइवा, लिसामीन कॉर्निया को स्टेन नहीं करता, ठीक है, कंजक्टाइवा को स्टेन करेगा और डेड सेल स्टेन करेगा, ठीक है ना, डेड सेल स्टेन करेगा, और इंटरस्टिशियल केराटाइटिस में होगा नहीं। तो लिसामीन ग्रीन में यहाँ पे उन्होंने कॉर्नियल अल्सर दिया है, लिसामीन ग्रीन इज नॉट यूज इन कॉर्नियल अल्सर, ठीक है। लिसामीन ग्रीन को हम कॉर्नियल अल्सर में यूज नहीं करते। चलो गुड, इट वॉज अ ग्लोबुलर ग्रीन, ग्रीन वॉजंट डिफ्यूज, इट वॉज अ ग्लोबुलर ग्रीन, अच्छा ओके डॉक्टर अंकुर। अगर कोई इमेज मिले तो आई अगेन मेंशन माय नंबर, सेंड मी द इमेज बेसिकली इमेज के ऊपर डिपेंड करेगा कैसा है। इसीलिए मैंने INICET जब मैराथन किया था तो उसके अंदर मैंने बहुत सारी इमेजेस दिखाई थी, क्योंकि ऑफ्था में इमेज बहुत इंपॉर्टेंट है। ठीक है डॉक्टर अंकुर, अगर इमेज कोई मिलती है उससे सिमिलर तो सेंड मी ऑन माय व्हाट्सएप। ठीक है। अल्सर सोच के कोबाल्ट ब्लू मारा था, अल्लाह मेहरबान करता है। नहीं यार, आपने पढ़ाई करी है, दिस इज कॉल्ड एज सिक्स सेंस। ठीक है, इसमें गधा पहलवान नहीं है, इसमें मेहनत पहलवान है। ठीक है, कहीं ना कहीं वो इमेज देखी हुई होगी, वो आपके बैकग्राउंड में पड़ी है सेरिबेलम में। ठीक है, इट इज हाइडिंग इन द सेरिबेलम। ठीक है, तभी वो बाहर निकल आके आ जाती है। करेक्ट। तो सेरिबेलम पहलवान। ठीक है, चलो चलें। कोबाल्ट ग्रीन, चले आगे। ठीक है, गुड गुड गुड। ठीक है, तो ये तो हम कई बार कर चुके हैं। लिसम ग्रीन विल स्टेन डिवाइटलाइज ड्राई सेल्स। ठीक है, फ्लोरेसेंट स्टेन। ठीक है, सो दिस इज लिसम इन ग्रीन विल स्टेन द ड्राई सेल्स। ओके, करेक्ट। चलो ये क्वेश्चन, -1 diopter spherical, -2 diopter at 180 degree, what is the type of refractive error? है ना, यही क्वेश्चन था ना जो पूछे ऊपर पूछ रहे थे कुछ लोग। सेम क्वेश्चन, कोई कंफ्यूजन तो नहीं? हाँ बस डार्सन पुदन लास्ट क्वेश्चन है बेटा, इससे फास्ट क्या होगा? नहीं नहीं विजन, ट्राइपम ब्लू नहीं है यार वो। अच्छा, कोबाल्ट ब्लू, कोबाल्ट ब्लू। तो ट्राइपन ब्लू तो यार इंट्राऑकुलर यूज होती है। ठीक है, ट्राइपन ब्लू जो होती है ना बेटे, ट्राइपन ब्लू इज अ डिफरेंट डाई। ट्राइपन ब्लू इज यूज फॉर इंट्राऑकुलर स्टेनिंग। ठीक है, ओके। चलो 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 चलो, ठीक है, गुड। एग्जैक्ट क्वेश्चन आ जाओ इसमें। अरे तुम आप लोग आ जाओ फटाफट, लेट अस स्टार्ट। -1 diopter, -2 diopter, 180 degree, दिस इज विद द रूल एस्टिग्मेटिज्म। ठीक है, INICET मैराथन में ही पढ़ाया था। देखो ये वही वाली स्लाइड है, सेम स्लाइड ऑफ INICET मैराथन, मैंने मार्क किया हुआ, ये देखो। विद द रूल, माइनस एट 180 डिग्रीज विद द रूल। ठीक है, लेटा हुआ, लेटा हुआ माइनस आएगा, माइनस लेटा हुआ होता है ना, -180 पे आए तो विद द रूल मार्क करो, क्योंकि ऐसा ही होता है। ठीक है, करेक्ट। ट्राइप्लन ब्लू वाज देयर, यूज फॉर सर्जरी। यस, ट्राइप्लन ब्लू इज यूज फॉर सर्जरी, इंट्राऑकुलर सर्जरी में यूज करते हैं हम उसको, टू स्टेन द कैप्सूल। ठीक है, टू स्टेन द कैप्सूल। कॉर्निया में यूज कर सकते हैं टू स्टेन द एंडोथेलियम। ठीक है, एंडोथेलियम को स्टेन करने के लिए कर सकते हैं, उल्टा करके जब हम करते हैं ना पीलिंग, तब उसको स्टेन करने कर सकते हैं। ठीक है, यस डॉक्टर अंशु, बिल्कुल वी कैन यूज इट ड्यूरिंग कैटेट सर्जरी फॉर स्टेनिंग द कैप्सूल, कैप्सुलर एक्सेस के अंदर। एस्टिग्मेटिज्म वाला क्लियर है ये? ठीक है, विद द रूल, अगेंस्ट द रूल। सो दीज वर द 5 questions which are there. I think all the questions are quite easy. If you just applied your mind and you had paid attention during the class, all questions were easy. My favorite question, what do you call a bright student trying to become an ophthalmologist? ठीक है, गुड पीपल, है ना, ये मेरा फेवरेट क्वेश्चन है, ये मैं हमेशा पूछता हूँ। वेरी गुड, चलो डन डन डन। ठीक है, कुछ और कंफ्यूजन किसी और को? तो हफ्ता में कोई क्वेश्चन नहीं आया, बता दो भाई, कोई और आया हो? इस वाले की चॉइस मेरे को नहीं मिली है। ठीक है, चॉइस में एक के अंदर बस यहाँ पर यह है कि कोबाल्ट ब्लू, फ्लोरेसेंट स्टेन और इंटरस्टिशियल केराटिटिस, एक के अंदर 3 चीजें दी हैं, बाकियों के अंदर खाली 2। और रोडामिन स्टेन भी कुछ था क्या? रोडामिन भी आया था क्या? रोडामिन, रोडामिन भी कुछ आया था क्या? रोडामिन तो कहीं यूज नहीं होता। ठीक है, चलो गुड, थैंक यू विजन, थैंक यू विजन। हाँ, आप लोग कह रहे हो जल्दी जल्दी करने के लिए, मैच हमने भी देखना है यार, इंडिया जीतने वाली है, वैसे तो जीत ही गई है ऑलमोस्ट। मेडिसिन के लिए, हाँ डॉक्टर अंकित, मेडिसिन के लिए डॉक्टर दिलीप इज हियर। आई बिलीव आई कैन हैंड ओवर द माइक टू डॉक्टर दिलीप सर। डॉक्टर दिलीप सर, ऑल ओवर टू यू।
Yes, sir. Thank you so much.
थैंक यू, वेलकम वेलकम, थैंक्स अ लॉट। बाय बाय, बाय बाय एवरीवन। Stop share.
Hi, guys.
Wow, Dr. Dilip sir, you are looking handsome as always.
Sir, actually, I was traveling. I was driving on the way. I'm in a national highway. I just
Oh,
parked the car and I started.
Okay.
discussing.
I hope you are not stopped anywhere on national highways where you usually stop when we are traveling somewhere. Huh? You got
I understood.
Okay. All the best. Take care.
Thank you so much, sir. Thank you. Hey guys, sorry. Actually, I was traveling, so I couldn't compile much of a question, but still I did compile some questions on the way. So let me share those with it. I think there are tons of medicine questions. I think like 40, 45 questions were of medicine, to be honest. And most of the questions, honestly speaking, are something that we have discussed a lot of times. In fact, a lot of times. So probably if you have revised well, probably you could have answered almost all the questions very good, very well. So let me just share the screen right now. Just hold on. Yeah, are you able to see and hear me? Just having a look at it. I don't know whether my network is good or not. Anyways, no worries. Anyway, I'm going to do a detailed discussion later on. But as of now, okay, fine. So I'm looking at your comments. Okay, fine. So let us go on with that. So first, I think this is a very easy question. I think people who attended my classes must be able to tell this very easily. Drug that is used in diabetic patients, which are also used to treat heart failure. Very, very simple one. So this is basically a kind of so that's the right answer for this question. Easy one. So next 10-year-old boy with complaints of palpitation with ECG showing coving pattern. We have discussed tons of times. Answer is Brugada syndrome for this. So whenever you see ST elevation V1, V2, and you have a code pattern with TVA inversion in V1, V2, this is basically kind of Brugada syndrome, right? So then we have a patient who's a diabetic male, chest pain, palpitation, reaches hospital. ECG is kind of normal, no ST segment elevation. Again, we have discussed tons of times. Answer is likely to be aspirin, clopidogrel along with enoxaparin, typically low molecular weight heparin. Then coming to the next one. So most common cause of hypercalcemia in a hospitalized individual. So I told you there are only two important reasons for hypercalcemia. One is going to be either parathyroid adenoma or it's going to be a malignancy. So in a hospitalized individual, it's very likely to be due to malignancy. So parathyroid adenoma patients usually come like maybe in a non-hospitalized situation. So in hospitalized situation, most often it's very likely to be a malignancy. So tyrosine kinase inhibitor that is used in ITP. So typically either if the option is rilzabrutinib, that will be the answer. Or some people say it's kind of fostamatinib. So if fostamatinib is given, even that is going to be an answer, nevertheless. So next question, electrophoretic fraction, electrophoretic abnormality in nephrotic syndrome. I think they have given a image-based question, so easy one. So here is another question, 40-year-old woman presenting bilateral symmetric tender joints of hands and ankle, early morning stiffness, no erythema or redness. So what is the likely diagnosis? So, remember this is a symmetric tender arthritis, and patient is having morning stiffness, so it's very likely to be an inflammatory arthritis. So hands, ankle, everything is involved, so it's very likely to be inflammatory arthritis like psoriatic arthritis. Yeah. So 26-year-old presents with palpitation, weight loss, tremors, and diarrhea. So which of the following is better to establish the diagnosis? So there are some students who say that T3 has been given. So if T3 is given, that will be the right answer, because T3 is the one that's surely going to establish the diagnosis of thyrotoxicosis. In fact, TSH is not reliable in central case of hyperthyroidism, and TPO antibodies are also completely not reliable. Ultrasound is not at all important in such a situation. If T3 was given, T3 is going to be the right answer. So if T3 was not given, then TSH may be the right answer. Investigation of choice for localization of parathyroid adenoma. Repeat question, I believe. We've discussed a lot of times. Answer is going to be technetium 9M sestamib scan. The right answer is sestamib. So that will be the right answer. Then if you look at the next question, a 40-year-old with complaints of abdominal pain, cramps, endoscopy is diagnosed as ulcerative colitis. I think he had around 3 episodes of bloody stools per day. Treatment will be with sulfasalazine. treatment will be with sulfasalazine. So they're saying like 3 episodes, right? So according to True Love and Wits criteria, less than 4 episodes is basically mild. Whenever they say mention 3 episodes, so less than 3 episodes is going to come under mild ulcerative colitis. If it's a mild ulcerative colitis, then 5 ACE derivatives are going to be more than enough. So very likely it's going to be sulfasalazine. So serology pattern, surface antigen, anti-HBS, HBAG all negative, anti-HBC alone is positive. So this goes towards window period, right? We have discussed so many times. So if it's an acute hepatitis B infection, surface antigen should have been positive. If it's cured infection, then anti-HBS would have been positive. So only in the window period, anti-HBC IgM alone will be positive. All the other serological markers are going to be negative. So the right answer for that is window period. So there was a question of Hertel's exophthalmometer, I think. It is used to measure exophthalmos, that is proptosis, simple. So this is a Poisson and matching site, quite simple, not a big deal at all. Metabolic syndrome will not include what? LDL. Okay. So if LDL was given, that is the right answer, because metabolic syndrome includes, even in the marathon session, we have discussed that metabolic syndrome includes waist circumference, metabolic syndrome includes blood glucose, it includes HDL, it includes blood pressure also, but LDL is not going to be included in metabolic syndrome. So case of DK with pH 7.2, blood glucose 300, ketones positive. So this is actually a case of DK, as everyone knows. So what is the management? Management is always fluids followed by insulin. People say that, I mean, many people are telling that already fluids have been started. But still, what's wrong in that? You're going to continue fluids for the first 1 hour. This is something that we have discussed so many times and again. First, always fluid. In the first 1 hour, it's almost fluids and fluids. Oh, hip circumference was given. So in that case, that will be the answer. So HDL was given. Then that will be the right choice. So it's not the right answer. So if circumference was given, that will be the right answer. Yeah, okay. If hip circumference was given, that will be the right answer. All right. So whenever there is a case of DK, so you are going to always start with fluids and then you go for insulin. So you're going to give fluids for first 1 hour and then like you go for insulin. So that's the usual therapy. So not the other way around. So that is something that we discussed so many times. So case of pH 7.3, carbon dioxide 58, bicarbonate 25. So this is a case of respiratory acidosis. We know that your pH is suggestive of acidosis. Carbon dioxide is high. Bicarbonate is kind of relatively normal. So this is very likely to be a case of acute respiratory acidosis. So 18th question, post-adrenalectomy, patients developed hyperpigmentation of fingers. I think they have given a case of hyperaldosteronism for which they did bilateral adrenalectomy. So I think the question was post-bilateral adrenalectomy and patient developed hyperpigmentation of fingers. Answer is likely to be Nelson syndrome. I think Rahul Ratan. Yeah, thank you so much for your comment, Rahul Ratan. Yeah, I know that I've been traveling so far, so I'm not able to collect questions. So what you have said is correct, Rahul. Thank you so much. Okay, so next you have something called as 19th question, that is rheumatoid arthritis patient on steroids. So stop taking steroids, developed hypotension, hyperkalemia, and hyponatremia. I think management is IV fluids with hydrocortisone. So the better management will be hydrocortisone, but immediate management will be IV fluids. Sheehan syndrome was also an option. No, it's not Sheehan syndrome. Sheehan syndrome is very likely to be postpartum pituitary necrosis, right? So it's not likely to be Sheehan syndrome. Okay. So this is a case of Addisonian crisis. If it's going to be Addisonian crisis, so what do you think will be the best management? IV fluids and hydrocortisone. If they ask you the next management, it's going to be IV fluids. If they ask you the best management, it's going to be hydrocortisone. Right? Okay. All right. So I'm not very sure about what exactly the statement was, but I know that it's a picture of Addisonian crisis. So it's basically IV fluids plus corticosteroids, hydrocortisone. Somebody is asking about first question to be clarified, gliptin or gliflozin. Life-saving management. Life-saving management is hydrocortisone. No doubt. That's the best one. Life saving is equal to best treatment. So that must be hydrocortisone. IV fluids is only temporary. So it's for stabilization of the patient, but the best is going to be hydrocortisone. There's no doubt. This is something that we have discussed so many times, right? So somebody is asking about question number 1, whether it's gliptin or gliflozin. Oh, sorry. It's not gliptin, it's empagliflozin, SGLT2 inhibitors. So we know in heart failure patients, what you can use is SGLT2 inhibitors. That's empagliflozin. Sorry. Yeah. Then true about organisms and intrinsic resistance. This is a repeat question, I believe. So this is Cruzy and Glabrata. There are two things, right? Cruzy and Glabrata don't respond to fluconazole. They have intrinsic resistance to fluconazole. It's a straight line from Harrison. IV fluids was not there in the option. So fine, then you can ignore. There's no IV fluids. Thank you so much. Gliflozins can be given in high creatinine also. Yes, it can be given. High creatinine is not a problem for gliflozin, but you have to calculate EGFR. EGFR less than 30 is a contraindication for dapagliflozin, and EGFR less than 20 is a contraindication for empagliflozin. Yeah, this is Canada Cruzy. That's correct. So then we have post-COVID patient developing nasal discharge, fungal stain showed aseptate IFA. It's a very simple one. It's mucor, right? Answer is likely to be mucor. Yeah, I know that. So in this question, they have mentioned hyperkalemia also. They have mentioned hyperkalemia and hyponatremia also. And the BP was also low. So basically, like, this is the Addisonian crisis. No doubt about that. And I think we have got like few more questions as well. There are so many questions. I couldn't collect it. I just collected from whatever students commented in the Cerebellum group. I think there was a question on visual agnosia also. I think there was a question on associative visual agnosia. Associative visual agnosia. I think so. There was a question on that. So that location is actually inferior temporal lobe. If that was given, that is the right answer. Inferior part of the temporal lobe. Associative visual agnosia, where patients can identify what object it is, but their color, texture and all, they will not be able to identify. So, but they can say what object it is, basically, by looking at it. So that is inferior temporal lobe. So basically, it's a problem of occipitotemporal pathway. Because occipitotemporal pathway is affected, so these patients develop associative visual agnosia. So technically, it is a problem of occipitotemporal pathway, the best answer will be that inferior temporal lobe. That will be the best answer. Yeah, that's correct. There was another question also. I think, again, from heart failure, I guess. Again, from heart failure, I think they asked which drug reduces remodeling. There was a confusion between okay, somebody is telling can recognize color, but patient was not able to tell. Can't recognize objects. Okay. So then you're talking about, okay. Then you're talking about occipitoparital pathway. So I'll confirm with the students anyway. So they are not able to recognize object, but they're able to recognize the color, texture and all. Okay. Okay. Then it must be like occipitoparital pathway. It's not occipitotemporal. So then in that case, it will be parietal. That's correct. That's correct. So nevertheless, so we have another case of heart failure, I think. Which drug reduces mortality? Which drug reduces mortality? Which drug reduces mortality? Yeah, they have given carvedilol as well. And they have given captopril as well. So people who have attended my classes must be able to say. I told you the first line drug in any heart failure and reduced ejection fraction. If you talk about HFrEF, what is the first line drug? It's always captopril, no doubt. Always captopril. See, even though we give carvedilol, beta blocker, ACE inhibitor, RNEs, we can give MRS. First line is always RNAs or basically AS inhibitors or ARBs. It's not going to be like carvedilol. Yeah, digoxin is also not going to be the right answer. Digoxin never decreases mortality. It has neutral mortality. I think there was a case of ascites. They asked like which diuretic mobilizes edema fluid. There is a case like that, right? Which drug mobilizes edema fluid? I think it's MRS, eplerenone. That must be the right answer because MRS, the spironolactone and eplerenone are more important diuretics in the setting of cirrhosis and ascites. So more than furosemide. Okay. So that was one question. And there was another question on TB meningitis, I guess. I don't know whether it's covered in micro or not, but there was a question on TB meningitis where the glucose was low. The glucose was low, protein was high, and it's predominantly lymphocytic. Okay, cool. Covered. Okay. Lymphocytic CSF. Okay, all right. So that is a TB meningitis. That's correct. So it's very likely to be a TB meningitis. So what about the indication of dialysis? Which question you encountered? Because I've never encountered a question on indication of dialysis. So what question basically? What question on indication of dialysis? I don't understand. What is the question on indication of dialysis? Okay. All right. Then I think there was a question on Mobitz type 2 block. I'm not very sure what ECG was asked, but I believe a Mobitz type 2 block was asked. Okay, so hyperkalemia is an indication for dialysis. Okay, fine. Yes, we know whenever you talk about indication of dialysis, indication of renal replacement therapy, we have a mnemonic, right? AIOU. AIOU. That is acidosis, electrolyte imbalance, that is hyperkalemia. Then we have intoxications with dialysable drugs. Then we have volume overload state. And we have uremic symptoms. Yeah, so hyperkalemia, that's an indication for dialysis. Especially if it's a refractory hyperkalemia, there is a indication for dialysis. Yes, Mobitz type 2 block was asked, I guess. And there was a question on acromegaly also. Do you know that? So there was a picture, acromegaly image was given. Yeah, Mobitz type 2 block, and I think we have acromegaly image. So one image that was given on acromegaly, as far as I know. Yeah, so it was there then. Yes. And I think there was another question on sarcoidosis also. Sarcoidosis as well. So there was a sarcoidosis question also. I think the question was based on hilar lymphadenopathy. A patient had weight loss and patient had increased serum angiotensin converting enzyme levels. I think there was a question on sarcoidosis also. Yeah, DK management we discussed already, but there was a question on sarcoidosis, right? That's what students were telling. I didn't see the discussion in the group properly. Sorry for that, because I was continuously driving for the last 6 hours. Oh, is it a casseting granuloma? No, casseting granuloma is for TB, right? It must be a non-casseting granuloma. So I think they have given a clinical history. Clinical history, what they have given is a case who had weight loss, who had elevated serum angiotensin converting enzyme levels, and who had bilateral hilar lymphadenopathy. So it must be a sarcoidosis. Based on the clinical picture itself, it must be sarcoidosis. Okay. Anyone knows there was a case on PFT? There was a question on PFT, I guess. I don't know what question on PFT. I don't know. There was a question on PFT, I suppose. FE1 by FEC is 50%. Then it must be bronchiectasis because it's an obstructive lung disease. So if you feel that FE1 by FEC is less than 70%, FE1 by FEC was less than 70%, that's equal to obstructive lung disease. Obstructive lung disease, it must be bronchiectasis because bronchiectasis is basically an obstructive lung disease. It must be bronchiectasis. ILD cannot produce an FE1 by FEC of less than 70%. Sarcoidosis is also an ILD. It cannot produce an FE1 by FEC of less than 70%. And the neuromuscular defect is also restricted lung disease. It cannot also produce an FE1 by FEC less than 70%. Impossible. Okay, it must be a bronchiectasis then. Okay. What else? I think there was a case of iron deficiency anemia also. The patient had a low transferrin saturation. So low transferrin saturation, which is basically iron deficiency anemia. Iron deficiency anemia. And there was also a case of scrub typhus, which is equal to always doxy. Scrub typhus means doxy, as simple as that. So these are some things that, I mean, I think like most of the questions were, I mean, I felt like medicine questions were very simple. There is not a big deal at all in medicine questions. Yeah, low transferrin saturation, that's iron deficiency anemia, that's correct. Scrub typhus is always doxy. I mean, first line, best treatment, everything is doxycycline. Unless and until maybe the patient is a pregnant woman or probably child, then probably I can deal with azithromycin. Otherwise, unless until the patient is a pregnant woman or a child, I'm going to stick on a doxycycline, nothing more. Doxy plus azithro. Show me one guideline that shows doxy plus azithro. Lung pathology. If it's a lung pathology, you're going to give azithro. Scrub typhus itself can cause pulmonary infiltrate. Still, the treatment is doxy. Ceftriaxone plus doxy. My God. No, definitely not. Remember, rickettsial organisms are atypical organisms. Beta-lactams won't be effective for rickettsial organisms. Lung infiltrates can occur in scrub typhus itself. It can occur in leptospirosis also. So that doesn't mean anything. There's an additional pneumonia. Still, the answer will be doxycycline. No. Definitely not ceftriaxone plus doxy. It's only doxy. There's no doubt. No ceftriaxone plus doxy, no azithromycin plus doxy. It's only doxy. Only doxy. Azithro is an alternative only in pregnant women and in children. Otherwise, it's doxy. As simple as that. Okay. Anything else? Don't worry about it. I know that I couldn't collect the questions because really I was traveling. So right now, even I'm now in National Highway, I park somewhere near a hotel and I'm doing with my hotspot. So really sorry for that. And hopefully I'll be compiling more and more questions and I'll be coming back to you one more time with authentic questions and answers very soon. Okay, they've asked about the CURB 65 score calculation management of pneumonia. That must be quite simple and straightforward. Yeah, I think there was a question on glomerulonephritis also. That's correct. They asked about crescentic glomerulonephritis and they asked about what to do next. I think that is ANCA. So there was a question on that. ANCA has to be done. RPGN. So it's a pause immune, right? Pause immune means obviously it must be ANCA. Without a doubt. Okay, fine. So I know there has been like plenty of questions, plenty of questions from medicine. I'm going to compile everything and I'm going to get back to you soon. So this is the maximum I can do as of now, the limited time. But nevertheless, don't worry. I'm going to come back to you and we're going to discuss more and more questions. Thank you very much for patient listening. I think next.
So Dr. Apu sir will join.
Yeah, I think Apu sir is already there.
Yeah.
Yeah, I'll stop the screen sharing.
Thank you, Dilip sir.
Thank you so much. Thank you so much, sir. Sorry, sir, I was traveling. That's why I couldn't.
Yes, sir, same is with me. Apologies to students. Even I couldn't join the session today, but I wanted to come and meet and greet the students. I'm sure they must have done exceptionally well in the exam. They have been working hard since such a long time. I'm sure they must have entered the examination hall with a high degree of confidence.
Yes, sir. Yes, sir. Definitely, sir.
And I was just listening to you as well, sir. It's really amazing.
Thank you so much, sir. Thank you, sir. Actually, I was parking my car near the national highway, sir, near a dhaba, and I was just continuing with the discussion in the hotspot because I couldn't reach Chennai on time. So there was a lot of traffic in the place where I went. That's why, sir.
Then it's the same thing with me. Somehow I was not able to get an internet connection for this. So I was just waiting.
Oh my God. Oh my God. No problem, sir.
I think Kapoor sir must also is just about to join. Meanwhile, friends, thank you so much. I'm sure you must have enjoyed today's extensive session with all the faculty of Cerebellum Academy. All the team at the back end also, Shubham, Mukta, Priya. Thank you so much, friends, for being a part of this session. As Dr. Kapoor sir is joining, we can all wish all the students that they definitely get the result of their what they want. I just want them to succeed. I just want them to be satisfied once they come out of the examination hall. And finally, Apurv sir is here. Hello, Apurv sir.
Vivek sir, how are you?
Absolutely fine, sir. Absolutely fine.
Thank you very much for joining on special request.
Thank you so much.
Without your blessings, the session could not be completed.
Thank you so much, sir. And I'm sure students must have done exceptionally well today. And thanks to all the cerebellum educators as well, sir, who have devoted this time to sort out all the questions in such a short span of time and try to be as close to the students as possible in this time. I'm sure students must have enjoyed today's session.
Sir, also Vivek sir, I remember when we used to write exams, we were lost ki aaj kya karna hai. I think this is one of the time when they can just look at how they have done. And we are certain that this is not the last exam, because now this is the first exam, in fact, in the course of preparation. So this is an assessment. I hope it's your last exam. I just wish that you get the seat that you all want to have. But also, it's a time that you can assess whatever has been discussed by the teachers, the pearls. When we started at 4 p.m., we told you that most of the things have come from the expected norms this time. And it has happened in most of the subjects. It's a classical paper. It's not very skewed out. It's in the center zone that you need to prepare for. And I wish that you get a seat that you wish for, but then get up, take a break. It is a festive season. You can enjoy Diwali. You can probably focus on other days after taking a break. What do you say, sir? What should be their plan for tomorrow, Vivek, sir?
Sir, absolutely. Time has to be spent with family and friends first.
Right, okay.
And then they can come back. What do you say, Dilip, sir?
Definitely, sir. Actually, I really believe that our students must have definitely performed very well, because as Apur sir said, like most of the questions were from expected domains only. And in fact, I believe, like, I don't know about other subjects, but medicine wise, the questions were just from the expected domains, and they were very simple also. Even though there were clinical scenarios, but the questions actually were very simple and they're from expected domains. So that's what I've been telling. Even from the marathon session that we have done, the previous, like last 1 week, there have been like 25-30 questions easily from medicine. So even from the revision session, so we have discussed everything almost. So maybe students who have not very happy with what they have done, maybe their revision is the one that might be lacking. That's also what they have to concentrate is mostly on the revision again and again. So maybe that they can do once the Diwali is over.
And those who were so serious in preparing, just to update them that India has won the match, India versus South Africa. Kohli has got his 49th century, and we are 8 on 8. And I just wish that the way India has performed today, all of you have done in the exam. And now let's listen from the universe boss. He has been there to guide us and sail us through. Dr. Praveen, sir.
Yes, sir. Good evening, sir. Good evening, Dilip sir. Good evening, Vivek sir. So, I mean, we all know Dilip sir is such a phenomenal teacher, and we have been listening from students that how nicely is he teaching. But sir, I have one difference from you. We do not have time to wait till Diwali, sir. I think Diwali is on 12th, if I'm not wrong. You know?
Yes, next Sunday.
Next Sunday. So I think we can take a break of a day or two. And students, all of you who are watching, see, this has been the pattern. The INICET exam and the AIMS exam is usually an eye-opener, right? I mean, all of us say nice things that, take rest and all of that. That is fine. But as they say in English, now that the shit just got real. After the exam is over, now it's a very important phase of preparation. What you do from here is going to have a huge impact on the rank that you are going to get in the NEET examination. So today, I believe maybe 2 or 3% students would go to their bed happily after performing well in the exams, and 97 to 98% would go to bed with a heavy heart that the exam did not go as well as they wanted it to be. Out of those 97-98%, around 5-7% would again be very happy on the day of NEET exam. So you have to ensure that you come in those 7 or 8% students. And now is the time that we have to study very hard. We have to study very hard. We have to follow a structure. We have to ensure that we complete subjects in time. We have to ensure that our concepts are good. We have to ensure that our hold on PYQs is good. And for those of you who are Cerebellum students, we will be taking a break of 7-8 days, primarily for teachers. And from 15th of November, we are again starting. I think it's 14th of November. We are starting with the revision series for NEET PG examination, right? In Cerebellum Academy, we had promised one thing when you guys joined us, that we'll be working with you till the last day. And this is what we did for the INICET examination. And the same is going to happen for a NEET PG examination. So in 7 to 8 days, we'll be starting with our revision lectures. Again, it's a whole program. The lectures would be taken. The PYQs would be completed. Then the test would be taken. And this time we have also integrated all the BTR sessions by Zaina ma'am along with the main schedule, so there is no confusion. So if you are angry with yourself today, if you are unsatisfied today, if you have a heavy heart today, take action today, right? When you are a bit unhappy with yourself, that is the time to take action. And you have to decide that you have to do good. And if you have decided that you want to do good, then it's the time to take an action. So I'm sure I'm being a bit contrarian here. Everybody must be telling you to relax and enjoy, but you can't relax or enjoy. You just have got 3 or 3.5 months. So at max a day or two, and then you have to be back on your study tables, right? So
विवेक सर ने यूनिवर्स बस हाफ डे दिया था, मैंने 2 घंटे दिए थे, तुमने 2 दिन दे दिए एंजॉयमेंट के लिए. You are the most lenient here. You are the most lenient here.
ठीक है, तो बस आज रात आराम से एंजॉय कर लीजिए, सो लीजिए, और कल से फिर से पढ़ाई शुरू करिए प्लीज. और बहुत इंपॉर्टेंट है, अगले जो 3 महीने बचे हैं, दे आर गोइंग टू बी they'll make or break your rank in the examination. So see you guys in the app from 14th of November. And I'm hoping that most of the students who are watching us are our students. If you're not, please join Mission NEET PG. And the program of Mission NEET PG would continue till the last day, till the day before the examination. And see you in the app.
Also, we are very happy that our notes and the lectures that teachers have taken, especially the revision sessions, the marathon sessions, they have actually converted into images and questions today.
Right.
And one more thing I remember, it always used to be exam around Diwali. So my grandmother, who was a teacher, she used to tell, पूरे हफ्ते पढ़ो, दिवाली के दिन एंजॉय करना.
हाँ, दिवाली
फिर दिवाली की एक रात पहले कहती थी, देखो सुबह तो दिवाली में कुछ होता नहीं है, आधा दिन पढ़ लो, दिवाली की पूजा के बाद एंजॉय करना. So that is how a doctor has to always learn. This is what is the motto. एक और बात है, she always used to say, एक दिवाली sacrifice करोगे, जिंदगी पूरी दिवाली की तरह चमकेगी.
Correct.
So this is the time which comes at a very young age, but if you value it, trust me, you will live very well. This is what I wish to say. And I think that is what I want to say. I'm signing off. And
I think so,
Dr.
Dr.
Vivek
Dilip is
sir,
on
Praveen-
screen. Dr. Dilip is on screen. So I want to make a special point about the medicine part of Cerebellum Academy and also surgery. That the kind of efforts Dr. Dilip and Dr. Amit have been putting, they are like phenomenal. And the kind of lectures and the recorded lectures and the live lectures that have come out from medicine and surgery, they are, I mean, on another level. So medicine and surgery are two of the biggest subjects. They a lot of questions come from them, but somehow Dilip sir and Amrit sir have managed to cover them in a period of time that is not too high, not too less, covers everything despite and still gives the students time for revision. So medicine surgery, Dr. Dilip and Dr. Amrit have done a phenomenal job, and it's very important that students follow these lectures properly.
I agree. So now all my three seniors are there on the screen. Praveen sir, Dilip sir, and Vivek sir. But out of us, the senior most is Vivek sir. I will request Vivek sir to conclude the session with your words, sir. Over to you, Vivek sir.
Thank you so much, Dilip sir, Apurv sir, Praveen sir, all the team, Shubham, Mukta, Priya, and all the Cerebellum team at the background. Students, as Dr. Praveen sir has summarized it very well, take a very short break, come back. This is the time, make or break time. And at Cerebellum Academy, we'll make sure 100% from our side that you achieve your potential. It's just you have to just come and align with us, or rather we'll come and align with you. So just stay on course, and definitely we'll reach the potential that you want to achieve, and we'll make sure you achieve it. Thank you so much.
Thank you very much, sir.
Bye-bye.
Thank you very much. और राजकुमार, तुम गुस्सा मत होना, तुम्हारा नाम भी ऐड कर दिया हमने. Bye bye. Good night.
Thank you, Rajkumar. Thank you, Rajkumar, so much.
Bye bye. Good night. Bye, sir. Tata.
Bye bye.